Our first main agenda is Keynote Lecture 2, Precision Stem Cell Therapy in Post-Pandemic Era, Safety and Efficacy of Placental-Derived Mesenchymal Stem Cells on COVID-19 Associated Acute Respiratory Distress Syndrome. This session will be moderated by Professor Dr. Shana Adiwinata Pawitan, MS PhD. Prof. Shana has finished her study as medical doctor in Universitas Indonesia, and then she continued her magister program in medical biology in Universitas Indonesia. She achieved her PhD in pharmaceutical science at Osaka University in 1990. Now, she is actively working as a professor in Histology Department, Faculty of Medicine, Universitas Indonesia, laboratory manager at Stem Cell and Tissue Engineering Research Center IMERI FKUI, and the head of Quality Control Integrated Medical Technology Service of Stem Cell, Cipto Mangunkusumo Hospital and Faculty of Medicine, Universitas Indonesia. Ladies and gentlemen, please welcome Professor Dr. Shana. Prof. Shana, the time is yours.
Thank you. Good morning, dear professors, our distinguished guests, Professor Rita Yen Hua Huang, dear colleagues, ladies and gentlemen. On this occasion, I would like to introduce our distinguished guest, Professor Rita Yen Hua Huang from Taipei Medical University, Taiwan. Prof. Rita graduated from the National Taiwan University for her bachelor, magister, and PhD. She has done her postdoc twice in Academia Sinica Taipei, Taiwan, and she got visiting scholarship from St. Louis University, USA. She is currently the Distinguished Professor and Dean of the Office Research and Development of Taipei Medical University and the Director of the Research Center of Cell Therapy and Regeneration Medicine, and also CED of the Research Center for Precision Health at TMU. She owns 2 stem cell patents and has published many papers in high-impact top-ranking journal, and also she has many awards. Prof. Rita, the time is yours.
Yeah, thank you very much for Professor Jenny's so nice introduction. Thank you for the committee to invite me, and for the conference chair, Dr. Mila, my good friends, Dr. Jenny, and all the members of the symposium, and ladies and gentlemen. So thank you very much for invitation. So my great honor and the pleasure to attend today's fantastic meeting. So I have already provided video. So maybe can help me to play the video to begin my talk. Thank you very much for the invitation from the organization committee. So it is my great honor and the pleasure to have this opportunity to attend this fantastic meeting. Today my topic will be the precision stem cell therapy in post-pandemic era. I will focus on the safety and the efficacy of a placenta-derived MSCs with so-called PCMSC on COVID-19 associated ARDS. I am Rita Yen Hua Huang from Taipei Medical University, Taipei, Taiwan. I would like to thank Professor Jenny's invitation. My good friends in Indonesia. So this year we have a very wonderful cooperation, a review article published on International Journal of Molecular Sciences. We discuss about the cell and the gene therapy on anemia, in particular for hematopoietic stem cells and the gene editing. So you can see here the first author and the second author, Dito and the Nova, all from the Indonesia. And right now, they are the PhD students for TMU IPCTRM. There's an international PhD program for cell therapy and regeneration medicine. So I'm very happy to share with you the future cooperation possibility, and really happy to have the further opportunity can work together. Thank you, Professor Jenny. So going to align the symposium ethics. So today I will talking about the stem cell therapy that during the COVID-19 pandemic situation. So this is the global COVID-19 pandemic map. So as you can see, so far we already have 250 million people just infected by COVID-19. So there are 5 million people, they died. So even though we just tried to get more vaccines for the first shot or the second shot of vaccination, but the virus variant is still a big challenge globally. So the COVID-19 pandemic situation, the virus also the high priority to attack the aged people. So global aging and the COVID-19 during the pandemic situation has been the daily routine for our next generation. So in Asia is the area for the high age population we have. So here is the reports this year for June. There has been more than 100 countries be infected by Delta variant COVID-19 virus. So as you can see on the slides, even though the country, for example, United Kingdom, United States, or it's Eraser, so they already received more than 2 shots of vaccines, but they still cannot defend the Delta variant virus attack. So the WHO data just show the challenge of our current life. So when we're talking about the vaccination, the vaccine or traditional medicine, so why it's really limited the poor response for our aged people. So as you can see on the slide, so all the traditional medicine or vaccine, they can work very well for young people. But for the aged population, so there is a lot of ARDS and ER's trace, so the poor mitochondrial activity or dysfunction of a protein quality for control system, DNA damages. So it's no wonder when we receive the vaccine or receive the classical medicine treatment, the aged people generally did not respond very well. So it causes the limitation for traditional medical therapy. So it also raises the possibility and the opportunity for regenerative medicine, in particular for stem cells. Here I just show you last year the market analyzed for the COVID-19 treatment. So there are 3 categories, including vaccines, stem cells, and the antibodies. So if we look at the Asia and the Europe and the America, you can see all the global, they need a vaccine as all the first priority. But in terms of the second priority, there is some differences. For Asia, the second priority will be the stem cells. But for the Europe, it's not. For America, it's really similar to the third priority, stem cell and the antibody. So you will know the stem cell use in our Asia country is very priority and popular. So why? So maybe 2 reasons. One reason is the COVID-19 raised from China. So in the beginning, there is no vaccines. So the stem cell therapy can be applied to the acute ARDS and for the treatment. And the second is the aging issues. So the Asia country right now is the highest age population distribution. So it's also open the window for stem cell therapy, the current needs for next generation medical care. So due to the reason, you can see the 2020 regenerative medicine market. So if we analyze the growth rate by region, the green color indicated the high, and the yellow color just show the median, and the red color present the low. So very clearly, so Asia is the all green area. That means the Asia area is the highest growth rate, for the top one. So the reason for the Asia to be the highest, the high population and the high growth rate, the reason is maybe due to the aging. So aging will be the key driver. So when we compare to the next 40 years to 2060, so you can see the color to represent the age distribution. So our Asia country and some of the Europe country, so they will enter a super high age population. So it will lead to the change of our government policy to take care about the aging population. So it's no wonder. So in Asia, the stem cell market, the regenerative medicine has been to be the top priority and the high growth rate. So if we look at the COVID-19 cell therapy, so according to 2020, the market analysis, so there is a 73% belong to the allogeneic stem cell therapy, and only 27% just belong to autologous. This is because the COVID-19 ARDS is really emergency and progress very fast. So only allogeneic stem cell can fulfill and help to support the ARDS treatment. If we analyze all the allogeneic stem cell therapy, you can see most of them belong to mesenchymal stem cells. So more than 50%. So it's due to the high immune modulation and allogeneic MSC cell bank layer. So it's provide very, very easy and usable and ready to use cell source, in particular for stem cell source for the urgent ARDS treatment. So here is the MSC mechanism, why they can be popular use for COVID-19 disease. So one reason will be immune modulation. So MSC has been well known to modulate the immune, in particular for inflammation, to reduce the T lymphocyte activation, to reduce the macrophage infiltration and the microglia activation. And very importantly, for this COVID-19 infection, not only immune response, but also neuron damage. So MSC can stimulate the neurogenesis, also prevent the neural cell apoptosis. And in addition, they can secrete the trophic factors to induce angiogenesis or neuron regeneration. So all the data just show very, very useful information for the MSC for COVID-19 disease on immune, neuron, and the cardiovascular disease repair. So this year we have a review article published on Journal of Biomedical Sciences, and we're talking about the global MSC based therapy. We discuss about the mechanism, systemic safety, and the biodistribution for the next precision clinical applications. As you can see from this slide, so there has been around 650 clinical trials globally. So you can see very clearly the MSC tissue origin diversity is very clear. So according to the analysis from bone marrow is the top one cell tissue source, and the second will move to the adipose tissues, and then will be the umbilical and the cord blood and water jelly, dental pulp, placenta, and the others. So if we look at the 2020 post-COVID stem cell clinical trial, so the top three just belong to osteoarthritis and COVID-19 related pneumonia and the ARDS, or ischemic heart disease. So the first one will belong to the age-related disease. And then the following, the second and the third has been the COVID-19 infected induced disease, in particular for ARDS. So you can see for globally, if we look at the cell type, so the market analyzed 2019, they discuss about the current market distribution to the next 10 years to 2027. So you can see very popular adult stem cells always occupy the major markets. So in 2019, the adult stem cell, they occupied around 56%, and then moving to iPS, and then moving to embryonic stem cell. For the next 10 years to 2027, so you can see the adult stem cells, they increase the occupation up to 65%. And the second one still be the iPS is because the drug screening or the potential for clinical trial, and the embryonic stem cell market has been decreased. So during the adult stem cells, for the allogeneic mesenchymal stem cells is the major population. It's due to the COVID-19 infection and the aging population. So if we want to know whether this market or whether the mesenchymal stem cells allogenetics is really essential for the current need, we can learn from the global regeneration medicine financing. So if the market, if the company, they would put money in this field, and then you will know it is needed by the people. So if we compare to the 2020, in 2020, so the whole year, the financing for the global regeneration medicine has been reached around $20 billion. So I remember for 2020, so the market analysts just show, wow, this is the best year. But if you look at this year, so in the 2021, only the beginning, the 6 months, and we can know, so there has been reached $14 billion. So you can see very, very popular data to show. So this is a very promising and really a strong hope for the current regeneration medicine in market. So if we continue to look at the global regeneration medicine company, you can see the Asia company just go to really rapid growth. So as I show here, so for the last year, there was around 1,000 companies globally. So the major population, the major distribution is the North America. So the North America, just these markets. But when we compare to this year for 2021, so currently there has been 1,195 companies. So you can see the increase a company just locate where, so locate Asia. You can see this year the Asia we only have 200 companies, but this year it has been increased to 361. So you can see the Asia company just grows really rapidly. So when we think about the treatment, so we have a bit well educated for the traditional personalized medicine and the precision medicine. So we know for traditional medicine, maybe one drug to provide everyone, but someone maybe will benefit from a drug, but someone no benefit, and some others maybe have AE. So we move to maybe we need to group the patients, so by disease or by risk or by others. But right now we have been moved to the precision medicine. So our individual patient information, including the genomics, omics, lifestyle, reference, or some of the medical record or exogenous factors will be considered. So we will have our personalized data file precision design to super match, in particular for AI. So specific drug for specific individual patients. So we so-called precision medicine. But if we look at about the cell therapy, I'm so sorry, the cell therapy is still in the early stage. So if we look at the cell therapy, so far we only one cell for all the people. So we don't know what exactly the cell source, the differences, the backgrounds, the genetics, epigenetics, or others, proteomics. And we also don't know how to fit our patients. So I would like to talk about the precision stem cell therapy. In particular, we focus on the MSC and the patient condition. I would like to take a picture to share this idea. So if we're talking about our cell therapy, we will have an in vitro expanded MSC cells, and we will go try to apply these MSC cells to our patients. So it will have many factors we need to consider about. For example, if we're talking about the MSC, so we will know the MSC came from different tissue resources. So from bone marrow, adipose, as I just mentioned just now. So we will have a diversity of MSC from tissue origin. And then how you purify the MSC, you will get different MSC population. So you just extract it, or you just put the hypoxia condition, or you just how to identify. So how you pre-treat the MSC, you will growth factor supplement in your culture medium, or your oxygen tensions, or others. And so if we have this MSC, and then what is the next condition for your patient condition? Whether your patient, what is their immune status? And how about if the patient is still concurrent use some immunosuppression therapy? Or what time you can use the MSC for administration? And how you just give the MSC by IV or by IM. And what is their patient, they can tolerate your MSC dose. So what will be the maximum dose for your patient they can tolerate? So you can see from the cell source and to the patient, there is a lot of factors we need to consider about. But currently, our information is really limited. So continue, we will know the MSC diversity has been well documented. So as you can see, 2018, the Nature paper just published editorial comments. They just highlight we need to clean up the stem cell mass. It's talking about the diversity for MSC. The clinical trial of MSC failed to deliver. So we will know the tissue origin and the cell processing will be the key to generate the different MSC. So as I show here, so the MSC cells can from different tissues, and the processing is the products. So different processing will generate different MSC products. So what exactly the MSC different phenotype to fulfill with different patient needs is very critical for next generation for MSC stem cell therapy. So this is the paper published on stem cells. They're talking about what exactly the MSC function. Yeah, the MSC came from the different tissues, as I mentioned before. So they will have the ability to different cell differentiation, including osteogenesis, adipogenesis, and the chondrogenesis. In addition to these three lineage, also have other lineage differentiation has been reported. And the MSC also can secrete some cytokines, growth factors to modulate the immune modulation. And also currently a very hot area is the exosome and the microvascular for provide microRNA, non-coding RNA. And in particular, most important is the mitochondrial transfer to provide the cell with the fresh or young mitochondria to support the cell viability. But most importantly, one part is one risk may be due to the MSC also will be attractive to the cancer cells to support the cancer proliferation. So this is the cancer promotion, tumor promotion risk. So our recent review article just summarized around 100 and more than 100 preclinical study to summarize a different kind of MSC, their risk for promotion or suppress the tumor growth. So everybody know that MSC will not initiate tumor. So the MSC itself will not initiate tumor initiation. But whether the MSC will promote tumor growth is still under discussion. So according to our data analysis, you can see, so different MSC from different tissues, they both show the promotion and the suppression effect. For example, bone marrow. So some will, it's just a report, will promote tumor in different tumor type. But other paper also show they will suppress tumor in different tumor type. So similar to the ADMSC, umbilical MSC. So you will ask what will be the correct? Yeah, both correct. Because the MSC from different tissues, they will be generated by different protocol. So the processing, how you deal with the MSC, the growth factors, the oxygen tensions, and then the pressure, also will induce the MSC go to different transcriptional activation. So they will express different gene to show different protein, so to present the different characters. So it's no wonder the same MSC from same tissue, some will promote tumor and some will suppress tumor. So we just summarize with different MSC in different tumor promotion, and also summarize with for each tumor type to analyze the different MSC tissue origin risk. So the other risk will be thrombosis and the lung fibrosis. It's talking about the MSC number for your clinical use. So just wondering, what do you think about it? If a higher cell number is really better for our clinical use? Not exactly. For example, if the patient, they just have a higher LDL, so with the risk of atherosclerosis. So yeah, if you just give a really high number of the MSC, so it maybe will induce the thrombosis to cause the patient risk. And another example will be the COVID-19 induced lung fibrosis. You know, for the IV injection for the MSC, all the MSC will just go to the lung and accumulate at the lung very well. So whether the patient can suffer the high number of the MSC in the short time. So the key of MSC in clinical use, the cell number maybe is not the key, but the key factor will be the MSC potency. Whether you can have a very high potency MSC quality is really critical for next generation MSC clinical use. So based on our understanding for the MSC clinical therapy, the advantages and the limitations. So here I would like to share with you our study, in particular for the Vanco PCMSC stem cells. So everyone know the Vanco painting. So you can see there is a very beautiful curve here. So our cell culture, we can present our PCMSC with a very similar curve. So we so-called is Vanco cell. Our study just show PCMSC show very beautiful systemic safety to be the allogeneic stem cell products. So we culture from the serum-free selection, and we can continue culture for 20 passages with chromosome stability. So this cell show very beautiful low IL-6 level and very wonderful immune modulation. I will show the data later. So as I mentioned just now, so we know the MSC would have some advantages but some risk. Here we just want to mention about tumor promotion. PCMSC cell is systemic safety without any tumor promotion. As I show here, when compared to the MSC from the X tissue or Y tissue, the PCMSC show very safe condition, co-injection with different cancer type. For example, for cancer 1, cancer 2, cancer 3, all the X-MSC or Y-MSC will show different strengths in tumor promotion on cancer 1 or cancer 3. But PCMSC not only will not promote the tumor, but also will suppress the tumor. So first data just show the systemic safety of PCMSC. We know the transcriptional data, they show very low level of the gene expression relative to cancer-associated fibroblast cell and the EMT. So it can answer why PCMSC would not promote tumor or would not promote metastasis. So if we compare to the in vivo animal data, you can see the X and the Y MSC, they will migrate and infiltrate the invasion into the tumor tissues to support the tumor growth. In contrast, PCMSC, they just will migration, but just align outside the tumor. So our data just show the safety of a PCMSC. So we also work on the PCMSC single cell analysis and to find the clusters of the PCMSC and to identify the potential significant marker for the PCMSC significance. We also work on the PCMSC immunobiomarker. In addition to transcriptome data, we also identify the potential immunobiomarker. So we will know very well when we apply the PCMSC in clinical practice. So take the advantage of a TMU GTP laboratory. So we already successfully generated the clinical grade PCMSC production. So all the PCMSC cell products fulfill with the FDA CMC chemical manufacturer control and is ready for clinical practice and the clinical treatment. For the COVID-19 induced ARDS, it belongs to acute lung injury. So we examine the PCMSC efficacy on the animal preclinical study first. We use the LPS ICR mice model. So with the control and the LPS induced acute lung injury, and to test that whether the PCMSC really present the very good efficacy in ALI repairment. So as we can show here, the PCMSC just show very beautiful repair ability for LPS-induced lung injury. So the injury score just show very beautiful suppression. As COVID-19 also present the damage of a neuron system, so we also examine whether the PCMSC their efficacy on ICH and multiple sclerosis. So here I just show you the ICH data. So we create the ICH injury model and to test whether the PCMSC treatment efficacy. As we show here, so the cross break circle just show the PCMSC group. You can see from the low tower test, so the mice can just work very, very well. So if we move to the full lip placing test, it also show the efficacy of PCMSC. So that means the PCMSC can help with the neuron injury very well. To test this hypothesis, so we move to the multiple sclerosis model. So I would like to show you the model. We use the MOG. This is myelin oligodendrocyte glycoprotein to induce the multiple sclerosis animal model. So as we show here, this is the control. You can see the mice work very well. The MOG model, very clearly, damage the neuron system. So the mice just work very, very poor. As you can see here. Okay, so after treatment with the PCMSC, you can see the mice can work very well. So this is the in vivo animal data to show the PCMSC effect on the neuron degeneration. So here I just show you the ICH model and the multiple sclerosis. This year, the COVID-19 also attacked Taiwan. In Taipei, we have a severe COVID-19 associated ARDS patient. So in the Taipei Medical University Hospital, Dr. Guo Hanbin, also our Dean of Cardiac Medicine, Taipei Medical University. So we use the PCMSC to treat the COVID-19 associated ARDS. So as you can see here, this is before treatment, this is after. So after the PCMSC treatment, so the second days we can observe very significant improvement for the patient lung function. So all 5 patients in our hospital received the compassionate treatment of a PCMSC. They all survived. So molecular data just show very beautiful the lung injury score after PCMSC treatment. The lung injury score just decreased very well. And the days of the symptom onset also decreased in the MSC group. So we move to understanding the dose and the immune profiling. So as we can see, the high potency of PCMSC is very clear. So we only use 2 to 10 to 7 cells per round, not per kilogram, but only per round, 1 injection. So very limited PCMSC cell can show the efficacy. It presents the PCMSC high potential and the high potency and high efficacy in ARDS treatment. So we examine the PCMSC effect on the immune profiling of ARDS treatment. So take advantage of a high parameter flow cytometry. We can observe all the patient immune profiling before or after PCMSC treatment. So as we can see very clearly, so the purple color just represents the plasma cell after PCMSC treatment. So the plasma cell population decreased. And we also can find some location increase that belong to B cell. So B cell increase after the PCMSC treatment. And there is another cluster of immune cell. This belong to mononuclear cell. So we can see the mononuclear cell also decrease very well. So with the understanding of immune profiling for the MSC treatment, so we also detect about the PCMSC efficacy, in particular for the extracellular matrix, DNA replication, and the cell cycle. So we can know the PCMSC will stabilize the extracellular matrix, in particular for the ARDS patient, and also promote the DNA replication, increase the cell cycle to help with the cell proliferation. By this way, to prevent or rescue the COVID-19 induced ARDS. The immune modulation profiling of a PCMSC also has been demonstrated by PCMSC transcriptome data and the proteomic data. As we just present just now, so they show very beautiful immune modulation. And talking about the proteomic data, you can find very beautiful the neutrophil downregulation of a PCMSC effect. So it's no wonder the PCMSC high efficacy on the LPS or COVID-19 induced ARDS, because the virus infection will increase the neutrophil in lung very, very well. So next, I would like to talk about the exosomes, the stem cell secretes. So I just showed the EM picture. Here is the PCMSC cell, and the cells can secrete a lot of exosomes for the paracrine factors and the exosomes for the disease treatment. So in literature survey, we can know the MSC secretome, including the secretion protein and the exosome. So many papers just show the secretome can do, in particular for the exosome, can do the immune modulation, can do the tissue repair, can do the stem cell function. But we need to pay attention about the double-sided of an exosome. We just mentioned about the physiological exosome, so the good size for all the functional biological function. But here I would like to remind the pathological side of the exosome. So given different cells secrete different exosomes, so some of the pathological exosome will help with the tumor cell for the immune system invasion, cause Alzheimer's disease or tissue failure, or the cancer formation or promotion. So our lab are also working on the MSC exosomes. So we successfully purify and identify and categorize the PCMSC exosome for clinical practice. So here is the exosome cell morphology identified by TEM, and the NTA assay can show the exosome size, just around to 300 nanometer. So very standard exosome marker CD63 and the CD9 present very well. So LC must analyze it. We can know what the exosome contain, what proteomic data. So we have a comprehensive analysis, including the exosome gene expression, epigenome expression, and the protein proteomic expression. So we are very happy to share with you. So our team have successfully continually received the National Innovation Award since 2019 and last year and this year. So focus on the systemic safety stem cell products. So it's a focus on, as I just mentioned, the ARDS and the others will be the agent and the unmet needs. For example, the diabetes and the severe burn and the cancer. This is my final slide. So as we just mentioned just now, for systemic safety PCMSC, the clinical use, we only talking about the lung, ARDS, acute lung injury. We also work on the asthma, COPD, and the lung fibrosis. For neurodegeneration for aged population, so the stroke, multiple sclerosis, and dementia, and Parkinson's disease are our project right now we are working on. So immune modulation for psoriasis and the ARS, and the infertility issues for the aged population. So the POF and the embryo implantation. So as the advantage of a PCMSC on tumor promotion free, so we use the PCMSC to be the cell glue or cell sheet for the patient receive the cancer tumor surgeon. So for the following treatment for metabolism disease such as diabetes and the diabetes for author and the acute kidney injury and the chronic kidney disease are the project we are working on. So we welcome for all the opportunity to work together. So thank you very much for this great opportunity again, and I will be very happy to take questions. Thank you.
Thanks a lot, Prof. Rita, for the very interesting speech. If I can summarize, then Prof. Rita has talked about the placental stem cells and their many advantages. It can, it don't do tumor promotion, but suppression. But to avoid thrombosis, should be the best number of the stem cell given to patient. And then there is no tumor promotion because there is no CAF and EMT related gene expression. It's very efficient against lung injury. That is can be seen from the 5 COVID patients with ARDS. Yeah. And then it's also, Prof. Rita also has taken the exosome from the secretome, and this also can have many function, immune function, and her placental stem cells has been tested for lung, neuron, immunity, infertility, and cancer and metabolism, and give good results. Okay, are there any questions? I think there are no questions in the chat room.
Can I ask question to Prof. Rita, Prof. Sharna?
Yeah, Dr. Radiana.
Hello, good morning, Prof. Rita. Nice to see you again.
Yes, nice to see you again.
Okay, Prof. Rita, so we are currently establishing the exosome isolation protocol here in Jakarta at a cluster of stem cell and tissue engineering. And your talk was fascinating, particularly in the way that you managed to characterize all the exosomes that's coming from the placental mesenchymal stem cells. So my question would be, do you think naive mesenchymal stem cell in comparison to induced mesenchymal stem cells, so if you induce the stem cells to generate a specific disease exosome, do you think it is worthy? The second question would be, in comparison to induced pluripotent stem cells, since you did mention that it is number 2 in production of exosomes or production of or the market value will be the second runner-up for mesenchymal stem cells. So if you compare exosomes coming from mesenchymal stem cells and induced pluripotent stem cells, how do you make the comparison? Because there is a publication already stating that the number of exosomes is higher, highly concentrated, and have a greater characteristic than mesenchymal stem cell exosome. Okay, that will be my question. Thank you.
Yeah, thank you. So, for Dr. Rediana, so good questions. Yeah, really nice to see you again. The question is really perfect. Yeah, the first about the specific exosome. Yeah, it's really the right direction. Yeah, given naive mesenchymal stem cell can derive from different tissues, so they can secrete the basal exosomes for, I think, the immune modulation or specific tissue origin, specific MSC exosome will have the unique function. But if we can generate the specific function exosome, will be perfect. So no wonder there is some priming process. For example, yes, if you want to deal with the immune modulation, so we can prime in the MSC with the inflammatory condition. If we want to deal with the MSC in different lineage differentiation, so we can put the different microenvironment to culture the MSC to generate the exosome. Exactly right. So I believe in the future, we will have a different brand of MSC. This means MSC 1, 2, 3 to maybe 100. We also will have a different MSC-derived exosomes to treat a different disease. So I think exosomes, the secretomes will be the next generation, very competitive and the business market. And talking about the pluripotent stem cell derived exosome, this is also a very good question. Today, I did not share with the data we generated the IPS derived differentiate cell lineage exosome for disease treatment. So given, the pluripotent stem cell always raise the concern about the tumor risk. So the exosome derived from the IPS differentiate specific lineage cell type for the clinical practice will be very, very interesting. And I think that's why when I analyze the market, IPS is the top 2 when compared to the ES. So the feasible and the broad possibility in the future clinical use, I think is very important. Yeah, thank you very much for Dr. Rediana. So
thank you, Prof. Rita. Thank you.
Okay, thanks a lot, Prof. Rita, for the elaborated answer. But due to time constraint, we have to end this session here. Again, thanks a lot for your participation in this event.
Yeah, thank you.
As mentioned before, in Hall A, we have concurrent session 7 with the topics updates on gastrointestinal cancer diagnostic and treatments. This session will be moderated by Dr. Irandi Putra Pratomo, MD, PhD. Fellow of Asian Pacific Society of Respirology. Let me introduce Dr. Irandi. Dr. Irandi has finished his study as medical doctor at University of Indonesia 2008. And then he unlocked his PhD degree in biomedicine in Hiroshima University in 2017 and finished his study in pulmonology specialist at Universitas Indonesia and in 2020 as consultant pulmonologist. Now he is currently active as lecturer at Pulmonology and Respiratory Medicine Department, Faculty of Medicine, Universitas Indonesia, as the Chief of Pulmonology Medical Staff, Universitas Indonesia, and Universitas Indonesia Hospital, and also a coordinator for COVID-19 Task Force in Indonesia, Universitas Indonesia Hospital. Dr. Irandi, if you are ready, the time is already yours.
Yes, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning for the Honorable Director, members of the board, coordinating officers of the core facilities and the research and medical education clusters of IMERI, and the Honorable Dean, Vice Deans, and the managers of Faculty of Medicine, Universitas Indonesia. Allow me to welcome you, the honorable invite speakers, Professor Esohiyama, MD, PhD, Dr. Ihsan Hassan, MD, PhD, consultant for gastroenterohepatology, fellow of the Indonesian Society of Internal Medicine, and also Professor Murdani Abdullah, MD, PhD, consultant for gastroenterohepatology, fellow of the American College of Gastroenterology, fellow of the American Society for Gastrointestinal Endoscopy, and to the professors, doctors, colleagues, and all distinguished participants. Okay, my name is Irandi Putra Pratomo, and I have a great honor to be the moderator for the concurrent sessions of Human Cancer Research Center in the 6th annual Eyes on IMERI today. Our concurrent session will be discussing the updates on gastrointestinal cancer, diagnostic, and treatment. At this moment, we have 3 of our speakers are already joining us to deliver their presentations. The topics are updates on pediatric liver cancer diagnostics and treatments from the Japanese point of view, and then liver cancer diagnostics and treatments in Indonesia. And the final topic will be pancreatic cancer diagnostics and gene therapy. Each of the presentation will be delivered by our honorable speakers within 20 minutes of time frame and will be followed by a panel Q&A for 15 minutes at the end of the session. Should a question arise, please deliver your question through the chat box feature or through the comment section. And please be considerate that not all questions will be answered due to the time constraint. Ladies and gentlemen, before we start our first presentation, allow me to introduce of our first speaker, Professor Esohiyama, MD, PhD, from Hiroshima University, Hiroshima, Japan, which currently the member head of the Natural Science Center for Basic Research and Development, Hiroshima University, and also the professor of Department of First Surgery, Hiroshima University Hospital, Hiroshima, Japan. Professor Hiyama is a medical doctor graduate from Hiroshima University and also a PhD graduate from the same institution. Okay, without further ado, Professor Hiyama, the floor and screen is yours. You may begin your presentation.
I appreciate for giving me the opportunity to have a talk for our experiences. There are nothing to be disclosed. As you know, pediatric liver tumors were divided into the malignant and benign tumors. In malignant tumors, most were hepatoblastoma, some were hepatocellular carcinomas. The symptoms of these tumors usually abdominal distension and abdominal tumors. In some cases, with the hepatoblastoma showed high count of platelet and cholesterolemia. A hepatoblastoma arabdoid tumor and well germinal tumor is usually detected in small infants. On the other hand, school-age adolescents show hepatocellular carcinoma or sarcoma. Sometimes these patients have a coexisting disease, as shown in the slide. For diagnosis with such liver tumor, we usually abdominal CT or MRI with a contrast media. And also we use chest CT scan for detecting ground metastasis. And then to get a definite diagnosis, we should do biopsy. We performed open biopsy for get enough volume of sample. Recently, we performed core needle biopsy, as shown in next slide. This shows an example for liver biopsy, like this. Before 1990, survival rates of child liver tumors were poor in Japan, even if the tumor was located. Similarly, the overall survival was about 35%, but those with standard risk hepatoblastoma improved to about 90% at 2009. How has the progress been achieved? The usage of cisplatin and anthracycline is effective to primary and metastatic tumors, so that the rejection rates increased and then the outcome of patients has improved. Moreover, new surgical approaches including hepatic exclusion, Pringle, ultrasonic dissection, etc., contribute to the safety and reliable rejection. Multi-center cooperative studies such as SAPO, CUG, and JPLT are important for this progress. This shows the pretext classification. This classification depends on the number of contributed lobes with a tumor. This is the 3 non-tumor lobe. This is the pretext 1, 2 is the 2, only 1 is 3, nothing is the 4. This shows a pretext 1 tumor, the primary rejection, like this. This case has a rejected pretext 2 tumors. We usually use the scusa for rejection and hemocoagulation powder for preservation of bleeding from the rejection margin, like this. This shows the post-text with a major vessel involvement, like this. The transplantation or extreme rejection tumors with major vessel involvement are controversial. In Japan, we established a whole Japan study group, so-called JPLT, to evaluate the efficacy of cisplatin and pirarubicin, JPLT1, protocol that conducted between 1991 and 1999. Then JPLT protocol was ranked out on 1999 to evaluate the cure rate of risk stratified hepatoblastoma using pretext system. And then we are ongoing study at JPLT4 with a global study. This is the first regimen, so-called SHEETER, consisting of cisplatin and vilarubicin. Vilarubicin, the derivative of doxorubicin, is considered to be less cardiac toxicity equivalent effect in compared to doxorubicin. In original CETA regime, we used 80 milligram per square, and in low-dose CETA regime, we used 40. JP study used pretext classification for evaluation of tumor exchange like this. This system also used the annotation factors used for risk stratification. The definition of this was revised on 2017. Mainframe of JPT protocol strategy was shown in this slide. All places were underwent upfront resection, and protected cases usually underwent surgery after 2 cycles of CETA regimen, and other advanced cases, we perform 2 cycles CETA regimen. The responder go to the another 2 cycles of CETA regimen, and responder with the second line chemotherapy item. And then we go to surgical resection. In some residual refractory cases, we use high-dose chemotherapy with stem cell transplantation. This case has a small protected 2 cases, like this. A segment shakes. We reject the tumor with non-anatomical resection. This case has a protected 2 tumors reported tumor thrombosis, like this. So this case is defined as annotation factor P2. After preoperative chemotherapy, this thrombosis diminishes. Standard left hepatectomy was performed in this case. This tumor is PROTECT3, which located at segments 4, 5, and 6 after shrinkage of tumors by chemotherapy. We perform central to sectionectomy for preserving liver function. This case had PROTECT3 tumors originated from caudal lobe, and we detected lung metastasis. After preoperative chemotherapy, the primary tumor nicely shrank. We resected this tumor by left extended hepatectomy. In this case, we also resected lung metastasis at the same time. This shows the living donor liver transplantation, like this. For the treatment of advanced liver tumors, extreme rejection and liver transplantation remain controversial. Among CFL2 cases with hepatic malignancies, 32 showed spontaneous tumor rupture at diagnosis. We define tumor rupture as free fluid in the abdomen, like this, and diagnosis one or more of the signs shown in this slide. Internal complex separatation with fluid, high density fluid on CT, heterogeneous fluid on ultrasound with echogenic debris, visual rupture. Interventional radiology through the left femoral artery revealed tumor vessel of femoral right rib hepatic artery here, extravasation indicating intra-abdominal bleeding due to tumor rupture. TA was effective for stabilization of circulating dynamics, but the bleeding of the tumor remained. Therefore, we rejected the resection of the tumors after TAE. Like this. You can see the ruptured hepatoblastoma. This slide shows the survival rate of the cases with ruptured hepatic tumor. As you can see, the cases with a spontaneous ruptured hepatic tumor shows poor prognosis, especially or in the cases in shallow resection. There are no cases who survived with pretext for ruptured tumors. The outcome of the case whose tumor margin was microscopically positive, like this, is also controversial. In the previous Symposia report, there are no significant difference outcome of the patient whose margin was microscopically positive. However, this shows the event-free survival rate of the cases with microscopic positive marginal rejection in complete rejected cases and in non-metastatic cases. You can see the cases with microscopic positive cases show the poor outcome in the comparison of complete resection. Recently, we have tried ICG navigation surgery for detection of microscopic residual of surgical margin. Usually, this method, microscopic residual might be expected to decrease in the rejected trial. You can see the nicely ICG positive node. There are small ICG positive node in liver. Usually, we injected ICG 3-4 days before abdominal surgery. This slide shows primary metasectomy using the ICG navigation surgery. Like this, you can see the nicely ICG positive nodule in here and here in lung metastasis. There were examples of micrometastasis under navigation surgery for lung. For the detection of lung metastasis, we inject ICG 1 day before phlebotomy. These lesions were difficult to be identified by naked eye, but these lesions were distinguished by ICG navigation. In this case, pulmonary metastasis almost diminished by chemotherapy. Before liver transplantation, we performed exploratory phlebotomy using ICG navigation. So you can see the ICG positive here region. We rejected here. HE staining of rejected species are shown in this slide using the fluorescent microscopy for ICG. You can see the ICG positive region. This is the micrometastasis. TACE is a combination therapy of TAE and radial chemotherapy because hepatic malignancy tumor is mostly depending on supply of the hepatic artery. The embolization interrupts the arterial blood flow to a tumor and prevents washout of the injected chemotherapy agent from tumor. This is a hepatoblastoma case who underwent TAE This case was 9-month-old girl who protects 3 large hepatoblastoma. Tests usual using carboplatin and pilarisin was performed by her right hepatic artery, like this. This tumor is markedly shrunk after 2 courses of tests, like this. The outcome of the patient who underwent tests is equivalent to that of patient who underwent usual chemotherapy. Finally, I'd like to introduce global collaboration study of pediatric liver tumors. As you know, there are 3 major groups for multi-center trial for pediatric liver tumors: SAPO, COG, and JPLD. Primary surgical resection for resected tumors has been an integral part of the treatment strategy of patient treatments in JPLD as well as COG-based trial. In contrast, SAPO-based trial usually undergo resection after receiving neoadjuvant chemotherapy in all cases. In 2011, we conduct MOU of Children Hepatic Tumor Consortium, so-called CHIC, to produce an internal database in Los Angeles among COG, SAPO, and Asian group. As a result, we made a new database consist of these 8 trials and performance variate analysis using total 16 500 cases. After the multi-parameter analysis of these factors, we made a new international risk stratification, which was published in Lancet Oncology. This divided hepatoblastoma into 4 groups: very low, low risk, intermediate, and high risk. This shows a cartoon for risk stratification: very low, low, intermediate, high risk groups, like this. This is a schema of data management. This global study will be performed as 3 individual consortia and merged in this Genica system. Asian group includes Gansu, Singapore, and Hong Kong participate in JCG consortium. Then we propose a FIT trial as an international trial for pediatric liver tumors, including hepatoblastoma as well as hepatocellular carcinoma. The aim of this slide are reduction of the toxicity in good prognosis tumors and improved outcome for poor prognosis tumors. Hepatoblastoma stratified in 4 groups according to this stratification, and hepatocellular carcinoma stratified into 2 cohorts, resectable and unresectable. This shows the primary objectives: clinical outcome in all patients, validation of new global risk stratification, and evaluation of clinical relevant factors, and the collection of clinically and pathological annotated biological specimen is included. This shows the sample size of this study. Total expected cases is about 1,200. This shows the schema of imaging center level system in JCCG. The DICOM data, including the CT and MRI, as well as the pathology, sent to the dental center. These data uploaded at the cloud system. And center reviewer access this data and then perform center review. The CRF data will be uploaded in the database using the same platform from European group and Asia independently, like this. And then these data will merge with COG data. These data will be able to be analyzed in each consortium as well as merged data. The current of fit is shown in slide. The number of registered cases not reached to the target number, but gradually increased. This is a schema of a global study. Thank you for your attention. Welcome to join fit from Asian groups. Thank you.
Thank you, Professor Hyama, for your great and very eye-opening presentation. At the end of the slide, thank you for the invitation. We hope that your presentation could serve as an insight for Indonesia to prepare to join the Global Collaboration Initiative of Pediatric Liver Tumor. Before we start our second presentation, allow me to introduce our speaker. Next speaker is Dr. Irsan Hasan, MD, PhD, consultant for gastroenterology hepatology, fellow of the Indonesian Society of Internal Medicine. He is a faculty member of the Department of Internal Medicine, Faculty of Medicine Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital, Jakarta, and is also act as the current Secretary Director of the Subspecialist Program for Internal Medicine from the same department. Dr. Irsan is a medical doctor graduate from Universitas Indonesia, an internal medicine graduate, a consultant for gastroenterohepatology, and a PhD graduate from the same institution. Without further ado, Dr. Irsan, the floor and screen is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Thank you for giving me the opportunity to participate in this important event. My topic is liver cancer diagnostics and treatments in Indonesia. This is the outline of my presentation. Let me start with the first part, current situation of HCC in Indonesia. Liver cancer is the sixth most commonly diagnosed cancer worldwide in 2020, with more than 900,000 new cases annually. And most cases of liver cancer come from Southeast Asian countries. Of course, Indonesia is included in that list with a total of more than 21,000 cases, new cancer cases in 2020, with more than 20,000 of deaths, meaning that this is the cancer with very, very high mortality. There are some risk factors of HCC, such as chronic HCV, chronic HBV, alcohol, and also non-alcoholic fatty liver disease. And in Indonesia, we found that hepatitis virus, Hep B and Hep C, as the most prevalent risk factor for HCC. This is the data from 2015 until 2020 from Cipto Mangunkusumo, our registry in Cipto Mangunkusumo Hospital, showing that Hep B and Hep C as the most frequent risk factors of HCC. This is the stage of the patient when they come to Cipto Mangunkusumo Hospital. We can see here that most of patients come in intermediate or advanced stage. Intermediate is stage B, and advanced in stage C or D. BCLC staging system and treatment algorithm is the most widely used staging system for HCC patients. It consists of 5 criteria, and for the first two criteria, very early stage of HCC, can give curative treatment. And these three stages are the stages with palliative treatment. And as I showed in the previous slides, that most of our cases in Ciptomangunkusumo are in intermediate advanced stage, meaning that most of our cases got palliative treatment. That's why the survival is very short. Based on this data, in 15 days, in 15 years, the survival almost similar, about 5 months. And newer data showed improvement in the survival of early stage HCC patients at Ciptomangunkusumo Hospital. But only a few patients come at this stage. Let's move to HCC treatment options. The treatment of HCC started in 1880 when the first successful resection of liver tumor was performed in Germany. But the progress is made after World War II, when hepatectomy became major, and other modalities then came, like liver transplantations, transarterial chemoembolization, radiofrequency ablation, and the most recent is targeted therapy. And the HCC treatment options or modalities can be divided in many type of treatment, like surgery, chemical ablation, energy-based ablation, transcatheter, radiation therapy, and systemic therapy. Liver resection is a curative therapy of HCC, and this is the first-line therapy for HCC with solid tumor and good liver function. Unfortunately, only a few number of HCC patients met the criteria of suitable candidate for liver resection in Indonesia. The other modality is liver transplantation. This is the preferred curative therapy also for HCC patient with reduction of liver function. This method can handle both of HCC and liver cirrhosis. Until now, there is only center or hospital perform liver transplantation. That is Ciptomangunkusumo Hospital. The other option is percutaneous ethanol injection. This is the old technique that used to treat the HCC with very small size, less than 2 cm. But after we have radiofrequency ablation, we don't use PAID anymore, because ablation gives better result than ethanol injection. RFA is recommended as the standard therapy for HCC with amount of nodule with size less than 3 cm. The newer local regional therapy is microwave ablation. Microwave ablation is a thermal ablation technique, also using microwave. But this technique is not available yet in Indonesia. The next local regional therapy is transarterial chemoembolization, or TACE. TACE is a percutaneous technique via femoral artery and hepatic artery to deliver the chemotherapy drugs that combine with embolization. TACE is the most frequent local regional therapy using in Cipto Mangunkusumo. Not because this is the best technique, but because the most stage of our patient is intermediate stage, and the treatment of choice for intermediate stage is TACE. And the next is transarterial radioembolizations. This is using the almost similar technique with TACE, but we give microspheres that containing yttrium-90 into the liver. Radiotherapy can also be used for HCC, like SBRT. SBRT, or stereotactic body radiotherapy, is radiation therapy with a high dose of ablation radiation. It can be used for HCC patients who cannot undergo liver resection or other methods. SBRT is available in Cipto Mangunkusumo Hospital. And the recent therapy is systemic therapy using targeted therapy. The systemic therapy was developing in the last 15 years after the targeted therapy was introduced. The mechanism of action is to inhibit the tumor proliferation. There are two systemic therapy that are available: multi-kinase inhibitor and immunotherapy. With so many options or modalities for HCC treatment, we believe that clinician needs guidelines. So Indonesian Association for Study of the Liver published two guidelines. The first guidelines on 2017 and the newer guidelines in 2021. The first guideline, Indonesian guidelines on HCC management, is the general guidelines involving many professional organizations like digestive surgeon, radiology, radiotherapy, pathology, and of course hepatologists. There are some recommendations on that guidelines for clinician. The new guidelines, or the second guidelines, focus on systemic therapy. I will discuss some recommendation on the guidelines. First, recommendation for hepatocellular carcinoma surveillance. High-risk populations are recommended to undergo hepatocellular carcinoma surveillance, which is high-risk populations. So we consider this patient as high risk, which is liver cirrhosis patient in childhood class A and B, non-cirrhotic hepatitis B older than 40 years for male, or older than 50 years for female, or hepatitis C with stage 3 fibrosis or cirrhosis, chronic hepatitis C. These are the patients should undergo routine screening or surveillance. How to do the surveillance? Hepatocellular carcinoma surveillance should be used ultrasound and tumor marker test, AFP and or PIVCA, protein induced by vitamin K absence, at 6 months interval. Next is the recommendation for hepatocellular carcinoma diagnosis. There are 3 important diagnostic criteria for hepatocellular carcinoma. First, underlying liver disease. B, The second, tumor markers, and the third, specific radiologic features. Diagnosis of HCC can be made if the patients have A plus B plus C, or A plus C, or B plus C. So C, specific radiologic features, is the most important diagnostic criteria. So every patient with suspected of HCC should undergo CT scan or MRI. Next is a recommendation for hepatocellular carcinoma treatment. This is our algorithm. This algorithm using liver function, extrahepatic metastasis, vascular invasion, the amount of the nodules and size of the nodules as the criteria to choose the treatment. So we can choose the treatment based on childhood stage, metastasis, or amount of nodules and the size of the nodules. So we move to the last part, future perspective on HCC management. After the era of sorafenib is the first targeted therapy. There are many new options for systemic therapy. New systemic therapy drugs arrived since 2017. Now we have regorafenib, lenvatinib, ramucirumab, bevacizumab, and atezolizumab. It seems that systemic therapy will be the main modality for HCC management in Indonesia because most patients come in the intermediate and advanced stages. But the problem with systemic therapy is the response is not very good, and the cost of the drugs is very high for our patient in Indonesia. Therefore, a biomarker is needed as treatment response predictor, so the drug can be adjusted to the condition of each patient, or we call it personalized therapy. Various biomarkers have been investigated to be used as therapeutic or prognostic predictors. Biomarkers can be divided into protein markers, gene markers, or immune-related cells markers, or host-related markers, or other biomarker classifications like tumor markers, tumor microenvironment, peripheral blood, or gut microbiota markers. Experts are trying to find a good HCC biomarker to predict treatment response. They use PD-L1 or TGF-beta or PD-1 or other plasma biomarkers or tissue biomarkers. But until now, there is no good predictor has been found yet. So all experts are still competing or trying to find a good predictor. So I think there is a wide opportunity to do study to find good biomarker for HCC treatment, especially for systemic therapy. Finally, as the take-home message of my presentations, HCC cases in Indonesia are still high, and most patients come at an advanced stage. The consensus on systemic therapy published by Indonesian Association for Study of Liver, or PPHI, should be a guide for clinicians in treating HCC patients. There have been rapid advances in systemic therapy drugs and are likely to become the main modality for HCC patients in Indonesia. There is no accurate response predictor of systemic therapy, so there is an opportunity for further research on this. Thank you.
Okay, thank you, Dr. Isar, for your great presentation regarding updates of the HCC in adults in Indonesia. Okay. Moving right along, before we start our third and final presentation, allow me to introduce our speaker, Professor Murdani Abdullah, MD, PhD, consultant for gastroenterohepatology, fellow of the American College of Gastroenterology, fellow of the American Society for Gastrointestinal Endoscopy. He is the current head officer of the Human Cancer Research Center of IMERI, and is also a professor of gastroenterohepatology in Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital, Jakarta. Professor Murdani is a medical doctor graduate from Universitas Indonesia, an internal medicine graduate, consultant for gastroenterohepatology, a PhD graduate, and a professor of gastroenterohepatology from the same institution. Professor Murdani, the floor and screen is yours.
Thank you, Dr. Irandi, for your kind introduction, and thank you for the organizing committee for inviting me to this wonderful meeting. May I have a slide, please? Ladies and gentlemen, I was supposed to talk on the gene therapy, but I'm afraid it's too tough for me. So let me change a little bit of my talk and the outline of my talk in this occasion. Well, next slide, please. Next slide. I would like to start with the fact that pancreatic ductal adenocarcinoma, PDAC, should be the majority of cases in pancreatic cancer, and this cancer predicted to become a second leading cause of cancer-related death in U.S. and other parts of the world by 2030. In 2017, global incidence showed almost 500,000 of world population suffered from this cancer, which incidence rate is 5%, and the death also at the same number. In our situation, we have data from Dr. Cipto Mangunkusumo Hospital showing that 1 year survival rate no more than 14%. And the significant predictor of mortality are metastatic status and not undergoing Whipple procedures. Next slide, please. If you look at the age standardized incidence rates, Indonesia show 2.1% could be a medium in ASR compared to another part of the world. Next slide. Interestingly, to learn that the number of this cancer is increasing steadily during the last decade. Next slide, please. Those are some challenges we found in this dealing with this cancer. late stage diagnosis, most of cases, more than 80% of cases have reached metastasis or locally advanced state once they visit the hospital. And aggressive cancer cells with high proliferation rate and powerful local invasive and metastatic properties, and lack of effective systemic therapies, and there are numerous exomic alteration in diverse signaling pathways that vary considerably between patients, and this all induce difficulty in molecular targeted therapies. Screening for pancreatic cancer is not recommended for a general population as regard the screening is not cost effective. Slide, please. Some risk factors of pancreatic cancer are smoking, obesity, diabetes, alcohol use, pancreatitis, and genetic predisposition. Some genes have been identified regarding pancreatic cancer risk, as shown in this slide. Slide, please. The image shows a progression of acinar cells into pancreatic ductal adenocarcinoma. The pancreas contains cells of exocrine, what we call acinar, epithelial or ductal, and endocrine, alpha, beta, and theta. Its origin, among which acinar cells are well known for their high degree of plasticity. This plasticity is considered to drive pancreas homeostasis and regeneration. As in contrast to other organs of the gastrointestinal tract, the pancreas seems to lack a defined stem cell compartment. In a process called acinar to ductal metaplasia, or ADM, acinar cells transdifferentiate to more epithelial phenotypes when experiencing certain macro and microenvironmental stimuli, such as tissue damage, inflammatory, or stress condition. During ADM, acinar cells acquire progenitor cell-like characteristics, which render them more susceptible to pro-oncogenic hits, such as activating mutation in the proto-oncogene KRAS, eventually transforming them into pancreatic intraepithelial neoplasm. This transformation is generally considered as the initial step in PDAC development, followed by sequential progression involving genetic hits in several tumor suppressor genes. Slide, please. I think we agree that almost all pancreatic cancer patients have one or more mutation of those 4 genes. The table shows major genes in pancreatic cancer development. There is an activation of oncogenes, KRAS, which cause proliferation, differentiation, and cell survival, accompanied by inactivation of tumor suppressor genes. Loss of these genes influence cell growth and cancer metastasis. Almost all pancreatic cancer patients have one or more mutations of those 4 genes. Slide. The figure shows algorithm for pancreatic cancer diagnosis. Based on history taking, physical exam, laboratory result, further imaging should be done. When high level of skill is available, endoscopy ultrasonography is preferred for diagnosis. Pancreatic cancer diagnosis must be established by histopathology as much as possible. Regarding cancer staging, dynamic CT, dynamic MRI, AUS, PET or laparoscopy examination should be performed as needed. Slide. Those are some modalities available to treat pancreatic cancer, such as surgical procedure, chemotherapy, radiotherapy, immunotherapy, and targeted therapy. But we are focused maybe more endoscopic palliative therapy in this case. Slide, please. Even following complete successful resection of pancreatic tumor, overall survival and prognosis remains discouraging. Hence, post-operative chemotherapy and chemoradiation is almost always incorporated in the therapeutic regimen. Slide. Slide, please. Next slide. Next slide, please. Yeah. For unresectable pancreatic cancer, radiofrequency ablation or RFA is one of the options for local treatment. It involves delivery of thermal energy through needle electrodes that cause coagulative necrosis and decrease tumor bulk. Potential adverse events are acute pancreatitis, pancreatic fistulae, gastrointestinal hemorrhage, damage to surrounding structure, and the approach can be done intraoperatively, percutaneous with ultrasound or radiologic imaging, or ERCP. But recently, we have AUS RFA is a relatively safer approach with high technical and clinical success rate, less risk of procedure-related mortality and adverse event. Next, please. The figure shows the procedure being done on the pancreatic mass with a hyperechoic zone seen around the electrode tip. Next slide, please. Other modalities such as immunotherapy and targeted therapy are also being studied. Immunotherapy remains a future breakthrough in the treatment of PDAC. A growing number of what we call chimeric antigen receptor T cells target have been identified, such as mesothelin, CEA, CD133, and some other target. The positive result of this treatment in preclinical studies suggests a promising application in clinical setting. And many of these molecules are being investigated in ongoing clinical trials. Next, please. We would like to look a little bit some review on gene therapy available recently. Next, please. Well, we will further discuss about strategies used in gene therapy. There are gene replacement, modification, augmentation, and blockade. For monogenic diseases, gene replacement is a good approach, but there are technical limitations and complex genetic alteration. So direct modification of genes are ideal manner of therapy, but there's also some difficulties. Gene augmentation involves exogenous transfer therapeutic genes into deficient cell. It is a commonly used strategy in gene therapy. Gene blockade, also called antisense gene therapy, tries to prevent the transcription and translation of certain cancer-associated genes. Next, please. These are viral and non-viral factors for gene delivery, with different benefits and consideration. Some viruses used as factors are adenovirus, retrovirus, and adeno-associated virus. Non-viral factors have the advantage of lower immunogenicity, easier manufacturing, and larger DNA or RNA payloads. It is achieved through RNA inference, plasmid DNA, and gene editing using CRISPR-9. Slide, please. I would like to show one case reported by Liu this year. This is a case study of gene therapy application in pancreatic cancer is done. The patient was an 84-year-old white female with the initial diagnosis of non-metastatic, poorly differentiated pancreatic adenocarcinoma. She underwent Whipple's resection with post-op radiation therapy and received also chemotherapy for 1 year. A year later, the patient had hepatic and lymph node metastasis and peritoneal carcinomatosis. The patient was given Delta-Rex-G therapy for 18 months. Estimated tumor burden was calculated based on tumor size. Patient had complete remission after week 36 of the treatment. There was no additional cancer therapy. No late adverse events were found. Duration of survival was more than 12 years. Next, please. In this case, Delta-Rex-G uses application in competent tumor target retroviral factors that track abnormal signature proteins exposed in tumor microenvironment. After binding and cell entry, the factor releases genetic payloads into host cell cytoplasm. RNA of the retrofactor is transcribed into the DNA. The DNA integrates into host chromosome and enforces expression of gene of interest, such as cytocidal DNG1. It inhibits a CCNG1 function that promotes cell competence and survival. Slide, please. The case showed the CT scan resolution of pancreatic mass and shrinkage of liver lesion. Slide. Let's back to our real world in clinical setting. We observed that only approximate 10% of patients who are diagnosed early benefits from potentially curative surgical resection. And more among this small group, more than 80% of patients who undergo surgical resection will experience tumor recurrence within 12 months of the procedure. Therapies currently available for pancreatic cancer can improve prognosis, but are less beneficial in survival rate. Some challenges are poor penetration and resistance of drug, low radiosensitivity, and severe side effects. However, pancreatic cancer may cause severe complications such as duodenal or gastric outlet obstruction, obstructive jaundice, and tumor-related pain. And the approach for this complication could be done by endoscopy. Next, please. This image shows median survival of pancreatic cancer patient based on its stage. Metastatic disease with ECOG score more than 2 had median survival less than 6 months. And I think the majority of cases belong to this group. It is best to treat pancreatic cancer early for higher rate of survival. But in fact, we found majority of cases come to the hospital with late stage of the cancer. Next, please. Pancreatic cancer may cause obstruction of gastric outlet. The treatment is done to re-establish oral feeding by restoring GI continuity and improve quality of life. Endoscopic methods is well tolerated and less invasive procedure compared to palliative surgery. Application of endoscopic stent showed shorter length of stay and faster oral intake. there may be increased reintervention rate due to stent obstruction or migration. Next, please. This image shows use of duodenal self-expanding metal stent or SEMS. Next slide, please.
Excuse me, Prof. Murdani, you have 3 more minutes for your presentation.
Yeah. Okay. This is another complication of pancreatic cancer, what we call obstructive jaundice. Endoscopic biliary stent is now accepted as palliation gold standard of obstructive jaundice in unresectable pancreatic cancer. Because less invasive, lower morbidity, lower cost, associated with shorter length of stay. Preoperative biliary drainage had a significantly less major adverse effect than direct surgery groups in malignant biliary jaundice requiring surgical resection, has been shown by Mole in 2016. And biliary stent is placed during ERCP after cannulation and bile duct and guide wire placement. Next slide, please. This slide shows the survival, stent patency, and cost effectiveness of plastic versus metal biliary stent for palliation in malignant biliary obstruction. The study have been conducted in our hospital. Next slide, please. Another complication is pain. Pain management. Malignant invasion of mesenteric or celiac nerve plexus could induce abdominal pain or back pain. And in this case, endoscopic ultrasonography guided celiac plexus neurolysis can be very helpful to reduce pain. And the report showed 80% efficacy. Well, ladies and gentlemen, I would like to conclude my talk to say that pancreatic cancer is often diagnosed late and it remains a challenging disease to treat. Therapeutic options are mostly palliative, while potentially curative treatment still has a high mortality. Endoscopic palliative approach in pancreatic cancer is well tolerated and less invasive. Some clinical studies of gene therapy are encouraging, with minimal adverse event and increased life expectancy. Further studies are needed for clinical application of gene therapy in pancreatic cancer. Thank you for your attention. Assalamualaikum.
Waalaikumsalam. Okay. Thank you, Professor Murdani, for your presentation. And next, there will be the end of the presentation session. Now allow me to continue with the panel question and answer. And we have our question to be directed maybe to Professor Hiyama first. Okay. Maybe this is also directed to all of the speakers. So do you experience any rebound, increase of returning or new severe tumor patient due to the pandemic because the patient is feared to go to the hospital? This is at least in our experience in the Persahabatan Hospital and also the Universitas Indonesia Hospital, that we experience this kind of situation where the lung tumor patient is somehow increased, but I think this is a kind of a rebound increase since the patient were reluctant to go to the hospital. Do you have any same experience in the Hiroshima University Hospital, Sensei?
Well, thank you for Irandi for the organization. Yes, well, the COVID-19 is not so problem for Mercy to our hospital. So we are now will continue to the caring of the patients. Is it okay?
Okay, without any trouble, Sensei. Okay.
Yeah.
And the next question would be, we do have shared the same experience of using NGS, the next generation sequencing. Now, do you found any human genomic variant that could be a potential target for molecular targeted therapy in pediatric liver tumor as observed in lung cancer, Sensei?
Okay, thank you. A good question for now. We are Japanese people now for genome sequencing for the almost all pediatric cancer, including neuroblastoma, Williams tumor, hepatoblastoma, other solid tumor. And then we perform full genome sequencing, and we are looking for the new target for such childhood tumors.
Because this is very interesting since in the IMERI we already have at least 2 NGS. The most one is the Illumina MySec, the one that we have the same experience in the Sisenkaga Placenta. So I hope one day we can make some collaboration. Next, maybe I need to confirm if the ICG died pulmonary metastatectomy, was it common? And does it mean resection is in the pulmonary or from the liver? I need to confirm that.
Yes, this is a very comfortable for the method for the ICG navigation surgery. We are now clinical trial for how the effective of this ICG navigation in our JHPLT group. Also, same clinical trial is going in COG people. So you can see the ICG very cheap and very old method for the testing liver function. So ICG, the uptake in the hepatoblastoma as well hepatocellular carcinoma cells, but this cannot excrete these ICG. So injection of ICG before surgery, and 1 day or 3 days before surgery, ICG injection. ICG is remaining in the only tumor cell. Normal liver cell excreted or the ICG in the bile duct, so nothing. So an ICG very useful navigation surgery. Only the detection is the ICG ultra red wave. This is a comfortable machine for dermatology or lymphangography is a comfortable machine. So we are used to this machine to the navigation surgery, especially in pulmonary small metastasis. This is very useful. We are now in the clinical trial.
This is very eye-opening. Maybe we could use the dying property of the ICG for another navigatory surgery. And then next to the Dr. Irsan and Professor Murdani, do you have any recommendation for screening and prevention of adult ACC and PDAC? Maybe for our public viewing in the YouTube channel.
Thank you, Dr. Irandi. Yeah, screening or surveillance is the most important thing if we want to increase the survival of cancer, especially HCC. As I mentioned in my presentation, that we have very short survival for our HCC patient in Cipto Mangunkusumo, about 5 to 6 months. So screening should be performed for every chronic liver disease patients, especially patients with liver cirrhosis. So the screening should be performed every 6 months with ultrasound and AFP. But the problem is the machine, ultrasound, and also the insurance reimbursement. So this is our problem in type C or type D hospital. So some patients should be sent to class A or B hospital. So I hope this problem will be solved in the next future. Thank you.
Yes. Prof. Murdani, do you have any remarks for the screening for prevention?
Yeah, thank you, Dr. Irandi. Yeah, we recognize pancreatic cancer is hard to find earlier. The pancreas is deep inside the body, so early tumors cannot be seen or felt by healthcare providers during routine physical exams. And I'm afraid there are no any single societies to encourage the screening for pancreatic cancer because of cost effective issues. So I think there are no screening for this kind of cancer.
Yes, thank you, Prof. Murdani. Okay, so I'm afraid the time is already up. So we learned today that in Japan, the introduction of new drugs, new surgical approaches, and initiation of international multi-center cooperative leads to the increase of survival rate in pediatric liver tumor. While from Indonesian experience, we learned that Indonesia is among the South Asia country with most new adult ACC case and death caused by ACC annually, with risk factor where hepatitis B infection and other non-viral risk factors. And maybe almost the same with the PDAC, where non-communicable risk factor of PDAC and ACC are similar. And both adult ACC and PDAC, most patients came with a late-stage disease, and palliative supportive care are insisted, although there are certain very strict limited patient also for the curative liver resection or transplantation, while systemic therapy would serve as potential both of the PDAC and adult ACC and also for the gene therapy. That's why from this experience, we hope that both Japan and Indonesia could build a strong collaborative ties to achieve a better understanding of liver and pancreatic tumor in children and adult. And we hope for Professor Hiyama and our side in Indonesia could discuss more about this particular matter. Okay. As we reach the end of the session, allow me to thank all the invited speakers, Professor Hiyama, Dr. Irsan, and Professor Murdani for giving us an insightful talks today. I also thank to the committees and all the distinguished participants for the given opportunity. And please accept my apology for any discomfort that happened during this session, and I hope this session will provide us a better understanding of gastrointestinal cancer diagnostic and treatment. I wish you all a pleasant day. Once again, thank you. I am giving back the stage to the MC. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
The next concurrent session will be moderated by Dr. Agus Rizal Ardi Haryandi Hamid, urology consultant, PhD. Dr. Agus Hamid gained his PhD degree in Redbourne University, University Nijmegen Medical Center in 2016. He is now an active uro-oncologist consultant, staff in Department of Urology and Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. He is also an editorial board member in Society Internationale de Urologie Journal and Medical Technology Cluster staff in IMERI. Dr. Agus, if you are ready, the stage is already yours.
Thank you for the introduction, MC. Assalamualaikum warahmatullahi wabarakatuh. Good morning for everybody. So now we're in the concurrent session 9, the role of medical technology in post-pandemic. As we see that during the pandemic, the technology grow very fast, and we see the advantage and also the application of medical technology in pandemic management. Now, in this session, we have 3 distinguished speakers that will talk about the AI, about the simulators, and also further simulation and teleteaching that we can use for post-pandemic. Without further ado, I will introduce the first speaker, Dr. Eric Daniel Tenda, DIC PhD, SPPD FINASIM. He had the fellowship in London and in other country. Now he's in the lecturer in internal medicine department, PIC of interventional pulmonology, and head of artificial intelligence and digital technology in medicine group, medicine research group, IMERI FKUI. So please, Dr. Eric, the time is yours.
All right. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hello, everyone. So again, thank you very much for the organizing committee of the 6th ISO IMERI 2021. So again, my name is Eric. Thank you very much, Dr. Agus Risa, for a very nice introduction. So let me share my screen. Yeah, so this morning, I would like to actually discuss about what's the current development, especially for AI in respiratory medicine. Again, my name is Eric. My background is internal medicine, especially an interventional pulmonologist. I finished my PhD at Imperial College London last year, actually. And my main focus for my PhD research is AI in interventional pulmonology. So without any further ado, I would like to actually share a very nice presentation, which is presented by our Vice Minister of Health, Dr. Dante, during the 5th Open Innovations IMERI 2021. So as you can see on your screen, that by the year of 2020, so this is despite what happened now, I mean, the pandemic, the chronic disease actually taking most of the cause of death, which is nearly 75% of all death worldwide. And in relation to that information, we can also think that most of the chronic disease will take more of the health expenditure. Right? This is not only happen in the US. On the screen, you can see this is the data from US. So according to this data, US healthcare system wastes about 750 billion annually. And this is also happening in Indonesia. So this is the very nice presentation by our Vice Minister of Health during the 5th Innovations Open Innovations IMERI. So as you can see, there's a changes actually in the trends of non-communicable diseases, right? I would like to focus on lung diseases. So as you can see here, that there's not much change actually between 1990 and 2019, right? Especially for lung diseases like non-infectious lung diseases, infectious lung diseases such as tuberculosis, all right? So now the trend is actually shifting. More non-communicable disease, and also we're seeing declining trends of communicable disease, all right? But this is the challenge for our country, how to tackle this problem, how to best manage and best approach in terms of a clinical approach and also for the treatment approach. All right. So this is the second slide that I actually quoted from the presentation from the Vice Minister of Health. As you can see here, on the very left column, age between 18 to 15, the main cause of death, number 7, 8, and 9 is actually lung diseases. And for us to be able to do the screening, we can simply do the chest X-ray. All right. Probably many of you with a background of internal medicine or a pulmonologist, you know there's a trend now from late 90s to the beginning of to the year 2000 that we use a low dose CT scan to actually screen those patients suspected with a lung cancer. So yes, in Indonesia, we still use a chest X-ray to do the screening. And this is based on the main cause for people, especially in the age of 18 to 15 because due to lung diseases. All right. So on this slide, I would like actually to share that the medical imaging diagnostic, and especially also for the clinical pathology diagnostic, this is such an assessment which is often based on your expertise, very subjective, and this is depend on education and experience. You cannot compare someone who already have, let's say, a 10 years experience doing a clinical pathology diagnosis under the microscope. They can just easily, probably between seconds, they can actually establish a diagnosis, and compared to someone as, let's say, me, I'm a fresh graduated clinical pathologist, right? So this is the area that we can actually improve our best approach to establish the diagnosis for patients that we actually suspected with lung diseases. All right. So I would like to actually discuss about what's the current development of AI in respiratory medicine. There are a few of AI development in respiratory medicine. If I'm not mistaken, it's already started with the computer vision or machine learning that use for patients with severe emphysema or COPD. And also, as I mentioned before, there's also the computer-aided diagnostic tools, which is the AI-based algorithm for lung infection, especially for tuberculosis. There are probably 2 or 3 research using this CAT or computer-aided diagnostic in Indonesia for tuberculosis. So we already have the software in place. And then the third one, this is the predictive models for or in pulmonary hypertension, asthma, and also pleural infection, and how we can use this AI algorithm to actually replace, quote unquote, the pulmonary function test, especially during this pandemic era. And also, the fourth is a computer vision for lung nodules detection. And this is also can give us a prediction for risk for malignancy. Number 5, there's a computer vision and molecular signature for diagnosis and pulmonary fibrosis. And last but not least, I think, as mentioned by the moderator, during this pandemic, we actually evolved quite fast. And one of the interesting area that is now quite very much developed is actually to use AI to help the clinician, the doctors, and also the hospital and the government to actually best predict whether this patient have SARS-CoV-2 infections or not by simply use a chest X-ray. And I will give the explanation on the slides after this. All right, so the box colored in red, these are the 3 boxes or the 3 platform in AI in respiratory medicine that we already used in Indonesia. The first one, we already have the CAT or computer vision for disease severity in COPD. We are now currently doing an ongoing research for AI in lung infection, especially tuberculosis. And we are now in collaborations with one of the biggest AI software company in the Netherlands for the development of AI in the SARS-CoV-2 infections. All right. So what other AI algorithms, especially for respiratory medicine, that are available in the market? This is a very nice publication from Professor Henry Colt and team at the European Respiratory Journal. As you can see here, there are probably about 5 or 6 algorithms that already have a patent for AI in respiratory medicine. The first one is to detect lung nodules. This is probably related to lung malignancy. Second, for COVID-19, which is now introduced by Delphi Imaging. The name of the software is CAT for COVID. The third one is AI for pulmonary embolism. And fourth one is AI, as I mentioned before, for COPD or emphysema. And we can also use this for ILD fibrosis. And also there's an AI algorithm for pneumothorax and AI for pulmonary function tests. On the very right column, you can see here, this is the software and whether the software is already registered for European community or European Union, which is approved by the CE mark, or already have an endorsement from FDA US. So firstly, I would like to discuss about the AI for tuberculosis. As I mentioned to you, AI for tuberculosis, we already use this algorithm probably about 10 or probably 10 years ago. The best part about this algorithm, especially CAT for TB from Delphi Imaging in Tirana, they already got the endorsement by WHO and also from the Stop TB Partnership. And the reason why, because the CAT for TB is actually quite sensitive as compared to the gold standard by bacteriologist laboratory tests. So the sensitivity can actually ranges between 90% or more, and the specificity is actually more than 70%. So again, yes, we are in collaboration with CAT for TB for this AI in lung tuberculosis TB in Indonesia. So this is actually the interface of CAT for TB. As you can see here, we just use a plain chest X-ray. We upload it to the software, and between the split seconds, I mean, it's only 2 seconds, you can just easily press this button with the stars. And then once you clicked it, and you can see that the software actually mark the area in the lungs using a color heat map algorithm that overlays the chest X-ray to mark which area that actually have the most probability for lung tuberculosis. As you can see here, the score is actually 73.35% of probability, right? So again, this is a very nice software. The software is already used in more than 40 countries in the world. It's already been trained more than 1 million chest X-ray. All right, and on a previous publication, the software is actually proved to be more accurate than the human readings. Again, but most important things, I don't want to give wrong perceptions about this, because again, AI is always start with human, how to best train the software, and as we go along, then the software will also increase their capabilities, and also it will also help the doctors, so then we are not more subjective in actually do the chest X-ray readings, especially for lung tuberculosis patients. So this is a very nice collaborations between the Faculty of Medicine, University of Indonesia, IMERI, Cipto Mangunkusumo Hospital, where we're also in collaborations with the Faculty of Computer Science and also Delphi Imaging to develop AI for tuberculosis. And also we are now in the midst of completing the AI research for tuberculosis in Indonesia. And then the second one I would like to actually focus on the AI for COVID-19. So we are in a collaboration again with Delphi Imaging to use probably the same algorithm as I mentioned to you before, the CAT for TB. This one is CAT for COVID. So we use, again, a color heat map to actually mark the pneumonia that caused by COVID-19. So we are already reached more than 500 participants from 3 hospitals, which is from Cipto Mangunkusumo Hospitals, Universitas Indonesia Academic Teaching Hospitals, and also Muhammad Hussein Hospital in South Sumatra. So with CAT for TB, with CAT for COVID, we actually try to upload the chest X-rays to the software. And then the software itself, I mean, the CAT for COVID will generate a score between 0 to 100 that indicates the probability of this lung lesion or lung abnormalities, which is correlates with RT-PCR results. So we already have a very nice results, and we are hoping to actually publish the result as soon as possible. All right. So again, as I mentioned to you before, my focus on the AI and respiratory medicine is actually for COPD. I would like to share a brief case of how we use the AI in COPD. I would like to draw you a case. So let's say we have a patient, 65 years old male. He's a smoker for more than 50 years now because of smoking. The patient's now diagnosed with COPD, decreased quality of life, and he already used inhaled corticosteroids, LABA, and LAMA. So 3 inhaled therapy already been used by the patients. So as you can see, that this is progression for this patient, right? So 5 years ago, diagnosis with COPD, and then 3 years after, the patients got a worsened condition. 2 years after that, got multiple exacerbation that requires hospitalization for this patient. As I mentioned to you before, patient is already in a maximum inhaled therapist. And then after that, 3 months prior the last hospitalization, the patient is actually hospitalized again for acute exacerbation. As you can see here, that the patient got into the hospital a couple of times in between 1 or 2 years, correct? Even though the patient is already given the inhaled therapies, which is on a maximum dose. So on the current admission, patient is actually died due to the respiratory failure. Probably some of you have a background of internal medicine or lung specialist. So this is how we actually diagnose patients with COPD. So we started with the algorithm by GOLD. So we have the ABCD, and then we use the spirometry to actually grade the severity of the COPD. Classically, we use chest X-ray to determine whether this patient have emphysema or not. But on a recent publication and guidelines, actually already 10 years ago, there's actually a beautiful use of chest CT for COPD patients. This is best to predict whether the patients have patterns of emphysema like centrilobular emphysema, panlobular emphysema that actually distinguish the therapy, right? So after we actually establish the diagnosis, we give the patients inhaled therapies. We can start with LABA, we can start with LAMA or LABA or LAMA, and then we combine with inhaled corticosteroid. But the most important thing, not only the inhalers, but we also suggest the patients to do a pulmonary rehabilitations. So this is actually quite a comprehensive treatment for patients with COPD or severe emphysema in Indonesia or many countries in the world. But the question is, the quality of life is actually declining. So we need to come up with a better solution for the patient. Isn't it correct? We need to come with a better solution for the patients. So one of the solutions introduced more than 60 years ago by Brantigan is lung volume reduction surgery. So this technique is actually will take out the diseased lung or the most diseased lung, and then we're hoping that the more healthier lung will actually expand and take up the space for the diseased lung after surgery. But the development of the treatment in patients with COPD give us actually better treatment, less complication. Patients with lung volume reduction surgery will have some major complications, right? Like infection and so on and so forth. But bronchoscopically treatment will give us less complication, less days in hospitalizations after the treatment, and it's already proven to increase the quality of life in patients with COPD. So this is the current actually treatment for COPD patient. But the thing is, the question is whether we already give the right treatments for the patient or the right treatment is already too late for the patient. All right. In the case that I presented to you before, I think we already give the right treatment. There is an option, but it's a bit too late for the patients. So now the current selection for patient for bronchoscopic lung volume reduction is actually based on the 6 criteria. First, how the patterns of emphysema, and this information can only be validated by chest CT scan. Second, how severe the emphysema. The third one, lobar volume. Yes, Doc. I will
please,
only
3 minutes. Yeah.
All right. And a lobar volume, fusion integrity, and vessel volume and pulmonary hypertension. This type of information can be only taken up from the chest CT. But again, in order to establish a diagnosis, we need to use spirometry to measure the lung function, because this is very important. Even though we're going to give the patients lung volume reduction surgery, we still need to perform spirometry. In the era of COVID-19, it's quite impossible to do lung volume reduction surgery based on the spirometry assessment. The reason why this is an aerosol generating procedure. So why we use a chest CT scan? Because from chest CT scan and with an AI, we can actually measure the lobar function at the lobar level. So we can actually measure lung function at the lobar level. This is a very nice publication by my supervisors and my friend in ERS, how they use lung function based on an AI algorithm. So the AI in medicine, especially in respiratory medicine, we use machine learning or neural network to develop the AI. And this is how we're going to do the deep learning and neural network. I'm not going to discuss this in deep, because tomorrow we will have a workshop, we'll especially talk about this. And this is the my PhD work that actually focused on how we're going to use the AI for COPD treatment. And this is a software, as I mentioned to you before, Dr. August, just 1 or 2 more minutes. So this software actually provides us a detailed information about the lung function at the lobar level. When we measure the lung function using spirometry or body plethysmography, it will give us information at the lung perspective, not in the lobar perspective. Again, spirometry and body plethysmography will give us information at the lung perspective or lung level, not at the lobar level. Using AI, we can actually measure the function of the lung at the lobar level. So this is actually why we can actually help our friends, the physician, the surgeon, to actually quantify the lung volume, and then best to select which lobe that we will treat, which lobe we will take out if we're going to do the surgery. All right. So the best treatment for COPD is actually to reduce the volume. And how are we going to calculate the volume that reduced after the treatment? The only way to do it is to use the quantitative CT by AI algorithm. So using this software, which developed during my PhD, so you can actually measure whether you already get a very successful treatment for the patients after lung volume reduction surgery. So before the treatment in this patient, the volume is actually nearly about 10,000 milliliters. And following after the treatment, there's also a decrease about 5 milliliters or 5 cc's. This is already a very nice proof that the patient successfully treated by lung volume reduction. So this is the current situation in Indonesia for today. We actually are hoping that we can use an AI not only for respiratory medicine, but also to guide us in most of the disease, especially in Indonesia. This is the ongoing research in the research group of artificial intelligence and digital health. There are quite the number of AI research that's now ongoing. And here's my conclusion. A version of the Friedman fundamental theorem is actually describing how AI will impact our way to treat and diagnose patients. So this is a very nice statement. The healthcare system with AI will be better than the healthcare system without AI. But once for sure that AI will not replace doctors, but instead will augment them, enabling physicians to practice better medicine with greater accuracy and increased efficiency. I think that's it for now. Thank you, and I'm open for discussion. Thank you very much.
Thank you very much, Dr. Eric, for the inspiring lecture, I think. And we can see that there is a hope because Dr. Eric already showed that the application of AI is already performed in Indonesia. So I think this can be a trigger for other disease that we can use the AI application for the other disease that is still a priority from the Ministry of Health. So we move to the next speaker. Before I introduce the next speaker, I remind for the audience or can also send the question for the panelists and then for the speaker, so we can discuss after later at the last after the last speaker. Now the second speaker is Engineer Muhammad Hanif Nadif, Sarjana Technology. He had education in Delft, Netherlands, and also in Universitas of Indonesia. Now he is a lecturer at Medical Physics Department, and also I think part of Medical Technology cluster in IMERI FKUI. So for Mr. Muhammad Hanif Nadif, please, time is yours.
Right. Thank you, Dr. Agus Hamid, for the time. And for now, I would like to share my screen first. And I hope that I can really do the slideshow properly. Okay, all right. Is it visible for you? I hope, yeah. Okay, so today I'm gonna present about the 3D printed simulators using rapid prototyping for remote medical education during COVID-19 pandemics. Okay, well, usually, actually the 3D printing and rapid prototyping is the same term with two different likes. Some people prefer to use the 3D printing, some people prefers to use the rapid prototyping, but actually these two terms are actually the same. All right, so I think just a little bit profile that has been presented by Dr. Agus. So yeah, beside the lecturer, I'm also a coordinator of the biomechanics research group in the medical technology cluster, IMERI. And yeah, before this presentation, I also have presented this work in the AAHC webinar, Association of Academic Healthcare International webinar about the simulation in healthcare professions, education, and I'm very glad that I can share the panel with the researchers from the University of Minnesota and Harvard Medical School, and also the University in Tehran. So here, I think this is the outline of this presentation. So first, I would just present why these simulators are important in our medical education, and also about the simulator development, and of course the confirmation about the performance in terms of the biomechanics, and also the proposal how to implement these types of simulators in our medical education basis. And the last one is about the recap of this presentation. Right, so we move to the introduction now. And yeah, if we talk about the simulators, or in the archaic version of the term is phantoms. So educational phantoms or medical educational phantoms, we know that it has two types. Like the first one is the virtual simulators, and the second one is the physical simulators. And here, I would like to discuss about the physical simulators that has several advantages. Like the physical simulators have tangible continuum, and also compared with the virtual simulators, it also have physical appearance, and of course mechanical construction and texture and touching sensation and haptic feedback. And the one that the one with the blue inks, actually I think are the most important features about the physical simulators that the trainees, the medical trainees, can also have the haptic feedback due to the texture, and also the physical appearance, and so forth. So yeah, so this is the one that we will discuss. And talking about the 3D printed simulators, we know that there are a lot of simulators that are tried to be fabricated using 3D printing. And here's one of the example of the works. So me and the colleagues from the Department of Urology try to reviews about the development of 3D printed phantoms or simulators, and we found a lot of organs in urology that have been tried to be fabricated as a phantom. For instance, these the prostate cancer model, and also the kidney cancer model, and also the kidney stone. So the researchers try to make a more accurate simulators using 3D printing, and this is only one of the example of the 3D printing technology that has been used in medical education, especially for simulator development. And these are the other examples of the use of 3D printing. So my point here is that the 3D printed simulators have been increased in terms of the use in clinical basis and also in the clinical research. And my take is it is also very important to also utilize this technology in the medical education in Indonesia. So yeah, and if we talk about the existing physical simulators, we know that most of the simulators are mainly focused on modeling the geometrical aspects of the biological counterparts. The geometrical aspects here meaning that the modeling are only in the anatomical point of view, but there's a question: what about the biomedical aspects? So if we see about in the many types of physical simulators, we know that if we want to develop more biomechanical compliant simulators, we require higher fidelity, and higher fidelity means higher cost of production and also higher cost of maintenance. And for instance, it's like the risk to spend more money to get a biomechanical compliant simulators are there. So we try to think how can we develop simulators made of 3D printing that has higher biomechanical compliance but with lower fidelity. So yeah, it means that simple but biomechanically compliant. And if we talk about the COVID-19 pandemic, so this is the data from Indonesia, and we already went through the second peaks of this COVID-19 pandemics, and of course this pandemic have impacted our work, like the PSBB or PPKM that do not really allow us to go to our office fully. Like we couldn't apply 100% work from office policy, and finally, yeah, here still, if even if we are now in the PPKM level 1, there's still kind of restriction not to go to fully capacity office, and this is also the regulation that is applied in our Faculty of Medicine. So we know that we remote learning in that sense, and also we experienced that as well. Almost 2 years that we couldn't really have a in-person education process. So here, like the three aspects, the 3D printing of the simulators, and then the biomedical aspects of the simulators, and we know that the learning and using simulators must be also implemented in the remote learning. So these are the three intakes that pushed the research in this 3D printed biomechanically compliant simulators. So that's I already mentioned about 3D printing, and the biomedical relevance becomes the novel simulator, and yeah, as I mentioned earlier, the biomechanically compliant 3D printed simulator for remote learning. And here, I just want to share a little bit of snap of the simulator development. And first, the step that we do is the 3D reconstruction, either from a DICOM. We can use the DICOM data from the MRI or CT scan, and then afterwards we try to identify the important parameters to be replicated in the simulators, and also the 3D modeling using CAD software. CAD software means computer-aided design software that can allow us to tweak or to modify some important parameters that can be fully taken by the MRI or CT scan. And finally, the finite element analysis. It is basically a mechanical analysis approach to validate the mechanical strength or the mechanical properties of the material that we want to design as the simulators. And these are the modules that we used. Sorry if it is a little bit technical, but I think it's important to also share here that we use two types of modules. The static structural is for the simulation of the mechanical works in a static condition, and explicit dynamic is the mechanical simulation that involves the inertia and also the time factors. And yeah, mainly it's to validate the biomedical compliance of the simulator. And of course, the fabrication using 3D printing and also the molding. So here, as I mentioned, is for the geometrical replication. This is for biomechanical characterization. And also you can use it to select the most compatible material for the simulators. And of course, this is for the realization of the simulators. And this is the 3D reconstruction. This is one of the example of the works. Here, the segmentation of the intervertebral disc model. So here we can see the whole spine, and then finally we have the volume segmentation, and then we get into detail in the segmentation with two steps in B and C, and finally we can isolate the 4 IVD in the spine, and we can get the IVD models from this type of segmentation. And if you wonder the software, it is a free software. It's called the 3D Slicer. And yeah, this is the parameter identification. This is so if the last slide is about the intervertebral disc. So in this slide, you can see that this is a gynecologic phantom replicating vagina. So there is a paper that works with the anatomical identification of vagina using MRI. So they shared a very nice parameter identification of the vagina. So we get the information from that paper, and we know that the vagina has 5 different diameters. And this is the other works about the baby simulators for the application of immunization. So we try to find a most compatible simulator for the immunization process in Indonesia, because the baby size in different countries may differ, right? So here, this is the 3D modeling. So after we get the parameters from the papers or from the DICOM, and we design the 3D models of the simulators. For instance, here, as you can see, the vagina simulators, and this is the cervix simulators using the CAD software. And this is when it's implemented. So this is a mounting that can be attached to the desktop, so you can so that the trainees can easily train their skills in terms of like cervix biopsy and also the vaginal opening using speculum and so forth. And this is the modeling of the mold, since this fabrication not only requires 3D printing but also the molding system. And this is the design of the intervertebral bladis models. So here, as you can see, this is the finite element analysis. This is the example of the works. So here, this is the simulation, the mechanical simulation that was proceeded in the FAA software. So here, the speculum is simulated to enter the vagina model, and then finally the speculum was opened, and then we can compare the real vagina model with the respective properties with the material candidates. So here it's also the cervix model. So there is an explicit dynamic model to simulate the cervix biopsy here. So this is the area of the cervix biopsy, and this is another work to find a better material for spinal phantom or spinal simulators. So we try to replicate or to simulate the forces that were applied on certain intervertebral bodies. Actually, the works are for each intervertebral body.
Mr. Hanif, please, the time 3 minutes more.
Right. Okay. Thank you. Okay, this is the dynamics, and I think I can skip this part. This is the technical approaches of the finite element analysis, and here are the results, and we can determine the vaginal opening, and we can compare it with the respective tissues. And this is also the biopsy simulation, and this based on the finite element analysis, we can determine the materials that are most compatible with the respective tissue. For instance, we get the DS10 silicone rubber. It is most compatible with the vagina tissue and also with the cervix tissue. So here's the 3D printing parameters. I think what we need to do is we try to adjust the parameters in terms of the extrusion width, for instance, and these are the parameters either in the software and also in the hardware. That's my take, and this is the parameters of the molding. And yeah, this is the results. If you want to see, sorry, it is in black and white. And this is the immunization phantom or simulators. So yeah, what about the correlation with the pandemics? So what my take is, how if we install each 3D printing setup in each medical centers, for instance, like this. So every medical centers have at least one 3D printing setup, so that the medical centers can fabricate the simulators and distribute it to the trainees, and the trainees can also try to improve their skills or learn new skills in their house or in their facilities. So this is the proposal of the use of 3D printed phantoms in the pandemics, and even in the post-pandemics, if the remote learning is still applied. So here's the recap. 3D printed simulators for this application have been successfully fabricated, and some of the 3D printed simulators have been tested for to be biomechanically compliant. And I hope that the installation of 3D printing setups can also increase the use of 3D print, the low-cost simulators made of 3D printing. Okay, so this is the works. Yeah, I think, yeah, thank you for your attention, and right back to Dr. Agus.
Thank you, Mr. Hanif. It's very nice talk, lecture, and also showing that the need of 3D printing actually crucial especially in medical education. That's why Mr. Hanif suggests that in every medical center that we hope we can have a 3D printing. For the next speaker is Dr. Tedius Prasetyono, spesialis bedah plastik, rekonstruksi konsultan. He had many fellowship in the United States. Now he's a hand and microsurgery consultant in plastic surgery, FKW RSCM. He also still, in the beginning of Indonesian clinical training and education, he's still chairman until now. So I'm sure he had a very long or a lot of experience, and he will talk about embracing simulation and teleteaching. And please, Dr. Teddy, the time is yours.
Dr. Agus Hamid, thank you very much for the nice introductions. That's very generous. Let me now start my presentations. It's really a privilege for me to be invited here to share some of the experiences. And I have no disclosure with these presentations. And also I would like to start with this first picture just to let us remind ourselves that the simulation is part of philosophy to take care of patients at the best, to provide safety, and there is supposed to be no harm in our medical practice. And whatever providers in healthcare give service to the patients. My talk is just about introductions and also some of the innovations in taking the topic on embracing simulations and teleteaching in procedural skills post-pandemic drive. So I believe everyone understands that the healthcare industry has managed to pop up into very high in the form of e-health. And many stakeholders in our country has come up with the anticipations on how the future of e-health should be embraced in its practice, although the regulations and law is not in line, because we understand in many situations, not only in our country, but also in many countries, that the law and regulations come later. But then, this is not a halting situation for us to start with our innovations. So the healthcare industry should come with advocacy from many stakeholders. That would include the authority taking advocacy, but also the practitioners and also health providers take the advocacy from others. And the good thing with the development of the healthcare industry through this e-health concept, that it comes into equity. A virtual and home-based needs comes into a real, that, health service come at home. I have worked in a remote area for 3 years in the past as medical practitioner, as general practitioner. And I observe myself and experience in my life that many people in the remote islands are away from health access. So with this development of e-health, it comes into reality that, everyone in every angle of the world, of the globe, would get the access through this, digitally enabled healthcare system. And just for taking the information based on the US only, that this e-health comes as high as 3.6 trillion rupiahs. That's a huge amount, and that's annually. So besides that, innovation should come with a concept that works for all, not only for the high level of people or high level of society that could afford the technology. That is also one of the concerns that in line or similar with the equity concept. Of course, the outcome is unquestionable. It should be, at the same level with the in-person service. So at the beginning, as Dr. Agus Rizal has mentioned, I'm part of the ATEC. We have started to use this, platform technology, which is not really that new. But at the beginning of last year, and even, at the end of 2019, we have started to approach patients through this online consultations. And that time, many people were surprised and did not really, know on how to cope with this technology, which is actually started from long time ago. And even this, faculty, when I invited him to give lecture, he is Korean, but that time he was in Bangkok, and to give lecture to everyone in the region in Southeast Asia and some participants also from Asia, he really questioned on how it was supposed to be. Now it ended up that, everything is possible and everything is easy and everyone got into the practice, like common practice. This is kind of like best practice, especially during the pandemic. Our data shows that only until, the end of September, we have conducted 386 webinars. 2% of the webinars were given for lay people, and a total of more than 100 participants has been in our data. So the healthcare industry has shown the embracing concept of telemedicine. Although you could see that, it was picked up during April last year and declined, but then it came into steady. If we calculate, it's already been 36 times from before the pandemic era. So the perceptions by the time it declined was about technology security. But now people has come with the idea that, it's secure enough and it's really compatible to our own life in every social aspect, including the medical practice. So we also got the study to our community. I'm a plastic surgeon, so I conducted the study to plastic surgeons in the early of pandemic that hit our country. It was in April 2020. We asked on how the practitioners, especially plastic surgeons, embrace technology. That time, many are still, questioning, and even some of the people really against about this practice of telemedicine. So the idea of the future flipped medical practice is already in our daily activities. So during the pandemic, it has brought us from the practice just to give service for urgent matters. Now it comes into virtual care to longitudinally chronic diseases, meaning that we could take care of patients with chronic diseases by online. And also with telehealth, with other virtual health solutions is in combinations. Platforms are combined together to make it more comfortable. And so for the future, as some has practiced, the hybrid virtual and in-person care models, which I call it as flipped medical practice, we now has come into the practice to limit the in-person meeting so that the practice could be more effective. If you look into literatures more, then it comes also that the idea of this telehealth, the telemedicine, come into a very good personalized care. So we could also elaborate the practice to a potential use of clinical pathological conference or any case managed by a multidisciplinary team where a patient does not need to visit every single doctors. So just put into the platform, the teleconference platform, for example, which is very easy now. So a patient could be managed by a team. So this personalized care could be combined in person and a telemedicine visit, or I call it as a flipped medical and surgical practice. So the telehealth care industry, an example in the area of sport and exercise medicine, just an example. The community has taken the example of practice in medicine, so then they could embrace the service through this platform. And I believe you all agree that medical schools have had to develop new telehealth to focus curriculum components. And I also would like to bring you into just a brief of history, where at the beginning of the Flexner report about medical education, which started in 1910, that time technology has come up with a quite primitive idea about laparoscopy and thoracoscopy examinations and learning, coming up into the idea where the anatomical course has decreased a lot. And now we see that, from the two previous presenters, we understand that virtual reality, artificial intelligence, and simulators has come up into the influencing the medical educations, the medical practice, as well as the training, of course. All right, so by taking the idea into procedural skills, we understand that, we embrace 7 concepts, 7 elements in teaching procedural skills. They include conceptualizations, visualizations, verbalizations, the practice by the learners, and also the learners got feedback and the chance for the learners to get the skills in mastery level and also by the autonomy. So then the complexity varies. Skills are supposed to be best learned by following a sequenced and stepped approach to teaching. But in healthcare's practice, many procedures are complex. So people start to question whether the 5 model or the 4 steps model of teaching the procedural skills should be always in practice. This is quite, debatable because complex multi-part tasks are difficult to be taught by these 4 or 5 steps models. The 5 step introduced by George and Dodo, and also the 4 step by Peter. But then people have already seen and observed the potential use of the old way of teaching by the 2-step models, demonstrations, and directly with the formulations. If it is not about back into the very old practice of see one, do one, and teach one, but then this is the dialogue in the way how teachers, faculties, and doctors, people, and other healthcare professional practice the teaching in the procedural skills. So the use of simulation has been proven to be associated with better patient care and improves patients' safety. The reason is very simple, because the learners practice the skills in a protected environment where there is no risk of patient harm. And the beauty of these simulations and simulative training is that it could be used also for assessment. We believe that the frequency and repetition is possible by the simulative training, and it also impacts skill retentions. Recall and transferability is obvious to the real clinical environment when the learners start to practice it for the first time to the patients and the subsequent practice. So just for the procedural skills, simulation-based training is important in the aspect of knowledge acquisition for the learner. The learners is also able to see, to observe the procedures, and also deliberately practice using simulations, and also could be part of the competency assessment. And it's also performed on clinical setting under direct supervisions at the early practice of the learner. And it could also be an area for practitioners that needs to be, assessed with the maintenance of their practice. And so this has been in almost all area of medical education, where the area use simulation-based training in its respective curriculum. And this is just part of the activities that we have conducted in our university and in our hospital, in Cipto Mangunkusumo Hospital, where all the simple and difficult tasks has been managed to be given through simulations, including also the simulative training in critical care by interdisciplinary team and by multidisciplinary team to work together. And so just an example where it is not only for doctors but also for other healthcare professionals.
Kemudian pasiennya suruh tarik nafas lagi. Jadi kalau datang kita jangan berusaha memaksa, kita berhenti sampai pasien rileks. Setelah itu suruh tarik nafas, baru kita berusaha masukkan lagi. Karena
this is the case of the practice of teaching for nurses. And of course, the practice like this laparoscopic basic training could be really simulating the real clinical situations. The practice like Dr. Hamid has it in daily work with the laparoscopy could be given into simulations training. Then the learners could really practice and and really mimicking the real situations. And so with other, more complex procedures, including the high-end procedures such as microsurgical training, at the basic, all simulative trainings provide risk-free environment before performing procedures in the patients. And so with other practice in medical field, including the cardiology, internal medicine, pediatrics, whatever. Now, I would like to share a bit about teleteaching and assessment in procedural skills on how we have experienced during the pandemic and could be seen for the future as the post-pandemic drive. In the residency training, including also the training for students, the use of technology is unavoidable. It's really strongly suggested to embrace technology, and we could practice the flipped class model so that every aspect in the cognitive domain could be finished before the meeting. So the in-person meeting could be very limited just for the practice. The online practice questions or a basic competency test could be performed by distance. And so with the telemedicine clinic as part of the training for students and also especially for the residents to follow, to observe the seniors, the faculties, the teachers on how to practice telemedicine. The service is there for residents also. And so with the facilitations using videos, because there are many skills, many procedures that are not available yet with the simulators. So then it is difficult to take that simulators and then the patients needs to meet more than one patient and even 3 to 5 patients to start their first practice on the procedures, such as, for example, a very simple example with this is about the appendectomy. It's not existent yet with the simulator for the appendectomy. But then the practice for the surgery could also be overcome by the use of video. Of course, the VR and the other descendants of VR could be in our practice. So further innovations on simulators are on high demand. I personally am happy to see the previous presenter presenting on how the development of simulators and the models in our own setting. So the online meeting platform gave us limited experiential learning. However, the participation is maximized, for example, through the debriefing. And also the recorded video allows review and share mental model. So then we could, shortcut the steps of procedural teaching in reality. And we could maximize impacts of simulative training across institutions. With this, I would like to highlight the potential of the sharing trainings between centers, between cities, between countries. And so this is just an example where the instructor is in one room and the participants are remotely following the teaching.
Muncullah dia body mark namanya. Muncul di layar body mark yang di situ. Oke. Nah, yang di mesin Mysono itu pakai tombol apa tadi ya? F3 ya? F5 ya? Ya, F5 body mark, ketan F5-nya.
So instead of taking all the participants with the instructors, it's really possible by delivering the teaching remotely through multi-system camera.
Jadi kalau beda sama itu kedalamannya.
Now you could see that the voice comes remotely and the participants follows in different side.
The time is only for 3 minutes more.
Okay, thank you very much for the reminding. And now once again, that it allows interactions between the instructor and the participants. Participants could lively interact with the instructor.
Tali kuning juga. Nih, tali kuning saya kait melalui tali hijau. Lalu saya bawa menjauh. Selanjutnya, Anda lihat ya, tidak melintir ini. Selanjutnya, saya gunakan index finger technique.
And so we could understand that the step of teaching would also combine the verbalization steps. That is simultaneously with the practice. You see that the video is broadcasted remotely and the participants verbalize the procedures while also practicing. Because this could be enabling the shortcut of the steps of the procedures with the teaching. And so it could also be embraced into whatever the procedural skills, including laparoscopic training. And so it allows us with the synchronous assessment. Just an example with this video showing that the learner is remote from in the remote distance from the assessor, and you could see through the different angle of viewing, then the assessor could manage to simulate the real situation when he or she observed directly on site. And so this could be taken, broadly into more than just area in the medical teaching and the medical practice. It could also be whatever practice that could be transferred for lay people, for whatever skills training in farming industry, in whatever. So you could see that, centers with these procedural skills could be developed across the archipelago. And so people could follow the teaching from one side and also sharing between sites of centers. So as a take-home message, the pandemic simulates massive innovations, and the technology is incredibly needed to create effectiveness and efficiency, and the post-pandemic role of simulation is predicted to be more and more important, and the teleteaching and assessment in procedural skills to be included. Thank you very much for your kind attention.
Thank you, Dr. Teddy. The nice lecture that still reminds us that the pandemic triggered many innovation for all of us, and to answer all the question or the obstacle in development of medical technology. Now we invite all the speakers. There are some questions, but I only select one question for one speaker. First for Dr. Eric, based on your experience, because I know that you take the PhD about the AI in UK, what do you think is the obstacle for the AI development or application in Indonesia?
Well, thank you very much for the question. So I think the challenges is actually quite similar to other countries, not only in Indonesia, but specifically in Indonesia. We know we have a lot of data, but most of the data, we're not managing it very well. So it's everywhere. Basically, it's everywhere. So we need actually more time to actually label the data. We need actually more time to cluster the data. So I think that's number one. And number two, we definitely need more expertise. Expert on AI in medicine. And this actually enhance how the collaborations, multidiscipline collaborations. So not only a doctor, but also a computer scientist that actually specialize or focus on developing AI in medicine. And also in the same way, we would like to have like a hybrid human resource. So doctors who actually know how to do the coding, and the other way around, a computer scientist that know a bit of a medicine. So I think this makes two of the challenges that we still face up to this point.
So you suggest that we should manage our data more, how do you say it, more clean, and also collect it more detail, and then after that we develop the AI application for any disease, right?
Yes. And I know some of the hospitals, they already started to use electronic health records. And this is a bright light at the end of the tunnel, because by using an electronic health record, this is actually more manageable. It's more easier for us to use this data and translate it to an AI algorithm.
Thank you. For the next question is for Mr. Hanif. Yeah, Dr. Teddy.
Yeah, I would like to add one more point in seeing this obstacle, that we have the regulations of not easily collaborating with the international world, where actually experts are there and they are actually very curious to also come to Indonesia and have the collaborations with his AI research and also with the development. But then we have to be aware of our law that, we cannot be easily in the collaboration because the data needs to be really protected in this country. This is at one point is very secure for us to make sure that we put our big contributions in the development with the international collaborations. But also this is one of the obstacles.
Okay. Thank you for the reminding about the law in Indonesia for AI application. For the next question is for Mr. Hanif, that we know that the 3D printing is need a material. Do you think that all the material that we need for any 3D printing is available in Indonesia, or we still import the material, and also it makes the price is more expensive than if we can have all material in Indonesia?
Right, it's a very interesting question actually. So basically there are a broad types of 3D printing, but the most common 3D printing that we see is the FDM, fused deposition modeling. And this one is not patented. So the inventors of this technology decided not to patent this invention, so that the price of the 3D printing is lower. So that's the first thing. And then the material itself, it's also cheap for this filament for the FDM. But the unfortunate thing about this technology is, even if it is cheap or low cost, we still import this technology, either the machine or the materials from China or Europe, but the cheapest one are from China. And for the filament itself, you can get the 1 kilogram of filament with only 300,000 rupiahs. And the cheapest machine, I think it's around 3 million rupiahs. So even if it is imported, yeah, you can get it cheap. But the saddest thing about this development in Indonesia, so there used to be a company producing a local 3D printer, but for now, in my knowledge, the company is closed. So yeah, we still need to import all the machines and materials, but we can get it in a cheap price.
That's a pity.
Yeah, that's a pity. For sure. Yeah.
I hope next year they will be open again, and then we get all the material in Indonesia.
Yeah, hopefully.
For Dr. Teddy, it's interesting that this pandemic, we have an innovation for the teleteaching, but when we look at the video, actually we need more equipment for like a camera or something. Is it make more difficult or also expensive for the development of this teleteaching? So how do we manage this to make we don't have to expend much money for any more equipment?
Thank you very much. Yeah, that's a very important issue about this teleteaching in procedural skills, because we need camera. And so with the other necessity is available, we have embraced into the use of the very simple platform with a video conference platform. And so with the system to broadcast the multi-sources data, but then the camera. But however, if we look into a medical school or a faculty, the investment should be seen as cheap. I mean, affordable, because we could, try to use the existing camera available in the market. I would say that in one site, one room, to just make sure that we are connected through our camera system with the same interface, then let's say not more than 50 million to say that, you actually really equipped with all the fully equipped with the system, then that's very cheap. Like in our faculty, then we could develop, let's say 10 or 20 even sites, so that to allow all multidisciplines to go online with teaching. So students could be distributed into 20 different sites, and that's really affordable. But on the other side, I would welcome the expert in technology to help us with a system so that we could develop our own system, integrated system with this multi-camera system so that we could come up with a product from ourselves. Thank you.
Thank you, Dr. Teddy. Yeah, maybe in the beginning we thought that's expensive, but after we use it regularly and more income because of the education or workshop, I think they will overcome the price that we spent in the beginning. I think last question for Dr. Eric. Sometimes for the medical doctor, it's quite difficult to say or think about the AI. So how do we start to apply or to develop AI? So what is your suggestion for medical doctors? I mean, we are clinicians, so we are not data scientists, but we are interested in the AI.
Yeah, thank you. That's a very good question. So I think it always starts with what is your research question? And the research question should be based on what's the gap in science. All right, let's say, so you need to find what is the gap in science. Let's say for respiratory medicine, on my presentation, I actually give an example that there is a lack of patient selection for COPD. So that's the gap in science. And in order to actually increase the patient selection for better patient outcome, that we can use AI. So always start with the research question and what's the gap in science. I think that's the best answer.
Okay, thank you. And also, I have a reminder that from our cluster, medical cluster, that tomorrow we have post-conference workshop, artificial intelligence, what can it do for your medical research? So I think for all the few participants who wants to join, that we started because we try to make this workshop very early in the beginning. How do we start? So I think before we can present the data like Dr. Eric present, I think we start to do small thing and then how to develop into the bigger and also nice AI application. Due to time, thank you for all great speakers that give us the insight that actually the innovation should continue, especially after the post-pandemic, because we know that there are many disease or any obstacle that we should overcome. And for sure that we hope that we can increase our services to our patient and then they can increase their quality of life and outcome. So I would bring back to the moderator. Thank you very much for all attention. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
We are going to have a special lunch symposia with the topic, the effect of drinking water quality for overall health. In this session, during our lunch, I'm going to invite Dr. Wijaya Lukito, PhD, Master of Nutrition, Clinical Nutritionist Specialist. Dr. Wijaya Lukito has finished his medical degree in Erlangga University and then graduated his PhD in medicine in Monash University. And he is currently active in Indonesian Danone Institute Foundation as the chairman. To Dr. Wijaya, if you are ready, the stage is yours.
Okay. Thank you very much for the introduction. Let me check whether you can hear my voice.
Crystal
Hello?
clear, doctor.
Okay, thank you. Yeah,
Very clear, doctor.
Okay, thank you very much. So, well, first of all, I would like to warmly welcome you to this lunch symposia, which I think it is also very important on the issue on water and hydration and health. So let me greet you all. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. Let me give you one introduction that water and hydration are two sides of the same one coin. So what does it mean? So our hydration status is very much dependent on the water consumption. And likewise, water intake, if we have an adequate water intake, that would lead to better hydration status of our body. So these are two issues that are mutually dependent in our daily life. And certainly, if we want to improve our water consumption and hydration status, certainly we need a good quality water to achieve our better health status. So this is clear that now for the more than 1 decade, actually water and hydration has spanned beyond physiological status, but also reached to various health and medical dimensions. So we are very honored to have two prominent speakers in this area. So allow me to introduce two of them all together, and then we can just proceed with the presentation. The first speaker, Dr. Diana Sunardi, my very kind and good colleague. She is actually a clinical nutrition qualified specialist in the area of nutrition and clinical science. And furthermore, she is the chair of the Indonesian Hydration Working Group in the Faculty of Medicine, Universitas Indonesia. She is a senior faculty member at the Department of Nutrition, Faculty of Medicine, Universitas Indonesia. The second speaker, certainly I also have known her quite a long time, more than 20 years, Professor Ratih Dewanti Haryadi. She is a PhD graduate in food microbiology, University of Wisconsin Medicine, United States, and her current position is the professor in food microbiology, Bogor Agricultural University, head of food science study program in Bogor Agricultural University, and senior scientist at the Southeast Asia Food Agricultural Science and Technology SIFA Center, hosted by IPB. So I would like to invite the first speaker to make her presentation, and the time is yours for 20 minutes, if I may guess. Please, Dr. Diana.
Thank you very much, Dr. Wijaya Lukito. Please to the administration, secretariat of committee to help me.
Thank you, Dr. Wijaya, and I would like also to thank the committee to let us share on hydrogenic science. Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Today, I will share the role of water to health, and especially on drinking water and the type of drinking water. Our topic will be on the role of water, healthy hydration, and the impact to health, and the myth and fact on water type. First of all, of course, we will talk about the role of water in human body. As you all know, water is the major constituent of all human body. That is why water is essential for life. And maintaining optimal level of hydration is important for humans to function well, as water is important to support vital function in the body. 50 to 60% of our body is water, and many organs contain water,
more than 70%, such as brain. Water in our body distributed intracellular and extracellular. Total body water percentage differ in each stage of life, and age is not only the factors that affect total water need. Other factors such as gender, activities, climate, health condition, and also food intake. It is important to maintain body water balance to have normal hydration status. Therefore, we have to pay attention on how much we drink throughout the day. We gain water not only from what we drink, but only a few we can get from what we eat. Food provides only around 20%. And we lost water not only from urine, but also from sweating, respiration, and feces. Healthy hydration and the impact to health. As we drink throughout the day to maintain our hydration status, we have to pay attention on what we drink. Drinking other than water can contribute to intake of calories, and then the calorie may excess the requirement of calories for our body. That is why drinking water becomes a concern, because it may also affect health. We all know that obesity is increasing right now, and drink as well as food has become part of the source of calorie intake. And if we do not drink enough water, we can get also dehydration. And mild dehydration has been significantly impair cognitive function. In the hydrogenic science, we divided the dehydration effect on our body into short-term impact and long-term impact. The short-term dehydration may cause poor cognitive function, headache, fatigue, low mood, and also dry eyes and dry skin. In long-term effect, studies have found that dehydration may cause poor kidney function, such as UTI and also kidney stone. And last but not least, also its impact on the non-communicable disease such as hypertension. There is strong evidence showing that good hydration reduces the risk of NCDs and other chronic disease. Good hydration reduces the incidence of constipation, exercise asthma, hypertonic dehydration in the infant, and hyperglycemia in diabetic ketoacidosis. Good hydration is associated with reduction in urinary tract infection, hypertension, coronary heart disease, thromboembolism, and cerebral infarct. Also conditions such as cancer in the bladder and colon. Studies in Indonesia found that 1 out of 5 children and teenagers still do not drink enough, while in adults, 1 out of 4. In pregnant and lactating study, we found out that 2 out of 5 pregnant women is not drinking enough, while in lactating women, 1 out of 2 mothers did not drink enough. Water is macronutrient. Why? Because water is the most consumed nutrient. In 2013, water has been included in the Indonesian nutrition pyramid and also in nutrition guideline. So the recommendations for daily intake are divided according to age and gender. In children, 6 to 7 glasses a day. In adults, 7 to 8 glasses a day. For pregnant and breastfeeding mothers, don't forget to add 1 for pregnant woman and 3 glasses for breastfeeding mother. While in elderly, they need around 6 glasses a day. Water is essential. We know that water is essential for transporting nutrients, eliminating body waste, maintain body temperature, and also for reaction, metabolic reaction in our body. So, what does the water we drink become in the body? We have to know that water reaches the blood cells within 5 minutes of ingestion, and water will stay around 10 to 50 days in our body. That is why we have to pay attention to what we drink. And do all beverages hydrate the same way? Let's see. First of all, for soda, it might hydrate us, but remember, soda usually contain a lot of calories, mainly from added sugars. What about tea and coffee? Tea and coffee do not cause dehydration, but it may cause us to urinate more. While alcohol, we found out that it does cause dehydration. What about functional sport drink? It may hydrate us, but some sport drinks contain a lot of sugar, so it means more calories for us. What about milk? Milk contains 80% of water, but it also contains fat, protein, and also, of course, carbs. And it will be needed some time to be absorbed. So, water, in fact, is the healthiest way to hydrate, as it is the only food our body needs. Let's see the myth and fact on water type. In Indonesia right now, the 4 most common packaged water in our market is mineral water. Of course, it is naturally found in the earth. And the mineral water, it is processed through distillation, reverse osmosis, or deionization. And also oxygenated water. It is a mineral or demineral water with added oxygen in it. And also alkaline water. Alkaline water is water that is processed through electrolysis, ionization, or adding some salt on it. The problem is the impact on health of this water type usually according to testimonial basis, not on evidence-based medicine. So there lack of scientifically fact on it. Let's see. Drink mineral water every day is not good because the mineral will stay as sediment in our body. Of course, this is a myth because the fact mineral in mineral water is important to fulfill our mineral needs. Although, of course, the food is the main sources for our mineral. And then next, drink the minerals water every day helps to make you healthier. This is a myth because the fact is consume the mineral water in the long term is not recommended. WHO already said that long-term consumption of the mineral water will increase risk of diseases. Alkaline water will increase your pH body. Of course, this is also a myth. The fact is, alkaline water will not increase your pH body, as the water will adapt stomach pH after consumption. Oxygen water can improve physical performance. This is also a myth, because the fact, no scientific evidence oxygen can only provide by respiratory organ, not by digestive system. Next is, you only need to drink when you are thirsty. No, it's not the truth. The truth is you need to drink regularly throughout the day, as when you are thirsty, you might already be dehydrated. Thirst is a good indicator on how much you should be drinking. This is also a myth. The truth is, thirst is a late marker and may mean you are already dehydrated. It's better to look at the color of your urine. The lighter, the better. Everyone has the same thirst sensation, no matter how much they drink. This is a myth because people with a high amount of fluid intake tend to be thirsty more often, even if they are well hydrated. So, the tips for a healthy hydration is: first, do not trust your thirst. Don't wait to be thirsty to have a little sip. Thirst is an alarm signal. It means you may already be dehydrated. If you feel headache, you may drink a bit more. And keep an eye on your urine color to be sure you're well hydrated. The better. Remember to drink throughout the day to compensate for water losses and maintain an optimal hydration. Make a water pot. You may add a slice of lemon, cucumber, or orange, and you may also use sparkling water and fresh herbs. And visual memo may also help you to remember to drink. Keep a glass of water in different places. Keep it nearby you. Regular sips. Have a regular sip during a break or before a big meeting. When you keep breastfeeding, create a hydration moment. In the morning, start and finish your day with a glass of water, up on the right foot while hydrated. Start each meal with a glass of water. Each time you have a sip of water, have an extra one. And tips for healthy hydration: limit your caffeine and diet beverages, especially when you're in pregnancy. Sweeteners can also be transmitted throughout breast milk. Avoid alcohol. Drinking more water can help limit your constipation and urinary tract infection. Water is a healthy choice of all time. Make the water your first choice to hydrate. Water is the best choice. Water is the only fluid the body needs. Set the table for meals with only water. So next, soon, IMERI Indonesian Hydration Working Group will have apps on Hidrasiku. It will be launched soon, and it will help us to calculate our daily water need and also keep tracking on how much we already drink on a day, and also some tips and reading on hydrogenic science. And soon we will try to make it able to screen our daily urine. So please come to our website for information on hydrogenic science, and you may also download here material for any kind of hydrogenic science. In conclusion, hydration status must be maintained with a good quality of water, and natural water is good enough for our health. So please come to our website at ihwg.org.id and also join us in our social media in Instagram and also Twitter. Thank you very much, Dr. Wijaya. We'll give the time back to you.
Okay. Well, thank you very much, Dr. Diana. Very nice review on water consumption and hydration status. Now, let me invite the second speaker, Prof. Ratih Dewanti Aryadi. The time is yours, about 20 minutes.
Okay.
Please. Thank you.
Thank you, Dr. Wijaya Lukito, for a nice introduction. I would like to share screen. I haven't made any tapings, so let me share my PowerPoint first. Okay, can you see it well?
Yeah, good.
All right. Okay, so first I would like to thank the organizer for having me in this lunch symposia, and following Dr. Diana's important talk on the health, I would like to share a presentation on the how to make or how to produce quality and safe drinking water at home. Okay, so we will be talking about several issues here as I outlined. And I would like to start with the definition of drinking water by Codex. Drinking water has to be a water safe to be consumed directly, including natural mineral water and bottled water, whether it's carbonated or not. Those are the definition. And in Indonesia, drinking water is set for a requirement by the Ministry of Health, that is regulation number 492, on the requirement for quality of drinking water, which include requirement for its safety and the left, and also requirement for its quality. So this is probably similar or to public drinking water internationally or tap water. Meanwhile, the bottled drinking water in Indonesia is regulated by another set of regulation that is from the Ministry of Industry, 78/2016, and just revised 2019. And it's also set in several different requirements, whether it's from the National Standardization Agency or for the contaminants is also set by the BPOM or National Agency for Drug and Food Control. So here it is. You can see also the requirement for quality and safety. And as you might see here, it's slightly different from the previous requirement. So where do people in Indonesia got their drinking water from? According to the Center for Statistics Agency, or BPS, Indonesian people got their drinking water from the packaged water, 31%, pump well, 15%, protected well, 21%, and tap water, that is the drinking water or public drinking water, 11%. These water are generally processed from surface water, that is lake, river, ponds, etc., or groundwater, whether it is shallow groundwater or the deep groundwater. The two sources of water have different characteristics, or I could say three of them. Surface water, such as lake and river, generally has a fluctuating quality due to rain and air and climate, and therefore it is less consistent, including their microbiological content. Meanwhile, the shallow groundwater generally has more stable quality than the surface water. It has a lower number of microorganisms. However, sometimes it can be contaminated by human activities as well as industrial or agricultural practices. Of course, we can find the naturally occurring minerals in the soil. In contrast, deep groundwater generally are safer in terms of the above surface contamination because it is protected by impermeable layers of rocks. However, of course, the nature of the mineral is also depend on the location or the area. So these are another data from Drinking Water Indonesia. Quality and safety of water is usually measured by Water Quality Index, and the data from the BPS, the Central Statistics Agency, showed that 10 out of the 34 provinces in Indonesia still have poor water quality because of various contamination. In fact, 7 out of 10 homes still consume water from infrastructures contaminated with E. coli. This is the indicator hygienic microorganisms. So what are the pollutants or contaminants commonly found in water? Generally, in terms of food safety, they are categorized as physical hazards, biological hazards containing various pathogenic microorganisms, viruses, protozoa, and microbial bacterial, as well as chemical that can vary depending on where the water is originated. We are aware that not all of the contaminants can be detected by human senses, and they can be harmful if exceeding the safe threshold or safe limits. We all acknowledge that microorganisms generally present in water because it comes from air, soil, waste, etc. There are naturally occurring microorganisms in water that is dictated generally by the nutrition or the mineral content of the water. However, human activity usually contribute to the pathogenic microorganisms. Viruses such as hepatitis or polioviruses has been associated with water, as well as several other bacterial pathogens as mentioned in the slides. And of course, protozoa such as Cryptosporidium, Entamoeba, Histolytica, Giardia lamblia, et al., etc. So with all of these microorganisms, we can measure all of them for measuring their quality. Therefore, generally you will find the coliform or E. coli requirement because they are considered as the indicator microorganisms. Okay, so what are the risks of pathogens and chemicals in drinking water? In Indonesia, the data from the Ministry of Health suggests that the most common contamination in drinking water are pathogenic microorganisms, especially bacteria such as pathogenic E. coli, Salmonella, and Shigella, which causes gastrointestinal problems. But hepatitis virus is also commonly found. This can be related, for example, with the data that the fact that 1 out of 10 children below 5 years old are suffering from diarrhea, and diarrhea is still one of the fatal diseases for children below 5 years old. In terms of heavy metal contamination, it's occasionally found, and they can accumulate in a human body, causing health problems and may affect fetus and pregnant women, as well as babies' developmental health. Okay, here are some of the data showing outbreaks related to drinking water. This is public drinking water, like our pump here or tap water. In the US, parasites has accounted for about 18.4%. While non-Legionella bacteria is 13.6%, and chemicals such as fluoride is 10-something%, 10.8%, and viruses are the main or the majority causes of these outbreaks. In Israel, there's a report on the large outbreak involving 8,000 cases due to Shigella sonnei, and also 2002 in Spain. The same bacteria causes about 756 acute gastrointestinal diseases, and 181 of the samples are positive for Shigella sonnei. What about bottled water? Bottled water also has been reported to cause diseases. This is a bit new, but 5 years ago, a large bottled water outbreak associated with noroviruses. We all learned noroviruses is the emerging foodborne pathogen, and they are not killed by chlorination. And then bottled water recall in US, actually the report is in Canada, I believe, but the manufacturer is in California, and they recalled about 3% of their production, thousands of bottles, because of the warning presence of the E. coli in the source of the water. So it's not even in the bottle, but because of the source is contaminated, so most of the bottle then withdraw. Here are the data from the US also suggesting where or at what point water are contaminated that result in contaminated bottled water. So they may be contaminated at the water source, or during the bottling, during the production, can also be contaminated during shipping and storage, as well as at the point of use, so at the consumer or retail point. There are also several cases in which point of contamination is not solved. Okay, so how do we process drinking water? So we all know that drinking water has to comply to a certain standard because it has to be accepted aesthetically and also safe. So aesthetically generally relate to quality, and safe is usually related to the presence of chemical contaminants as well as the pathogenic microorganisms. In general, processing of drinking water actually aim to reduce about 6 log of Cryptosporidium parfum, but the approaches that will be done can be categorized into two things. You can have one-step process that will inactivate 6 LOX, or multiple barrier processes, that is more than one process that each probably kill less than 6 LOX. Multiple barrier processes is generally preferred because it can lead to a reduced potential of total failure of a process. And we all know, for example, boiling can be considered as a multiple barrier processes that is effective in inactivating microorganisms, but usually they are not working for chemical contaminants. Here are several steps generally involved in drinking water processing, and I think we have to mention the sentence in the beginning. I have to mention this. So what dictates the treatment are generally the amount or the types of contaminants in the drinking water source. So the amount and the type of contaminants will determine or will dictate the type of treatment needed to make the water safe or to make a drinking water. So you can have one or two or all of these processes to produce a quality and safe water. Here I mentioned aeration, coagulation, ion exchange, chemical coagulation, and then disinfection, filtration, and absorption. So depending on the quality of your source of water, you may use all or some of them. Okay, so what are the critical steps in drinking water processing? There are 3 that is generally mentioned in the literature. First is the maintenance of the water source to prevent the contamination or high contamination of your initial water. And then the disinfection, because these steps aim to kill all of the unwanted microorganisms. And then also remove all of the unwanted amount of chemical contaminants, and then the packaging or post-disinfection handling to reduce or to minimize the risk of recontamination. Okay, so to obtain a quality and safe water drinking, we have to consider several things. Contamination can occur at source, during manufacturing, during transportation, or even at the point of consumption. Therefore, to achieve good quality of drinking water, water must be protected against contamination throughout these processes. A good quality of water from the source may only require minimum processing, thus maintain the natural mineral contents. But if you have a poor quality of water, you may need more complex processing and disinfection that may lead to the disruption of the natural mineral water and generation of disinfectant byproducts. Some processes even able to remove all of the natural mineral presence. Okay, I would like to link a little bit with what have been mentioned by Dr. Diana. So if drinking poor quality water may have impact to health in short term or long term. If you're drinking water with pathogenic bacteria or viruses, you can have immediate illnesses, which may lead to loss of productivity. For example, sick leaves, you have to leave work, and you may have to cover the hospital costs. The risk of consuming poor quality drinking water contaminated with hazardous chemical, for example, heavy metal, may accumulate in the body and impact quality of life, long-term effect. And I think I would like to reiterate the previous speakers. Human body consists of 60 to 70% of water. So it is very important to have a good quality of drinking water at home as an investment for our health. I think that's all. I hope I don't exceed the time allocated for me. Thank you so much. I'll get back to you, Dr. Wijaya.
Okay, thank you, Prof. Rati. So actually your presentation is quite, less than 20 minutes.
Oh, thank you.
Based on my timer, so we have more time for the discussion. Well, actually, I have 2 points of concern and issue to be discussed. Yeah. For Dr. Diana, for example, if we look at the thirst, thirst and hydration. Thirst is actually the subjective feeling, in our body. Yeah, But then you mentioned about the urine color, which is actually much earlier happens before we feel thirst. But then, this thirst and hydration science already advanced very much. It's now concerning about the osmoregulatory function. That's number one. So the same osmoregulatory function will detect thirst much, before, the time when we feel thirst in a subjective way. Now, the fourth regulatory function will be the metabolic regulatory function. So, as we all know that, the vasopressin expression, when we have, early mild thirst, where in a mild form, the the copeptin level, the indicator of vasopressin, increase. So those 4 points that I would like to raise, and I would like to have your response on this. The second issue, Prof. Rati, you mentioned about the chemical contaminant in water. But now there is emerging issue of microplastic contaminant in water. Yeah? So we know that plastic waste is everywhere. President Jokowi in the COP26 committed to reduce the carbon emission. So I would like to have your idea or your response on the update information on this microplastic contamination in water and how it would affect, the way we process. Because I think this is very, very urgent issue to be discussed, especially in the Indonesian context. We know that the COVID pandemic, still happening. It is slowing down now, but I hope it can continue to be, eliminated, hopefully. But then we, it's not yet been discussed at national level how we handle the plastic waste, of all this, the equipment, instrument, the APD, during COVID time. So it's going to be a very, very, very high disaster. It's a high density of plastic waste in Indonesia due to this COVID pandemic. So I would like to have your update information on this, please. First, Dr. Diana. Thank you.
Thank you, Dr. Wijaya. Yes, as we all know, this copeptin and vasopressin is one point that we talked lately in our meeting in Hydration for Health, right, Dr. Wijaya? But we know that thirst is something subjective that we can feel. Simple as that. We don't need to check our osmolarity, or blood osmolarity, or even our vasopressin or copeptin. But as the thirst or thirsty is subjective, then like I said in my presentation, maybe it will be differ from one person to another. If their water intake is good, they usually more easily to get thirsty. But if their water intake is not good, they tend to not getting thirsty easier. And for urination, we urinate more if we drink more. And that's another objective. If thirsty or thirst is subjective, then urination will be objective. So it will be easier for us to ask our patient to see or look for their urine. That is why our campaign for hydration for health or the hydrogenic science, we usually ask for the urination or the urinate color to check how does the drinking intake all day long. That is why, Dr. Wijaya.
Okay, thank you, Dr. Diana. Prof. Rati?
Okay, thank you, Dr. Wijaya. I realized I did not write much about microplastic. There are a lot of ongoing studies on that. Even the definition also still range. Some say it's less than 5 millimeter, but there are many studies has been able to detect up to 1 micrometer, for example. But that will be something that is a challenge for us. So the microplastic apparently mostly coming from the surface runoff, and it's usually from degraded plastic, very likely or possibly coming from the packaging, right? It was not managed well. So there are probably many approaches or a lot of holistic approach that has to be done. You can first make sure that the plastic handling or the management of plastic is done correctly so that people are not throwing plastic in the land or inappropriately, that one. And then probably reduce the use. For example, for single use, that probably has to be reduced as much as possible. We all know the movement has been starting in Indonesia. I think people are now using less, for example, straw, etc. But yes, I think now with the pandemic, I realized there are a lot more plastic coming out. And also from the food deliveries, I mean, not only from the medical standpoint, from the food deliveries. So I think industry has to make their part, but also I think for the plastic waste management, I think has to be done collectively by, for example, pemerintah daerah or cities or something, because that's something that right now we don't have data for Indonesia much. I know some of our colleague in Ministry of Fisheries has started some research, but I don't think I have enough data to say the level of contamination in Indonesia, but we can predict by the probably behavior of people that are not only plastic, but any trash are just thrown away. That can be a source of potential contamination. There are several studies done, in particular in the Ministry of Fishery, because they want to see the quality life of the fish. But I think we also have to know what it will impact us as a human being. I think I don't have a data in terms of number for Indonesia, especially. There are many studies abroad that suggesting quite high contamination of plastic, of microplastic. I hope that will answer.
Yes. Okay. Thank you, Prof. Rati. It seems that we don't have, questions from the audience. So, but I do not mind because this is going to be our three-partite discussion between the speaker and then the moderator. Now, I have a second round of issue. So please, I would like to remind the committee, if the time is up, just let me know, because we are we are going to a kind of a deep discussion on this. Now, Dr. Diana, in your presentation, I like the idea of sip drinking. Sip drinking. Why this is important? The sip drinking is a kind of a concept. In the beginning, the concept was developed for the geriatric nutrition. Because why? As we become older, then because of the cognitive decline and neurological decline, then we often forget whether we have drunk enough or not, or we have eaten enough or not. So that's why the concept of sip feeding was developed at that time. Yeah. So it doesn't matter, regardless you sense hunger or not, or you sense the thirst or not, then just please apply the sip feeding and sip drinking. So it has been the practice, the best practice of very good nursing homes in applying the sip feeding and the sip drinking mechanism. Now, in your application, Hidrasiku, because you flip only part of that application, I'm just wondering whether you also include, especially for the elderly population, tersisa another 5 minutes, whether that include for the aged people, for the elderly people, whether they apply the sip drinking, mechanism. The second issue which I want to raise to Prof. Rati is I'm very interested in the parasite contamination. Yeah. So you have highlighted, Shigella, and perhaps there are other parasites contaminating the water. Why this is now very important? Because in clinical science, apparently the parasite infestation in our body for long-term infestation or long-term infection, it would raise the issue of inflammatory bowel syndrome. This is one of the issues. Yeah, there are many issues actually. So I would like to know from you, to what extent the parasite contamination, and then whether you have the data on the those infected with parasites from water sources. Thank you. Please, Dr. Diana. We have only, I think, around three or more than 3 minutes, so maybe just concise response on this.
Okay, thank you very much, Dr. Wijaya. Yes, thank you for your interest in our apps. The apps, like we know that drinking is better regularly, each 1 or 2 hours, not drinking at once time in a lot of water. So the apps will give the recommendation how much you have to take your daily drink by age, gender, and also activities. And also the alarm setting for the time that you have to take your drink. We can set it according to what we want. Is it every 1 hour or every 2 hours? So the apps will beep and we'll know that it's time for us to drink. Like that, Dr. Wijaya.
Good, thank you, Dr. Diana. Prof. Rati?
Okay. So when you say parasite, that probably involve bacteria and protozoa and also viruses. Is that what you meant? Okay, yeah. So actually for bacterial contamination, there's no link or direct associated with water, but with foods, which probably include the beverages they drink. We have few data, several old references suggesting, for example, Vibrio cholerae, Shigella, and also Salmonella are the main 3, and enteropathogenic E. coli are the main 4 associated with foods or with human diseases. In terms of processing, the good news is even boiling will be able to kill them. But when you process with the non-heat boiling or non-heat processing, such as the one I mentioned in the slides, then we are dealing with some of the protozoa and viruses that are not killable by chlorine. So use of membrane filtration, that's the only probably way to go. So, but in Indonesia, there are also data on parasite and suggesting that many children above 3 also include the expatriate, generally harbor this protozoa. So probably we are, I would guess, hopefully my guess is not too wild, but I would guess that we have quite a bit of contamination of that, and if that will lead to the IBS, well, that could be. So I hope we can reduce that by providing a safer water.
Good. Thank you, Prof. Rati. So the time is up. So I would like to thank, the two speakers, Dr. Diana and Professor Rati. Very well done, which color significantly this lunch symposia. And I would like to return back to the committee. So in the end, let me greet wassalamualaikum warahmatullahi wabarakatuh.
In concurrent session 11, Dr. Vita Silvana has finished her medical degree and also obstetric and gynecology specialist at Universitas Indonesia. She is also an active obstetrician and a lecturer in Dr. Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia. Dr. Silvana.
Halo, Dr. Dinda. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Doctor, the time is yours.
Thank you very much for the time in this session. Thank you very much for the time. This session, we are going to talk about the experience in dealing with high volume cases in reproductive medicine, in endometriosis, PCOS, and abnormal uterine bleeding, which we will have three speakers. The first speakers will be Dr. Kanadi Sumapraja, OBGYN consultant, Master of Science, and the second is Professor Dr. Andon Hestiantoro, OBGYN consultant, MPH, and the third speaker will be Dr. Ahmad Kemal Harzif, OBGYN consultant. This session will be divided into 20 minutes talk for each speaker. The first speaker is Dr. Kanadi Sumapraja, OBGYN consultant, Master of Science. He finished his degree in Master of Science in Human Immunity, Faculty of Medicine, University of Liverpool in 2005, and continued his degree in Reproductive Endocrinology Infertility Consultant, Universitas Indonesia in 2012. And finished his doctoral program in Faculty of Medicine, Universitas Indonesia in 2019. He is currently staff at Department of Obstetrics and Gynecology, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo General Hospital, and also senior researcher at HRIFP cluster in IMERI. Dr. Kanadi, the time is yours.
Thank you very much, Dr. Vita, for your nice introduction. Our permission for sharing the slide. First of all, thank you very much for the organizing committee for inviting me to give a talk about how to prevent delayed diagnosis of endometriosis through symptom and risk factor identification. This is a lesson learned from our endometriosis patient who are being treated at our outpatient clinic, especially in the endocrinology outpatient clinic at Rumah Sakit Dr. Cipto Mangunkusumo. First of all, I would like to remind us again that endometriosis basically is kind of disease that has been associated with the chronic inflammatory reaction. And I think every expert in the global already agree with this standing point. So therefore, this condition basically can give consequences on the progression of the disease and also recurrency. So therefore, it will be required a good strategy on dealing with this situation. So I think if endometriosis can be classified as a chronic inflammation with progressive and high recurrence rate, so basically we need a very good strategy. So therefore, our patient can have a benefit when they're being treated with us. So first of all, I just would like to remind us again about what is the meaning of having chronic inflammation. As we can see that inflammation itself basically is a very physiological reaction when the body encountered the harmful potential agent that going inside our body. And basically, the acute inflammation process itself should be under control. So when the threat is already disappeared, then the inflammation is supposed to be stopped. But unfortunately, in some condition, the inflammation is still carry on, and we have to see there will be a consequences if the inflammation process become chronic. The first consequences when the inflammation process become chronic is the tissue damage, because inflammation itself will create many products that is very harmful to the tissue, and at the end the tissue will have a damage. So if the tissue become damaged, then there will be a reduce in their function. On the other hand, when there is a high inflamed area in the tissue, so there will be a shift, changes in terms of the nerve fiber. The nerve fiber will turn out into a sensoric nerve fiber, and with the changing in the kind of sympathetic nerve fiber as well. And this kind of nerve fiber basically will give consequences when the inflammation will carry on. So therefore, learning from this basic of chronic inflammation, we can conclude that if we have a prolonged inflammation process, then there will be two consequences: tissue damage and sensoric innervation. I think it's very matched with our endometriosis patient, because most of the endometriosis patient will suffer from pain, probably because there will be a lot of sensory nerve fiber come into the endometriotic area, which is the area that really very high inflamed, and also by the consequences by prolonged inflammatory process, then many tissue will damage, and this kind of damage probably can cause clinical consequences like infertility and also other conditions like chronic pelvic pain. And as we can see that why most of the experts say that endometriosis is a chronic inflammation and have a progressive attitude, because when they try to encounter the endometriosis disease in more younger age, they can see that it's very rarely that the young endometriosis patient have a high stage of endometriosis. Maybe in certain studies, they have the opposite result, but many studies told that many younger endometriosis patients basically have a milder endometriosis stage. On the other hand, also, the kind of the endometriotic lesion that found in the younger age patient is totally different with the older age patient. And it will tell us that this disease basically is progressive. So if we do not take the action immediately when we encounter the younger endometriosis patient, probably this patient is going to have a prolonged inflammation caused by endometriosis and will end up with the more severe stage of endometriosis. And it's already being concluded by this publication that the kind of endometriosis like deep endometriosis and also endometriosis basically is a product of the prolonged endometriosis lesion in the body. So if we have patient with deep infiltrating endometriosis or adenomyosis or endometriosis, basically it will tell us that the process basically is already long. So this patient is a little bit too late to find out and try to seeking for help. So how could we improve the better strategy for endometriosis patients? So I'm trying to look for a model that also dealing with chronic inflammation. So I found this publication that explained about the journey of the chronic inflammation in autoimmune disease. As we already aware that autoimmune disease is one of the kind of disease that basically also have a prolonged inflammation. So from this kind of model, I'm trying to build out our own model on endometriosis, because by develop this model, I would like to analyze our patient that came to our hospital in order to see what we can learn from our patient. So first of all, as we know that endometriosis has already been introduced as a disease that started very early, since in utero, because there is a current theory that recognized that in female neonate that was bleed after she delivered, probably the blood that coming from her uterine cavity can also go to the abdominal cavity. And it was believed that that kind of blood consists very rich and stem cells that will stay for quite a long time before it will be awake when this lady will start to have menstruation. Means that the estrogen hormone will awake these stem cells. And these stem cells will be developed into endometrial-like cells and will be behave like an endometrial structure. So from there, this patient will begin to have a symptom. On the other hand, since 1928, we already noticed the very classic theory about retrograde menstruation. So therefore, many people believe that endometriosis start when a girl start to have a period, because 70% of lady that already have period will experience retrograde menstruation, but only 10% will suffer from endometriosis, because there is an immune system that will prevent the endometriosis, because these scavenging cells inside the abdominal cavity basically will clear up all the endometrial cells that coming into the abdominal cavity. But in endometriosis patient, unfortunately, the scavenging system was not doing very well. So we have the endometriosis data bank that will that we developed since 2020, and until now we have 200 patients that already included in our endometriosis data bank, and in the average age of 36 years old, most of them are graduated as senior high school. And as we can see from this current complaint of the patient in our hospital, basically they mainly complain about pain. Maybe because the age of the patient who came to our hospital basically is a little bit older, 36. So probably they're not pay attention anymore for having any child, because probably because of her age and because of the operation or the damage that already happened. Maybe they think that it will be very difficult for them to get a child. So their main focus mainly are pain. So what is the model on the diagnosis? So I did the research on the endometriosis patient with average 38 years old, senior high, most of them married. So we try to see what is the average age of their menarche. Their menarche mostly happen in 13 years old. And the symptoms basically happen 13 years after they had menarche. It's quite a long time. And most of the symptom that encountered in this patient was pain and also subfertility. So when they will try to find out for help when they got the symptoms. So in average, they try to seek for help in 3.5 years after they got a first symptom. And most of them will try to find their ONG. But some of them will also try to find midwife and GP. Our patient basically mostly have adenomyosis. I don't know, maybe many patients with only endometrioma maybe already being having surgery prior to our hospital. And they already in medication, most of them, and most of them already got non-hormonal treatment, and some of them also got self-medication. Almost more than 50% say that the treatment was improved, but 42% say no improvement. Many people got painkillers basically for their non-hormonal treatment, according to our research in 2019. And some of them also got surgery. Most of the surgery that was done prior to our hospital is cystectomy, because maybe adenomyosis is more difficult to deal with in surgery. So when patient got endometriosis, probably the previous hospital is more confident to do cystectomy. And how many years that they spend before they go to RSCM, or when it will require 8.5 years since the start of the symptom before they arrive in RSCM. And many of them spend almost 4 years in at least minimum 4 different health facilities before they came to RSCM. It's a quite long journey for every endometriosis patient. So when we try to put this model by the age, so we can see that probably in average 35 years old, this patient will arrive in RSCM after they got menarche. So it will be very unfortunate for us, because if we talk about in terms of fertility, 35 years old is not a very good age to start the fertility program. And if we talk about the progression of the endometriosis, if we start the symptoms in 27 years old, means that she already in almost 8 years before she go to RSCM, means that probably the chronic inflammation already happened quite long ago. So we're going to deal with more difficult case. So what is the delay? So I'm trying to think about what is the model on potential delay in diagnosis of endometriosis. So I found maybe there are 3 different kinds of delay. First is in the stage when the symptom is still not found. Maybe there is a biological phenotype variation, because as we know that there is a lot of variation in terms of the symptoms of endometriosis, the onset of the endometriosis. Probably the genetics or epigenetics will play a role in this section. The second delay model is in the individual awareness, because probably the symptom is already started, but unfortunately maybe there's a lack of knowledge about endometriosis. So it will be very late that this individual will encounter that probably they might suffer from endometriosis. And we try to collect summit about endometriosis from all around Indonesia with help of our colleague in Endometriosis Patients Association. So there's a lot of myth that we found in Indonesia endometriosis patient that will not help to understand about endometriosis. And the third model of delay diagnosis is probably in the health providers itself. There is maybe a lack of awareness, because, like I said, prior to this analysis, there is a lot of medical advisor also may think that endometriosis have to be diagnosed by directly observe the endometriotic lesion, either by operation or by histopathology. So it will contribute to the delay of diagnosis. So what is the solution? So I'm trying to find out the model of the solution in terms of this kind of 3-stage of delay. So I think I find out that maybe it will be good if we can intervene the stage 2 model delay of diagnosis, because maybe there will be a low cost, there will be more easily to deliver, and the coverage is very wide. So I'm trying to find out what is the best option for improving the diagnosis. So I'm going back to the lecture that was delivered by Professor Chapron in 2020 about what is the best thing to use as a primary diagnosis for endometriosis. And coming surprisingly that clinical diagnostic nowadays is become an essential indicator for endometriosis instead of histopathology, or maybe try to look out for endometriotic lesion either by operation or laparoscopy. So they already put the model like what kind of symptom that we have to pay attention to, what kind of history, what kind of physical exam, and also for imaging. And also Professor Chapron in his recent publication already mentioned about another comorbidities that also probably can be as indicator that we have to ask to the patient. And interesting, they already developed the basic apps that in mobile phone that can be used very easily to assess the risk for having endometriosis. So I think in the future we have to develop our own the application that will be used for the prediction model that can be used by many patients with kind of symptoms to assess the risk of endometriosis. Because why? Because there's a lot of mobile phone use in Indonesia, and I think there will be a lot of increase in mobile phone use in the future. So for my take-home message from the lesson learned from our RSCM patients, so I found that there's a long journey that was experienced by most of our endometriosis patients. And I think there is still a big gap between the onset of symptoms and the treatment. So therefore, I think we have to narrow that gap. And I think we have to increase the awareness about the importance of clinical diagnostic. So therefore, in terms of that fact, we have to maybe develop a media that will inform the patient about what kind of sign and symptoms that highly associated with the endometriosis. So therefore, we can develop a mobile apps that will be delivered to many Indonesian population. So therefore, they will aware about the possibility for having endometriosis, and maybe they will go to the health or medical advisor immediately. So therefore, it will be narrowing the gap. So they can start the treatment in order to prevent the chronic progression of the endometriosis. So last but not least, I would like to thank my research assistant, my trainee, and my resident, and also my colleague, because I really very grateful by their help for completing my research about endometriosis, and it still carry on. And thank you very much for your attention.
Yeah, thank you very much, Dr. Kanadi, for your comprehensive talk. It is very enlightening and very interesting to see the things that delayed the diagnosis of endometriosis and all the lessons learned from our patient in RSCM. We are going to move to the next speaker, Professor Dr. Andon Hestiantoro, OBGYN consultant, Master of Public Health, that will talk about the lifestyle changes in adolescent while learning from home during COVID-19 pandemic, its potential consequences in post-pandemic era. Professor Dr. Andon Hestiantoro, OBGYN consultant, Master of Public Health, graduated from reproductive endocrinology infertility consultant in Universitas Indonesia in the year 2000, and completed his degree in Magister of Public Health in Universitas Gadjah Mada Indonesia in 2016, and completed his doctoral degree in Facultas of Medicine Universitas Indonesia in 2017, and he is now the professor in obstetrics and gynecology in 2021, and he is also the head of human reproductive infertility and family planning research cluster in IMERI FMI Universitas Indonesia, and manager of cooperation, venture, and alumni affairs in IMERI, Faculty of Medicine, Universitas Indonesia. Prof. Andan, the time is yours.
Thank you very much, Vita, for very nice introductions. Dear audience participants, please let me share my works. Yeah, this is the title of my presentation. I would like to give a talk with the title Lifestyle Changes in Adolescents while they learned from home during the COVID-19 pandemic. And also I would like to tell you about the potential consequences in this post-pandemic era. So we have already known together that menstrual disorder also can be found in adults and women, and sometimes they come with a very irregular menstruation. Actually, after the puberty, we must be very cautious since the HPO-axis is not mature yet. So at least during 3 years after puberty, sometimes our young lady has an experience for the irregular menstruation. And the normal menstruation can be developed stable after 3 years of their puberty time. But still, we still can find this abnormal in their cycle. The frequency or the prevalence is around 11 to 26%. Actually, the adolescence period is very important since this is the transition development from childhood to adulthood. So at this moment, the WHO make a definition. The adolescence is between 10 to 24 years old. But at this moment, we try to focus and to limit our subjects into age 16 to 24 years. There are many factors that may influence the pattern or changes pattern of menstrual cycle in adolescents apart from their maturation process in the hypothalamus pituitary ovarian axis. For example, there are other interdependent influences such as nutrient and calorie intake. Also, there is association with the micro and macronutrient intake. Also, there is also other factor that may influence the changes in the menstrual cycle during adolescence, physical activity, sleep quality, hyperandrogenism, and also increasing in body mass index. During a COVID-19 pandemic, there is a policy from the government especially for the high school students. They are required to study from home. And also, based on our observation, it seems that at that time, there is a reduction in their physical activity. Also, there is a changes in diet. So that's why we thought at this moment, so after this policy has been going on for 1 year, we think this would be a good model for us to get any information, whether any association with the reduction of their physical activity, also changes in their diet during their study from home with their menstrual cycle.
So we try to examine some medical students and then try to see their body mass index with circumference, physical activity, also the development of acne, intake of vitamins B1 and B6, fiber intake, iron intake, fat and calorie intake, and also the sleep quality, whether there is a correlation with the menstrual disorder. And then we collected, we got the data from students from 6 high schools. Actually, we collected this between November 2020 and then to January 2021, while the policy itself has been going on for one year. And then the inclusion criteria applied to our young women are, while they are willing to participate in the research, also they should have been menstruate for more than 3 years. We collected around 900 teenage students aged between 14 to 90 years old. And then we divided them into 2 groups, into 2 categories, a group without menstrual disorder and then group with menstrual disorder. And then we have descriptive survey about the questionnaire for anthropometry, and then we try to measure the height, the weight, waist circumference, age of respondent, when they have a menarche, menstrual regularity, length of menstruation, and amount of bleeding during menstruation. And also we use International Physical Activity Questionnaire, or IPAC, to measure the respondent physical activity. And also we use the global acne grading system for measuring the severity of acne on their face. And for the food recall, we use a food recall questionnaire. And then by means of this food recall questionnaire, we can measure nutritional status, calories, fiber, and vitamins. Then afterwards, we bring them to Nutri-Survey software and to analyze the result. The Pittsburgh Sleep Quality Index was used for measuring their sleep quality. And this is the result. And then we found in our study that during a pandemic season, or COVID-19 pandemic season, and during their study from home around 1 year, we found that around 64% young lady suffering from menstrual disorder, and then the 60% of them showing the normal cycle. And this we found also the age of them is actually not different. Also for the we cannot find any difference in the level of the school class, and also time for menarche. But in group with the menstrual disorder, around 0.9%, they reported the shortness of their menstrual cycle, and then the longer menstrual cycle around 5%. And then the group with the abnormal menstrual cycle, there are 7% complaining for intermenstrual bleeding. 20% of them reported more frequent menstrual cycle, and in around 5% with infrequent, and there are 2 to 3% of them complaining from absence of menstrual cycle. There are around 50% of them, comparing to 24% of them, also complain about menstrual pain during menstruation. And then what about the physical activity reported by them? Based on our study, around 46% they show less active during this learning from home. And then we didn't find such data in a normal, and then because in a normal cycle, and they normally have a normal activity. Sometimes even they have a very active, but not in a menstrual disorder group. They are almost half of them show a less activity. We could not find any significant difference for the acne score. It seems they don't have any problem with the acne during their learning from home. And also we didn't find any difference in their sleep quality and also their body mass index, and also for the BMI more than 25. They were not, or they are not obese. But surprisingly, when we are trying to measure the waist circumference, around 67% of students with the menstrual disorder, they show waist circumference of more than 80 centimeters. Yeah, of course, difficult to compare it. So that's why we go to the percentile 50% percentile, and that is 76%. And then we found that, okay, they have a higher waist circumference compared to the normal. And also their intake is also higher compared to normal. They also show the higher fat intake compared to normal. And then we go to the multiple analysis regression, and then we found there are 4 factors that may influence the menstrual changes and the menstrual cycles in the women in our models with the less active women during their learn from school. First is the physical activity. Less active also may cause this menstrual disorder. Also with larger waist circumference also, and then higher calorie intake, and also higher fat intake, and then less fiber intake also contribute factor for the menstrual cycle. I would like to summary. So during our study, we observed that the students suffering from menstrual cycles abnormality, they have or they showed less daily activity, larger waist circumference, higher calorie intake, and also higher fat intake, and then less fiber intake. And also, I think this, when we try to refer it, actually their intake is within normal, yeah, but higher. But probably there is a combination. If we combine it with the higher fat intake, or also with the less fiber intake and the less daily activity, also may cause menstrual disorder. And probably this condition, sedentary lifestyle, high fat diet, low fiber diet, may end up with the higher waist circumference. And then all these conditions may influence the formation of chronic low-grade inflammation and then decrease the sensitivity of insulin and will causing PCOS. And also with there is a changes with the appetite regulation also may induce the higher secretion of LH. And then all of them are associated with the syndrome that is so-called PCOS, that it may cause menstrual disorder in our patient. And so if we refer to the actual criteria, so yeah, it's in agreement with the criteria for PCOS, and also in agreement with our data that around 20% of our patients, PCOS patients, are normal or underweight, and also with a very low Fermat-Gallwey score. And this is the consequences of them. If we cannot control them, probably we can find increasing of central obesity, and also there is a complication during pregnancy, and also probably increase the risk for them for diabetes mellitus during pregnancy, also the risk for having stroke. I would like to conclude my presentation. During a pandemic COVID-19, around 60% of high school students suffered from menstrual disorder, which associated with less daily activity, with a circumference more than 76 centimeter, a calorie intake more than 1,700 kilocalories per day, with the fat intake more than 70 grams per day, and with the less fiber intake less than 20 grams per day. And yeah, it may of course have the future consequences for the formation of diabetes mellitus and hypertension during pregnancy, and also infertility. That's all my study. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Prof. Andon, for your presentation. It is very interesting to see the effect and the effect of the pandemic COVID-19 and its consequences in the adolescent while they're learning from home. For all the participants, please share your thought and discussion or maybe question to us, and we will discuss it later at the end of the session. We will move to the next speaker. The next speaker will give a talk about abnormal uterine bleeding management during and post the pandemic era of COVID-19. Dr. Ahmad Kemal Harzif, OBGYN consultant, graduated from Universitas Indonesia for the medical doctor in the year of 2000, and obstetric and gynecology specialist in 2007, and also reproductive and endocrinology infertility consultant from the same university. And he is now the staff at obstetric and gynecology department, and also a senior researcher at our cluster in IMERI. Dr. Ahmad Kemal, the time is yours.
Okay, thank you, Dr. Pita, for the kind introduction. Let me share my screen. Okay. Can you see my slide, Dr. Pita?
Yes, Dr. Kemal, okay. We can see your slide.
Thank you. First of all, I would like to thank the organizing committee that invited me to talk about how to manage AUB during and after the pandemic era of COVID-19. This is going to be the outline of my talk. I would like to briefly go on to do evaluation of the definition of the AUB, and also briefly talk about the normal menstrual cycle. I would like to also continue with some point, the role of progestin in treatment, and also how to manage it during the pandemic. As we know that we are not over the pandemic yet. So this is the definition of AUB. We have to distinguish it between chronic and acute AUB. So chronic is defined if the bleeding from the uterine corpus that is abnormal, whether in volume, regularity, or in timing, in the last 6 months. So it should be last for at least 6 months. If we are talking about the acute AUB, is a condition of episode of heavy bleeding with a sufficient severity that required immediate intervention to prevent further blood loss. And then the last definition is about intermenstrual bleeding. It's bleeding between a clearly defined cycle. So the cycle is normal, but there's bleeding between every cycle. So this is the normal menstrual cycle. I think that we all are very familiar with this picture. As a brief talk, I would like to state that menstruation happens needs a very concerted condition between the hormone from the pituitary, hormone from the ovary that's produced by the growing follicles, and also the growth of endometrium. There are things that should happen in a normal menstrual cycle. It's a follicular growth, ovulation, formation of corpus luteum, and also the secretion of progesterone, and also the fall of progesterone levels due to no pregnancy. That will induce the cascade of menstruation. That what happened in a normal menstrual cycle. So what is normal menstrual cycle? FIGO in 2019 defined the parameter that we should evaluate to conclude whether this is normal menstrual cycle or not. In terms of frequency, it should be 24 to 38 days, no longer than 8 days, and cycle to cycle variability should be around less than 7 to 9 days. So it should not be a very irregular cycle. So how about the volume? The volume should be patient determined. So the patient might tell us that recently she noticed that the menstruation is lighter or maybe heavier than usual. How to diagnose? Because diagnosis is very important before we going to do to manage the patient. The FIGOs also already developed the way of thinking about structural and non-structural causes of the AUB. So structural terms in palm, polyp, adenomyosis, leiomyoma, malignancy, or hyperplasia. Non-structural cases in terms of coin, coagulopathy of bladder dysfunction, endometrium, iatrogenic, and is not yet specified. However, even though it seems that we have to do maybe a complete diagnostic workup, including the ultrasound to exclude the structural causes of the AUB, the bleeding pattern itself might tell us what kind of pathology or what kind of whether or not this patient has a uterine pathology or not, or whether or not this is a non-structural causes of the AUB. We should look at the period timing. Is it cyclical predictable or cyclical unpredictable? And what kind of complaint? Let's say the patient has a predictable cycle but heavy menstrual bleeding, so the causes might be either adenomyosis, leiomyoma, coagulopathy, or endometrial factors. If the patient experiences intermenstrual bleeding, almost likely the patient has a polyps, whether it's in the endocervical or in the endometrium. If the cyclical unpredictable, this should be only two kind of etiology, whether ovulatory dysfunction or malignancy or hyperplasia of the endometrium. What to do after we encounter the patient with AUB? Usually we perform history taking, physical examination, also transvaginal ultrasound, and then we can conclude this is a structural or non-structural. And then in places that we can have the hysteroscopy as a diagnostic, and also, as we can see here, the hysteroscopy also has a place for diagnostic and also therapeutic tools. So we can resect the polyps, we can resect the myoma, And also, in terms of diagnosis, we can perform the target biopsy and also endometrial resection in patients with hyperplasia or malignancy. Not to forget that if we are trying to manage the patient, especially during the pandemic, we have to initially screen for the underlying disorders of hemostasis, because this might need more than just hormonal treatment. As we can see, this is the history that might tell us whether or not this patient has an underlying hemostasis disorder that triggered the AUB. So the first is heavy menstrual bleeding since menarche, one of the history of postpartum hemorrhage, surgical related bleeding, also bleeding associated with dental work. And also the patient usually having bruises or epistaxis that frequently happen whether or not 1 or 2 times per month. How to manage it? The NICE guideline tell us if the patient has no identified pathology, the fibroid is less than 3 centimeters, or the patient suspected with adenomyosis. This is the kind of patient that we can initially manage with medical management. We can give either tranexamic acid, non-steroid anti-inflammatory drugs, combined oral contraception, oral progestins, or also if it's available, we can insert the LNG IUS. Combined oral contraceptive is already widespread use for treating the AUB. However, it's less effective than higher dose progestin at reducing bleeding. If we want to be more effective, we can give it in extended use. So the patient should maybe take the active pills without taking the placebo pills and has the menstruation every maybe 2 or 3 months. It's far more effective than cyclical use. This is the common combined oral contraceptive that widely available in Indonesia. It varies from the level of estradiol. You can see there's 30 micrograms of ethinoestradiol up to 35 micrograms. It's also varies in terms of the progestin that contain in the pills. Levonorgestrel, cyproterone acetate, or the drospirenone, it will correlate with the side effects that we might encounter during we administer the patient with the COC. How about progestin? As we know, progestin is a synthetic progesterone. We have 3 types of progestin that classified according to the whether or not it's derived from progesterone or derived from testosterone or derived from spironolactone. I highlighted the 3 progestins that widely used in Indonesia that been used for treating AUB, medroxyprogesterone acetate, normegestrel acetate, and also noretisterone. This is the 3 types of progestin that's widely used. So how to choose the progestins for treating AUB? We have to know about the properties and biological activities of the progestin that we are going to choose. It will correlate with the efficacy, and also it will correlate with the side effects. Let's say the progestin has a marked androgenic effect. We might encounter androgenic effect if we use it for a long time. However, if in treating AUB, sometimes we need progestin that have an estrogenic effect. As we can see from the commonly used progestin for treating AUB, the type of progestin that contain estrogenic effect is not episteroid. And also we have to consider the transformation dose, because it is very important that we have to reach minimal transformation dose to have an effect if we are treating AUB. It differs from one progestin to another. Let's say we are talking about non-episteron, it's 100 milligram per cycle. So we have the tablet is 5 milligrams, so we give the patient 2 times a day. So minimally, it should be given at least for 10 days. if we're talking about medroxyprogesterone as start with 10 milligrams per tablet, it minimally should be given 8 days per cycle. However, giving the cyclical progestin for heavy menstrual bleeding, we have the Concurrent published in 2019 that stated giving the cyclical progestin is less effective than 3 to 4 weeks of progestin. So if we are facing with a patient with a heavy menstrual bleeding and the patient still want to get menstruation, but we want to reduce the amount of bleeding, we should give the patient at least for 21 days. From the Concurrent, is stated that from day 5 to day 26 of menstrual cycle, the long course, it is more effective in reducing menstrual blood loss. And also, we have to consider the weight of our patient, because classically, we give the patient only 10 milligrams per day for treating heavy menstrual bleeding using the progestin. For example, this is the norepinephrine. But if in treating a heavier patient, more than 55 kilograms, we can see that we can also give the patient with a higher dose, 3 times until 6 times per day. 15 to 30 milligrams per day of norepinephrine can be given if the patient weighs more than 55 kilograms. From this research, they conclude that the norepinephrine is very effective for treating the heavy menstrual bleeding, severe uterine bleeding in adolescents, for example, in this research. And the time of onset of progestin administration to the cessation of AUB is around 2 days. So we have to be very patient and we have to adjust the dose according to the way of the patient. Now, what happened with COVID-19? We know that this is not over yet, even though we are facing with a decreased number of active cases and also the success of the vaccination of COVID-19 in our population, but it is still not over yet. So we have to be very vigilant in treating AUB patient, because this is what we put out when the COVID-19 pandemic happened in Indonesia. We said that the patient can postpone visiting the OBGYN or the healthcare provider unless there's a bleeding. So AUB is a bleeding, of course, but in recent literature, it is the fact that even in patients with AUB, we can treat remotely. So the patient may not have to go visit the doctors in emergency or very quickly, so we can postpone it. Telemedicine is very important. We can ask the patient to assess the amount of bleeding, to assess whether or not there's signs of anemia, whether or not there's a sign of hemodynamic compromise. We can also do it by telemedicine, maybe give us a hint, maybe the patient has history of fainting. Also, the patient might look really pale during our telemedicine consultation. And also, sometimes the patient has tools that can measure their blood pressure, their heart rate, and also they can show us the capillary refill time. And then we can measure whether or not the hemodynamic is still good. And also they can show us their conjunctiva, whether it's pale or not. And also, the bleeding timing and quantity can be collected using the WhatsApp or mobile application. This is the application that we developed that might monitor the amount of bleeding by using the mobile application in their smartphone. This is actually the pictorial blood loss assessment chart that been transferred to the mobile application. Then we can see from day to day whether or not the bleeding is getting worse or getting better. In abroad, the Royal College in Concurrent with British Society for Gynae Endoscopy and also the British Society for Gynecological Cancer put out a guideline how to manage the uterine bleeding during COVID-19 pandemic. It's the same that I already talked before. It's remote communication is can be done, and also we can take a clinical history remotely. We can try to look whether or not there's a sign of anemia. This is if in milder cases, we can use the oral medication initially just to prevent or to reduce the need for face-to-face interaction if the pandemic is really bad. So when to refer the case as an emergency case immediately if the patient is suspected of having severe anemia or suspected of having a hemodynamic compromise. We can also call the patient to seek a healthcare provider, OBGYN, within 30 days. So this is not an emergency case, but she should visit the doctor within 1 month. If the heavy menstrual bleeding still happens, even though we already give her oral medications such as tranexamic acid or maybe NSAID, and also if the patient has a significant risk for having endometrial disease, it might be hyperplasia or cancer in patients with obesity, older patient, more than 40 years old, maybe the patient with high risk, with history of maybe in family, history of endometrial cancer, and also PCOS patient that already have multiple episodes of AUB, and also the patient that have a significant anemia that we suspected during our telemedicine. That kind of patient should visit the doctor within 30 days. And then what kind of patient that can see the doctor and postpone the visit after 1 month if the patient has no significant anemia, and also if the patient still having the ongoing heavy menstrual bleeding. So the patient that not having a risk factor can see the patient can see the doctor after 1 month. In hospital, of course, as I mentioned before, we should give her a high-dose systemic progesterone if the patient has no significant pathology that might contribute to the AUB. You can see there are 3 types. In acute bleeding, single 10 to 14 days course. To regulate bleeding is 5 to 26 days for menstrual cycle. And also to induce amenorrhea, we can give her continued dose of progesterone. For patients with intermenstrual bleeding, it's a milder case because the risk of malignancy is very low in intermenstrual bleeding. So we can, this is the ideal candidate for telemedicine and also remote management. So if the patient older, 40 years old and older with persistent intermenstrual bleeding should see the secondary care within 1 month. Younger patient or patient older with using hormonal contraceptives also can go to the doctor beyond 30 days. What happened in the hospital, of course, we can perform any of the diagnostic tools according to the history taking, physical examination. We can also collect cervical biopsy if we suspected cervical abnormality, using ultrasound to scan for structural abnormality that might contribute to the intermenstrual bleeding. Biopsy can be done by blunt biopsy such as PPEL, or we can also have a hysteroscopic diagnostic procedure and targeted biopsy. In postmenopausal bleeding, this is a much more serious case. This is a red flag because higher prevalence of endometrial cancer, 5 to 10%. Initially, we can manage it by remote communication, of course, if the pandemic is very bad. the cases is very high. Confirm the symptoms, determine if they have any symptoms of COVID, because if they have symptoms of COVID, then they should wait for 2 weeks. And then after that, they can visit the doctors immediately, because we have to rule out the presence of endometrial cancer. This is what we do in secondary care or tertiary care. We perform speculum examination, measure the endometrial thickness by ultrasound. If less than 4 millimeters, the risk of malignancy is very low, so we can discharge the patient. If the patient has thickened endometrium more than 4 millimeters, we should do endometrial biopsy either by PPL or more preferably using the hysteroscope. So to conclude my talk, management AUB in during and after the pandemic, we should encourage using the bleeding pattern that can lead us to the probable cause of AUB. Of course, progestin has a role in managing AUB. We have to consider the transformation dose. Telemedicine can be used to assess AUB patients, and also with the help of our smartphone, with the mobile application. Intermenstrual bleeding are the good candidate for remote management because the risk of malignancy is very low. Heavy menstrual bleeding can be alleviated using tranexamic acid and progestin remotely during pandemic. And she should visit the doctors within 30 days or more than 30 days according to whether or not she is a high risk of malignancy. For postmenopausal women, if she has no symptoms of COVID, she should visit the doctors immediately. Thank you for the attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Kemal, for the interesting presentation. It's very challenging to manage the abnormal uterine bleeding, especially in the pandemic era of COVID-19. I am now inviting all of the speakers. We are now approaching to the Q&A session. We already received some questions from the participants. We can start now for the first question to Dr. Kanadi. The first question is, can endometriosis become cancer and how to prevent it? And is it depend on the age of the patient or the lifestyle? And the second question to Dr. Kanadi, I would like to ask about the recurrent endometriosis case, especially happen after surgery. Is there any management to prevent it besides the followed hormonal therapy? Please, Dr. Kanadi.
Yes, thank you, Dr. Vita, and thank you for the question. I think the issues on the malignant transformation has been a long question during endometriosis management, because nowadays, based on the trend and the result from the current studies, we try to little bit more conservative on endometriosis management, because nowadays we already recognize that endometriosis basically is a very chronic disease, because it's dependent on the estradiol status of the patient. So therefore, maybe if we do have a chronic progression case, there will be an opportunity the cells will turn out into transformation to malignancy. Why? Because I think from the characteristic of the endometriosis itself is already close to the characteristic of the malignant cells. Because why? Endometriotic lesion is still survive even though it's not in the very good environment like in the uterine cavity, and it still survive, and moreover they can support themselves by inviting more blood vessels, and also paralyzing the immune system, and also increase the enzymatic process to invade the tissues. So I think from this standpoint, we can see that the characteristic of endometriotic cells itself is already close to malignant cells. So no wonder that maybe someday they will really turn out into real malignancy. So is there any way to prevent? I do believe that we have to prevent this endometriotic lesion to become active for quite long time. So therefore, I think we have to manage the endometriosis patient for quite long time, because as I told before, that the culprit for maintenance of the endometriosis tissue is the estrogen hormone. So we have to deal with the estrogen hormone in terms to calm down the activation of the endometriotic lesion. So that's my answer for the first question. So for the second question, is there any way to prevent the recurrency? I think yes, there is, because I think the guidelines already mentioned about the role of hormonal treatment after surgery. But the most important thing before I answer this question is the aim for the surgery itself. Because from nowadays, I think the expert already conclude that the surgery is the second line of treatment in endometriosis. And basically surgery will be experienced only once time for a life in endometriosis patient. So therefore, I think if we really want to have a surgery for endometriosis patient, we have to know what is the main object of the surgery procedure for this particular endometriosis patient. And it's supposed to be very clear, because as we know that endometriosis still an estrogen-dependent disease. And since as endometriosis itself also can be spread out through all the abdominal cavity, maybe there will be some endometric lesion will left inside. We cannot remove them all. So the recurrency itself basically have different kind of reason. First, maybe the recurrency is not about the endometriotic lesion itself, but the recurrence on the symptom. Second, the recurrence on the lesion itself means that we cannot take out all the endometriotic lesion. So there are a lot of kind of things that could contribute to the recurrency. I think that's all, Dr. Vita.
Yeah, thank you very much for the answer, Dr. Kennedy. We are now moving to the next question to Prof. Andon. The question is, what would you suggest following the pandemic to the teenagers to avoid the consequences of increasing body weight during the pandemic? For example, to avoid the risk of PCOS in the future. Please, Prof. Andon.
Yeah, thank you, Vita. Also, thank you for the questions. If based on our observation, there is no changes in their body weights, also their body mass index during this learning from home program in a pandemic situation. So it seems that the changes is in the daily activity. So at this moment also there is a program for the government for fighting, for combating the mager, malas bergerak. It is also I think not only in our high school young lady, but also in our student, medical faculty student also, we observe there's a mager is also the new activity during this online program. So I think we need to design one program beside of this online activity. Probably we can also ask together to increase their activity. Sometimes during this online, we can also increase the for example the exercise or something like that. Yeah, senam bersama, something like that. They probably may be useful for preventing the development or the formation of PCOS in our adolescent. That's Dr. Vita.
Thank you very much, Prof. Andon, for the answer. it's very interesting to prevent the sedentary lifestyle, especially in our students. We are going to move to the next question to Dr. Kemal. The question is, what is the best option for reducing bleeding in menstruating dengue hemorrhage fever patient with a low platelet level? Please, Dr. Kemal.
Yeah. Actually, recently we have several cases that consulted by the internal medicine, not only dengue patient, but also patient with anemia aplastic, and also patient with autoimmune disease with a very low platelet count. From clinical experience, that I found that using the progestin, but not only not just the usual progestin, but progestin that has a estrogenic effect. So it's very important to give the progestin with the estrogenic effect, because having an estrogenic effect, it will help us in reducing the acute bleeding, because it will induce the proliferation of the shedded endometrium, and also it help us in triggering the coagulation factors. So usually we give the patient with the norethistérone. The dosage is, I usually go on using whether or not the patient is less or more than 55 kilograms. If this is quite heavy, more than 55 kilograms, we can give it in a higher dose. If not, less than 55, let's say the patient is quite thin, we can give the patient with 10 to 15 milligrams per day. Usually the bleeding will stop within 2 days. The experience is very similar with the research that I already presented earlier.
Yeah, thank you very much, Dr. Kemal. What about the role of estradiol in the management of the this kind of patient, Dr. Kemal?
Yeah. From the guideline, actually, they suggest us to use the estradiol only for 24 hours for the initial management. But sometimes the medication is hard to get, especially the one that stated in the guideline is the equine conjugated estrogen. It's already really hard to find. The other kind of estradiol is the estradiol valproate. We also can give it to the patient, but we have to be very careful if we are treating the patient with this suspected autoimmune disease. I prefer not to give a high dose estrogen in this kind of patient.
Okay, thank you very much for the discussion to all the speakers. I think I have been notified by the committee that the time is up. Thank you very much, first of all, for all the speakers and all the participants that already actively discussing with us. I hope this session will have the benefits for our patient. Thank you very much. I will close the session. Assalamualaikum warahmatullahi wabarakatuh.
Now we are going to listen to our keynote lecture, the last session in today's agenda, the burden of endometriosis, how to overcome. This session will be moderated by Dr. Gita Pratama OBGYN, consultant of reproductive endocrinology and fertility, master of reproductive science. Dr. Gita Pratama, I will introduce Dr. Gita Pratama, as known as Dr. Tommy, graduated as OBGYN from Universitas Indonesia in 2004, and gained Master of Reproductive Sciences in Monash University in 2010. Current position as a lecturer at the Faculty of Medicine Universitas Indonesia, member of Indonesian Association in Vitro Fertilization, Australian Society for Stem Cell Researcher, and the International Society for Mild Approaches in Assisted Reproduction. Dr. Gita.
Thank you very much, Dr. Herdinda, MC. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat bagi kita semua. Good afternoon, ladies and gentlemen. I hope we are all good and healthy today. We are now in the keynote lecture session of IMERI 2021. The topic of this lecture is the burden of endometriosis, how to overcome. It's a very interesting and important topic, and this lecture will be delivered by Prof. Budi Weko. I'm sure we all know Prof. Budi very well. Let me read the short CV of Prof. Budi. Prof. Budi is a professor in obstetric and gynecology, Faculty of Medicine, University of Indonesia, and currently is the Vice Director of IMERI, FMUI, and also Prof. Budi is the Past President of Indonesian Association of IVF Terfitri, and also Past President of Asia Pacific Initiative on Reproduction, ASPIRE, among many other achievements. Prof. Budi has conducted many research in the field of reproduction and published many articles in the high-impact international journals. So after this lecture will be followed by 15 minutes of discussion. So for all the participants, please send your question in Eyes on IMERI website and also YouTube. The chosen question will be discussed after the lecture. Prof. Budi, the time is yours. Thank you.
Thank you very much, Dr. Gita Pratama, for your kind introductions. So good afternoon, ladies and gentlemen. So I'd like to continue our discussion today, particularly about endometriosis, the burden of endometriosis, and how to overcome this very important issue. I think my talk is quite related with the previous sessions that was leading by Dr. Vita, Silvana, and also talk about the burden of endometriosis. So if you look about the phenotype of endometriosis, actually endometriosis is a chronic inflammatory, hormonal, immune, systemic, and heterogeneous disease with very important three different phenotypes. It was the superficial endometrioma or deeply infiltrating endometriosis, and sometimes were associated with different type of endometriosis that we know as adenomyosis. And pelvic endometriosis is a complex syndrome characterized by an estrogen-dependent chronic inflammatory process. So that's why the patients suffering from endometriosis, they are suffering from chronic inflammatory process. And if you look these ones, the endometriosis could be happen because of retrograde menstruations, and then it becoming a peritoneal endometriosis, deeply infiltrating endometriosis, ovarian endometrioma, and it's slightly different. The invasion of endometrial tissue into the myometrium will lead to the establishment of adenomyosis, which is also very, very important. How was the concept of endometriosis like? I think this is explained by Chapron in Nature Review Endocrinology 2019, that endometriosis can be studied from in utero or neonatal, and then started to puberty, adolescence, adulthood, and even menopause. Yeah, it is because it has happened because of pathological endometriums. We know that endometriosis is an endometrial disease, and then it happened because of retrograde menstruations, hormonal fluctuations, and also inflammation process is very, very important that will lead to angiogenesis, neurogenesis, and fibrogenesis. And it is happen influenced by process genetic and epigenetic of endometrium itself, and also influenced by immunological factors, particularly in the peritoneal cavity. So that's why we have three different endometriosis phenotype: superficial, OMA, and DIE, and it will lead to many problems in fertility field or in reproductive medicines. And the other things also very important, the epidemiological factors, and also instead of molecular and cellular alterations, when we try to explain how endometriosis will happen. Epidemiological factors that giving very important contribution are menstrual and reproductive factors, the patient with low parity, and then early menarche, short menstrual cycle lengths, and high duration of flows of menstruations. They have a higher risk to have endometriosis. And the other constitutional factors involving family history, low BMI, high freckles and navy, and then also personal habits is quite relevant with endometriosis, including alcohol drinking, diet, even inconsistent, no effect on smoking, and very low regular exercise. And all the epidemiological factors are supported by molecular and cellular alterations, consist of altered steroid biosynthesis and receptor response, particularly the increasing of estrogen receptor beta expressions, increasing of aromatase expressions, and also deficiency 17-hydroxysteroid dehydrogenase, and increased invasiveness and vascularization because of upregulated MMP expressions, increased VEGF, overactive AKT, and then also increasing inflammatory response because of production of chemokines, RANTES, MCP1, IL-8, recruitment of alternatively activate macrophages, increased peritoneal IL-6, TNF-alpha, and engagement of NF-kappa beta. So how was the burden of endometriosis? We know that endometriosis is a chronic, complex, and relatively common gynecological disorder, reportedly affecting 70 million adult and adolescent females worldwide. It was in 2006. And on epidemiological data, endometriosis affect as an estimated 10 to 15% of all women in reproductive age. Since no permanent cure for endometriosis has been found, so that's why symptom relief is the primary goal of assisting treatment option, which might be pharmacological or surgical approach. We can see here hospitalization costs and length of hospital stay per patient with endometriosis as a primary diagnosis since 1993 to 2002. This is the data of patients between 1 to 85 years old. You can see the length of stay is decreased. However, the cost is steadily wiser, increasing across the year. And annual rate of change in endometriosis-related hospitalization costs and medical care inflations even is higher, which is higher than inflation rate. Inflation rate, this is the data in United States. Inflation rate is about 4 to 5%. Increasing the hospitalization cost is up to 15% so from the base rate. So we can imagine the economic burden of endometriosis. And then this is the 15 most frequently performed, the procedures that frequently performed in endometriosis patients. Number one is total abdominal hysterectomy, followed by LAVH, and also other vaginal hysterectomy, unilateral salpingovarectomy, removal ovary or fallopian tube, and also laparoscopic local excision or the extraction of ovarium. You can see this is the data is including length of stay and also the charging the patients. If we look direct and indirect costs for endometriosis and chronic pelvic pain, this is the cost per patient, and this is estimated U.S. annual national cost. This is the direct cost, including the surgery and also hospitalized patients and also medical treatment. The total is almost more than $1 billion US dollars. And we compare indirect costs even almost 15 times higher compared to direct costs. Indirect cost coverage of chronic pelvic pain, relative loss in work productivity, and also average out-of-pocket expenses related to chronic pelvic pains. This is the source of payment of outpatients. Basically, they are covered by private insurance. Since this is the data in United States, I don't know if we try to look for our national data in BPJS. Also, I think it's very, very interesting. Previously, the data from the US, and currently we are going to see how the data in Europe. This is the prospective multi-center questionnaire-based survey measuring cost and quality of life in ambulatory care in 12 tertiary care in 10 countries. And then the outcome measure were healthcare costs, cost of productivity loss, total cost, and quality adjusted life years. You can see how was the result. And data analysis of 909 women demonstrated that average annual total cost for women was more than 9,500 euros. And then it was divided into cost of productivity loss is about 6,300 euros per women. It was double than the healthcare cost of euro, which is about only 3,000 euro per women. And then healthcare costs were mainly due to surgery, 30%, monitoring tests, 19%, hospitalization, 18%, and physician visits, 16%. And endometriosis associated symptoms generated 0.8 quality-adjusted life years per women. It means that the women suffering from endometriosis, their quality of life only about 0.8 or 80%. 20% was disturbed by the endometriosis itself. And this is the data. This is the direct healthcare cost, about around 3,000 euros. And then this is indirect cost, about 6,000 euros. So totals annually about 9,600 euros per women per year. So considering all the results and then how the endometriosis burdening our life and also the governments, so it's very important is the concept of the preventive medicines, which is included the primary and secondary prevention of endometriosis. If you look this data, clinical diagnosis of endometriosis is very, very important. That was endometriosis in many of endometriosis is undiagnosed in large proportion of affected women that was resulting ongoing and progressive symptoms with associated negative impact on health and also well-being. The current practice standard rely primarily on the laparoscopy for definitive diagnosis before beginning therapy, frequently result in prolonged delay between symptom onset, diagnosis, and subsequent treatments. So the challenge of diagnosis of endometriosis is there is no pathognomonic feature of biomarkers necessary and sufficient to define endometriosis, and then the presence of lesions does not preclude other etiologies for the patient's symptoms, and the lack of obvious lesions does not eliminate the possibility of endometriosis. That was the challenge. And then endometriosis is typically defined by its histology. We know that extrauterine lesion consisting of endometrial glands, endometrial stroma, and or hemosiderin. And based on location, we know this is the superficial endometrioma or deeply infiltrating endometriosis. And if you look this one, the predictive value of signs and symptoms, endometriosis or diagnosis, assessment in the electronic medical record, assessment of parameter using the severe dysmenorrhea, chronic pelvic pain, dyspareunia, infertility, and use of oral pill contraceptive. And then the self-report replying in the affirmative, the doctor has previously told. This is including the sign and symptom, menstrual pelvic pain cramping, non-menstrual pelvic pain, dyspareunia, heavy menstrual bleeding, and then there's laparoscopically visualized endometriosis, and then laparoscopically visualized endometriosis, including sometimes they have very clear epidemiological factors and also clinical symptoms. And in the left side, this is consistent with endometriosis. If we do evaluation presence of the symptoms, if the symptom is persistent and or worsening cyclic or constant pelvic pain, dysmenorrhea, deep dyspareunia, cyclic dysphagia, cyclic dysuria, cyclic catamenial symptoms, which is very important, and then review patient history if the patients have suffering from infertility, previous laparoscopy with diagnosis, dysmenorrhea, and then on physical examination, if we found nodules in cul-de-sac, mice consistent with endometriosis, or perform ordered imaging endometrioma on ultrasound or present soft markers such as sliding signs. So women with diagnosis reported of endometriosis reported on average, I think, about 5.4 year diagnostic delay, with 3 years delay from onset of the symptoms to general physicians, and then 2.3 year delay between physician consultation and diagnosis. So we can imagine the patient even delay come to the doctor, and then the doctor even delay to start the diagnosis. And then if you look this one, the delay is ranging from 4 to 11 years. So that's why we can imagine how was the burden of endometriosis. And then consequences of delay in diagnosis are experienced by patients in multiple ways, including detrimental impact on quality of life because of persistent symptoms, erosion of the patient-physician relationship, and very important things, development of central sensitizations where the patient's persistent endometriosis associated pain increases pain awareness. This is sometimes it's very terrible to the patients. So how we can make a diagnosis of endometriosis easy and very fast? So that's why development of biomarker is very important. Even it's very challenging. Still, there is a lot of opportunity. If you look these ones, the delay of the diagnosis of endometriosis in adolescents, it's about 4.6 years, and then it takes another 4.7 years until diagnosis. And then we can see also they are waiting another year when they already come to the doctor. And then I think in case of endometriosis like symptoms in girls before age 15 years, indicating the potential need to screen adolescents and younger girl as early as display symptoms of endometriosis. This is why happened the chronic inflammation. What happened? Why happened the chronic inflammation in endometriosis? This is chronic inflammation induced by ectopic presence of endometrial fragments, and then chronic inflammation lead to hypersensitization of nerve fiber, ending with the very painful that the patient's feelings. And non-invasive diagnosis of endometriosis, this is very important because we should solve the problem that using the laparoscopy as a golden standard for diagnostic. The laparoscopy is costly and also very invasive procedures. The use of transvaginal ultrasound for detecting the ovarian endometrioma has a good sensitivity and specificity. However, in the non-endometrioma patients, I think the use of ultrasound is quietly very restricted. So people trying to combine the 28 biomarker as a panel for non-invasive diagnosis of endometriosis. I think a total 28 inflammatory and non-inflammatory plasma biomarker were measured in the during surgery from 121 control and 232 women with endometriosis. And then there are two models with 4 biomarkers, annexin 5, VAGF, CA125, and glycodelin. And then model 2 is plus with soluble ICAM1. And then this is with analyzed in plasma, could predict ultrasound negative endometriosis with a high sensitivity, about 80 to 90%, and acceptable specificity about 70 to 90%. The other thing about non-coding RNA in endometriosis, including the microRNA, we know that microRNA has a very important role in remodeling angiogenesis, and then survival and proliferation of the endometriosis cell, hypoxic injury, steroidogenesis, and inflammatory process. So that's why now people trying to establish the biomarker of microRNA as a non-invasive endometriosis biomarker in diagnostic. This is the algorithm. If we found the suspected endometriosis patient according to NICE guidelines in 2017, it is including young women at 17 and under with the symptom chronic pelvic pain, periodic related pain, deep pain during or after sexual intercourse, and this is period-related cyclic gastrointestinal symptoms, period-related or cyclic urinary symptoms. We should assess women individual information and then discuss the patient, and be aware of initial management with the short trial, NSAID or hormonal treatment, combined oral contraceptive or progestogen, or if the patient also suffering from fertility, please send the patient to the fertility clinics. And this is the considered referral to gynecology service. specialized endometriosis service, or considering referring the young women to pediatric and adolescent gynecology first aid services. This is, I think, all the clinical services that quite related with the endometriosis management. And this is the considerations that we should do: transvaginal ultrasound, transabdominal ultrasound, consider laparoscopy if needed, if we cannot exclude the possibility of endometriosis. And then this one is discuss medications, and also laparoscopic if needed. And what is the barrier of the timely diagnosis of endometriosis in primary care? This is the data in Netherlands that several factors in daily primary health care contribute to diagnostic delay in endometriosis. Future intervention to reduce this delay may be aimed at increasing awareness by means of educations, incorporating the subject into national clinical guidelines, and improvement in interdisciplinary collaboration. So that's why the role of primary care is very, very important to make a timely diagnosis of endometriosis. And then how can we handle the endometrioma? This is the modern management of endometrioma. We can see here, this is if the patient suffering from pelvic pain or infertility, or even combined pelvic pain and infertility. We can see, we can offering the medical treatment, fertility preservation, or even assisted robotic technology, or the last is surgery. It's very important, the referral center, if the patient have a complex associated of endometriosis. The other therapeutic mechanism or hormonal treatment in endometriosis is still a big question, because there is no ideal medications, since the medication now is more curative rather than suppressive rather than curative, because the criteria for ideal medication should be curative. Treat the patient and fertility at the same time. Acceptable side effect profile and long-term use should be safe and affordable, non-contraceptive, which is very, very important and very, very difficult to find the ideal medications. This is what, for example, we can use analog GnRH, consists of agonist GnRH and antagonist GnRH, use of progestin, selective progesterone receptor modulator, or combined oral contraceptive. This is the role of GNS analog in the treatment of the estrogen-dependent disease, including the endometriosis. Yeah, if you look this one, the role of GNS analog, they have some role in central, and also they have some role in peripheral. In peripheral action, based on in vitro and preclinical experimental model, it has been suggested that the analog GnRH may exert an additional and direct anti-proliferative effect on benign and malignant diseases. So this is, for example, in endometriosis and adenomyosis and uterine fibroid. Even in the peripheral, GNS analog exert direct anti-proliferative effect on different cells. Yeah, if we look, this one is based on staining of immunohistochemistry. This is GnRH positive. This is the endometrium. This is adenomyosis. This is coming from fibroid. You can see after giving the GNS agonist, the expression of Ki67 in the periphery is slightly lower compared to the control. So it means there is a role of GnRH analog not only in central but also in peripheral. And one of the GNS agonists is very important is triptorelin. This one, they have an increased affinity for GNS receptor, was in vitro 6 times more active than reprolites. You can see triptorelin 6 times compared to leprolite in receptor binding, that expressing the human GNS receptor. And then we can see here how the pituitary desensitization for 8 weeks after the administration of different GNS agonists. That one is triptorelin, and then this one is a leprolite. And we can see that triptorelin, because they have 6 times bonding is higher compared to leprolite, so the suppression of F8 and L8 is quite stronger than the use of leprolite. And also we can use leprolite triptorelin until 24 weeks. It means until 6 months, instead of injection only 2 or three times. So only for 2 or 3 months, and the triptorelin can make an effect until 6 months. So I think this one is one of benefit if we use the triptorelin for suppressing the symptoms of the patient, particularly is pain. So if you look how was the endometriosis life, currently the very important things that we should make a non-surgical diagnostic of endometriosis and then propose to make a long-term medical treatment. And if the patient desire to become pregnant, might be assisted reproductive technology is the best choice. And after the patient getting pregnant and conceive, they can use the long-term medical treatment, or even they can go to have a single definitive surgery if they want to if they still have symptoms such as pain. So as this is my last slide. As the take-home message is, it's very important that considering that endometriosis has burdening the quality of life and also increasing the economical cost. So that's why early diagnostic and prompt treatment are the appropriate strategy. This is very, very important, early diagnostic and prompt treatment. Up to now, still there is no single biomarker has been established as an endometriosis diagnostic tools. So that's why we should empower our primary physician in the primary care to recognize early signs and symptoms of endometriosis patients. Listen to our patients since they are telling us the diagnosis. So this is a part of empowering our primary physicians. Number 5, that we should understand well how our endometriosis life to keep us aware. The very crucial is early diagnostic of endometriosis. And then we give the patient long-term medication, and if they want or they desire to pregnancy, we can offering ART, and afterward we give them again long-term medication, and if needed, we can perform one definitive surgery. And the last, we should focus, treat the patients, not the lesions. This is the basic concept in endometriosis management. So that's why very important, and endometriosis, we should ending endometriosis by early detection and knowing the endometriosis early as possible. Thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay. Thank you very much, Prof. Iko, for your very interesting and comprehensive lecture. So now we are in the discussion session for this lecture session. So we have 15 minutes. So I will read some question that has been delivered to me. The first question is about delayed in diagnosis of endometriosis is one of the reason is the perception of dysmenorrhea in Indonesian women. So they think it is normal to have menstrual pain. I think it would be interesting if we have community research based on this. So the question is there any life changes or diet to prevent endometriosis in adolescent, especially with the history of endometriosis in the family? Thank you.
Yes. Yeah, thank you very much, Dr. Gita. I think this is a very relevant question if we are trying to prevent the endometriosis diseases, since we know that endometriosis is quite burdening, not only the quality of life, but also giving the high impact on economical costs. So that's why number one, the statement is quite true that the women should have a menstrual diary card that including not only the date of the menstruation, but also the symptoms. What is the symptoms during menstruations? Might be the pain during the first day or second day is still normal. However, if the pain is already disturbed your daily life, it's not a normal anymore. If you have to absence from the school, absence from the working space, I think it's not normal. So this is very important. Every women should have their own menstrual diary card. And then number two, also the lifestyle and environment and also nutrition is very important in order to prevent endometriosis. If we talk about the primary preventions, of course, every single disease is correlated with the genetic aspect. And every genetic aspect, the gene is not switched on if the lifestyle and environment is quite true. So that's why the nutrition, high, quite healthy nutrition, high protein diet, low fiber diet. Yeah, we know that endometriosis also related with chronic inflammation. So the women with the history of the disease, endometriosis disease, the genetic trait is very, very high. So that's why very important. We should also establish the concept of precision medicine in endometriosis. I think this is a very important precision medicine, nutrigenomics, if we are trying to make primary prevention. Thank you, Dr. Gita.
Thank you, Prof. Budi. So the second question is about, okay, I just read the question. Is it possible in the future we can make a gene test to predict the occurrence of endometriosis in women before it happens, like in BRCA gene for breast cancer? Thank you, Prof.
Yeah. I guess so. Yeah, I guess so. Yeah, that's why the precision medicine, the concept of the precision medicines, that the combinations among genomic clinical data and genomic data is very, very important. If I mention in my slide, the epidemiological factors with molecular cells, that molecular process we can combine, and also including the genomics. Yeah, involving the progesterone receptor, estrogen receptor beta, and a lot of ICAM or whatever that was related with the endometriosis. And then we can make the algorithm. We can make a kit, becoming one kit that consists of a lot of gene expression, also including the microRNA, maybe consists of 100 microRNA we can use as the tools biomarker in early diagnosis of endometriosis.
So it's not, I think it's not a single marker, yeah, Prof. Yeah? So
correct.
It would be likely a combination of many markers. Okay, because we have a short time, proceed to the next question. So the patient who came to our clinic mostly in severe condition, if we take more history with this patient, mostly already had dysmenorrhea since adolescence. So since the value in Indonesia is normal to have dysmenorrhea, most patients came in with the pain so severe and also infertility. So I think we need to educate the community, especially in early time of menstrual cycle or puberty. I don't think it's a question, Professor, but I think it's a
comment. Yeah, I think it's quite true. Yeah, we should empowering the patient and also empowering our primary care physicians, because the delay in diagnosis is 4 years in the patient's perspective and also 4 years in the doctor's perspective. So the total is 8 years.
Quite long time, Prof. Yes. Okay. Next question. So, what is the role of CA125 and also CRP and estradiol as the long-term medical management for the endometriosis, Prof? Maybe after the treatment?
Yes. Unfortunately, right now the CRP and also CA125 is not specifically can explain how was the endometriosis progressive and during the treatment. So that's why right now we cannot use them as one of the biomarker if we want to monitoring our treatment in endometriosis. So mainly the treatment monitoring is quite important. Is the symptoms of the patient, including the pelvic pain, the chronic pelvic pains. So the concept is listens to your patients. The cyclic pain, such as the dysmenorrhea, dyspareunia, dysuria, dysphagia, the four type of pain, we should asking to the patient.
Thank you, Professor. Next question. So since endometriosis make a big burden in quality of life and also economy, is there any promising approach that for prevention therapy of endometriosis, Professor?
Yes, yes. It's very interesting. Yeah, it's very interesting. Also, if we talk about health technology assessment, actually we should develop all the technology in health and medicine to prevent the disease such, like this. Yeah, high volume, high cost, high risk, and high variability. Particularly if the national health insurance will cover the treatments. So we should find what is the best technology. And then one of the important things, the use of OCP, yes, in the country, even in US, even in the United States, one of the country OCP user is highest. I think they're still facing the high burden of endometriosis. We know that COC is giving a very important role to handle all the symptoms of the endometriosis. However, they're still facing the high burden impact in endometriosis.
Okay, thank you, Prof. Iko. I think we don't have any more questions from the audience, but I have a question for you, Prof. Iko.
Yeah.
So I think looking at the concept of endometriosis life, as you mentioned in the lecture, so what do you think is the optimal time for us to decide whether we do surgery or just delay with the oral medication first? Can we decide? And I think, when is this the best time to do surgery in particular patients?
Yeah. Okay. Thank you very much, Dr. Gita. So, number one, please consider all the factors, including the symptoms. If the patient's symptoms is quite high, pelvic pain with high visual analog score, might be this is a good candidate to offering the surgery. The second thing, if there is some possibility to malignant transformation of endometriosis to becoming endometrioid carcinoma, however, this is quite low. And then number three, there's some very important contributing factor that should be considered, such as patient's age. Yeah, we can allow the surgery if the patient's age might be less than 35 years old. Ovarian reserve. If the ovarian is quite good, maybe we can consider the surgery. And then the bilaterality of endometrioma. If the endometrioma is unilateral, might be we consider the surgery. But however, if the bilateral, we should be very, very careful. And the last also, we should think that we should keep surgery to a minimum. The final surgery the first surgery should be the final surgery. So please consider all the important factors.
Okay, we have one more question, Prof. Iko. The primary prevention, including early diagnosis, can lower the burden of endometriosis. So how do we do the early diagnosis in the setting, maybe in the primary or secondary health service?
Yes, the primary care, I think we can see the paper from the Sony Sukhbir Singh and Agarwal. Yeah, they listed all the symptoms, the very important symptoms, all the cyclic pain, such as dysmenorrhea, dysuria, dysphagia, cyclic dyspareunia, or even catamenial symptoms. This is catamenial symptom is very important. That symptom related to menstruation. Some patients even they are a shortness of breath during the menstruation, or even the hemoptysis during menstruation. She should be very careful. And then after the presence of symptoms, evaluation of uterine and adnexal mass. If there is adnexal mass, should be very careful. And also physical examination by looking at nodule in the rectovaginal space. And then if the pelvic pain, chronic pelvic pain by our vaginal examination. Also, I think it's all the parameters that we can do in the primary care.
Okay, thank you, Prof. Iko. Because I think the time is up. So maybe from the discussion, we can conclude that the endometriosis has not only affect the quality of life in women, but also economical costs here in the country. So therefore, we need to perform early diagnosis, proper treatment for endometriosis. I think I'd like to thank for all the participants for joining us in this session, and especially for Prof. Budi for your very interesting, insightful lecture in this session. Thank you very much. Good afternoon. Please be safe and healthy. Assalamualaikum warahmatullahi wabarakatuh.
Good afternoon, ladies and gentlemen, distinguished guests, and all participants that I respected. Welcome to our last session, concurrent session 13 in Hall A. For those who are care to joining in Hall A, we are having a seminar in Essential in Research Biobanking. This session will be moderated by Professor Dr. Anda Asmarina, Master of Science. I will introduce Professor Asmarina. Professor Asmarina has finished her master program in Biomedical Sciences at Faculty of Medicine, Universitas Indonesia, and then continuing her doctoral program at University of Gießen, Germany. Gained professor degree in medical biology at Faculty of Medicine, Universitas Indonesia. Now she is currently active as staff in Biology Department, Faculty of Mathematics and Natural Science, Universitas Indonesia, and also a senior researcher in IMERI Promet. For Professor Asmarina, you are already joining with us.
Yes, I'm here. Thank you.
Yes. Okay, the time is yours, Prof.
Okay. So, Assalamualaikum warahmatullahi wabarakatuh. Okay, good afternoon for all of you here. First of all, I would like to greet from our faculty here for the participant and also for the speaker for this session. Yeah. Okay. Okay, they're all distinguished speaker and honorable our participant in this workshop. I am Asmarina from Medical Biology Department, Faculty of Medicine, Universitas Indonesia, as a moderator for today's workshop. I'm very happy to see you here and welcome all of you in this interesting workshop about essential research biobanking. So, as we know from the name, biobanking is represent a collection of biological material and associated data for information stored in the organized system that can use for research. Biological material and associated information stored in biobank is important source for biomedical research that can give benefit for diagnostic, therapeutics method development, as well as for public health management. And I think the demand of biobanking is increased nowadays because growing of the number of next generation omic technologies today. Yeah? So it is pleasure today we have this expertise speaker for this workshop that can give us knowledge not only about the standard qualification in research biobanks, but also prospective research biobank in the future, and how we can collect the tissue and liquid biopsy as important material in biobanking. So our speaker today, it's a pleasure to see you, Dr. Bart from the Groningen, Netherlands. I think I met you last time in West Sumatra for the workshop, national workshop in biobank. So thank you very much for your willingness to give us a lecture or your experience to manage the biobanking in Netherlands. So I think the big biobanking institution in Netherlands. Okay, and then the second speaker today is Rafika Indah Parabita, M. Pharmacy, apotheker from Faculty of Medicine, Universitas Indonesia. And the third speaker, or the last speaker, Melania Saraswati, medical doctor, specialist in pathological anatomy from Faculty Medicine, Universitas Indonesia. So before we start with the lecture from the speaker, let me inform you that the regulation for this event for this workshop. So each speaker will be given a lecture for 20 minutes. Then after finish the lecture from three speakers, we provide 15 minutes for discussion. The participant who want to ask the speaker can put the question in the chat box. So now we proceed with the first lecture from Dr. Bart Serder from the University Medical Center Groningen, Netherlands. So the title of the presentation or lecture today is the minimal standard qualification in research biobank. Before start this presentation, I will inform you the short CV from him, from Dr. Bart. Please let me, here, the Dr. Bart Serder, MBA, 2021 is a Master of Business Administration, graduate from Master of Business Administration, Maastricht School of Management in Netherlands. 2015, Lean Six Sigma Green Belt from University Medical Center of Groningen, Netherlands, and 2014 International Project Management Association or IPMA Level C. And current position, Business Development and International Affairs from University Medical Center of Groningen, Netherlands. And now is President, Board Member of the Association of Contract Research Organization Netherlands, or ACRON, and Board Member of the Dutch Clinical Research Foundation, or DCRF. So we continue now with the presentation from the Dr. Bart. So I think the committee has already prepared the video from Dr. Bart, but Dr. Bart also joined today. So later, Dr. Bart can answer the question from the participant. But for the presentation, the committee has already provided this video. So the committee, please, can play the video from lecture from Dr. Bart.
Good afternoon, everyone. My name is Bart Scheerder, and I work at the University Medical Center Groningen as an innovation officer with a specific focus on data-driven health, data science, biobanking, and innovative pharmaceutical therapies. I want to thank the organizers of the 6th Annual International Conference and Exhibition on IMERI 2021 for inviting me to speak at this important international annual conference. Unfortunately, I could not travel to Jakarta this edition due to the pandemic travel restrictions, but I look forward to sharing my lecture online. Today, I want to speak about the minimal standard qualification for biobanks. Before diving into the topic, however, let me please introduce the University Medical Center Groningen. The UMCG is part of the University of Groningen, which is an internationally top-ranked university. Historically, we have partnerships with a number of Indonesian universities, for which my colleague Tim Swastra is our liaison. The Faculty of Medical Sciences of the University of Groningen has approximately 200 full-time professors and about 1,200 PhD students at any given time, many of which have an international background. On an annual basis, about 225 of these PhD students will have their PhD thesis defense. Other than an academic institution, the UMCG is as well one of the larger hospitals in Europe. On an annual basis, we have approximately 800,000 patient visits and we have 1,300 hospital beds. The total staff count of UMCG is 13,000. But of course, you did not come to learn about all that, so now let's talk about biobanking. To understand the minimal standard requirements, it is helpful to start with a discussion about what makes up a biobank. The field of biobanking has been around for centuries actually, and originates primarily from pathology. However, in recent decades, there has been a strong growth in the number of biobanks available as the medical sciences progresses and relevant technology further develops. A biobank in essence is a collection of biological samples and associated research and/or clinical data. In the context of this presentation, I will limit this to collections of human biological samples, but there are also many biobanks from other types of biological organisms. There are two different types of biobanks that we differentiate: the clinical biobanks and the population-based biobanks. The key difference is that clinical biobanks will be a collection that is focused on patients, whereas a population-based biobank will focus on the general population, who may or may not also include patients. In Groningen specifically, we have the Lifelines Biobank, in which 10% of the regional population are included in a biobank and provide data and samples for research every 5 years. These 165,000 volunteers therefore participate in a population-based biobank. The biobank collection is intended to be stored for future purposes, hence the term banking. I have been working in biobanking for about a decade now and can tell you that the name banking can lead to some misunderstanding when people may think that biobanking is the business of making money out of biological samples. That's not the case. Biobanks are collections of these materials and data that are ready-to-go resources for contemporary biomedical research and approaches in personalized health medicine. They enable researchers to start with their research right away, rather than first spending a lot of time to collect new data and samples. Often, though, this is not a requirement. Biobanks have no predefined research question. Many biobanks are set up for a specific purpose. For example, a collection that is aimed specifically to promote the research into a certain chronic disease. But the precise research that will and can be done with the collection may not be predefined. Also, many collections have a longitudinal design, to collect data over time of a cohort of patients or participants. Also, this is not a requirement, but can be considered typical. Then there is an important differentiation to be made between two types of biobanks, the de novo biobank and the secondary use or residual tissue biobank. Let's start with the latter. During the healthcare process, there are many reasons why we collect biological samples from patients. This is often for diagnostic purposes, such as the drawing of blood or perhaps the collection of a surgical sample for pathology. Sometimes we also collect these materials for treatment purposes, such as stem cell therapies. When we collect this material, the primary purpose of this material is the medical care or medical reason for collection. There may, however, be enough material to also store this material for future scientific purposes. In that case, there is a secondary purpose for which we can store these samples. Of course, we can't decide ourselves to do this. We will need to make sure that we have clearance from an ethics board, and as well we should make sure that the donor, the patient, provides informed consent for this. In some cases, providing explicit informed consent is not a requirement, but it is enough to ensure that the patient does not object to the collection. In those cases, an opt-out procedure is used where patients are informed that the residual biological samples will be stored for research purposes unless they explicitly object. On the other hand, there are de novo biobanks. De novo biobanks are collections of biological materials and related clinical data that are specifically and only collected for research purposes. In this case, there is a specific purpose for the sampling, and the patient needs to be explicitly asked for permission through signing an informed consent form. There are different types of informed consent forms that can be used. There are the so-called broad consent, which basically means that the patient is asked to consent to a quite broad range of future research purposes for which their materials and data can be used. There will always be a central goal or theme for the research. For instance, the improvement of care for COPD patients. But further specification will not be given up front. Then there is the narrow consent, in which it is quite narrowly described or defined which type of research can be conducted with the samples and data. For instance, the comparing efficacy of different medication strategies for the care of COPD patients. Last category is the dynamic consent, which refers to a consent that will allow for the patient to provide informed consent on a dynamic basis, often through the explanation of new research proposals and asking again for consent on those proposals. So then let's make the step towards what is needed to create or operate a biobank. First and foremost, what must be in place is an ethics clearance to collect the samples and data. In different countries and regions, the requirements differ. Some areas have specialized rules and regulations and separate ethics boards to evaluate biobanking proposals, whereas in other areas, the normal institutional review board will evaluate them. In all cases, you cannot independently decide to start collecting without informing some oversight committee and obtaining their approval. This step can sometimes be difficult, because, for instance, some ethics committees may consider a biobank without a predefined research question to not be suitable for their evaluation, as they cannot make a risk-benefit assessment. The other elements that I've listed here, I will go over in a bit more detail later, but the last point I want to explicitly mention already now: users. There really is no point to create a large and unique biobank collection when in the end nobody or only a very limited number of researchers will use it for research purposes. I could talk for another hour or a day for that matter about strategies to ensure that your biobank will be found and used for research, but that is a bit out of scope for today. The first requirement is for data and samples to be fair. Many times biobanks, or for that fact research databanks, are collected and used to answer only a limited number of research questions. Increasingly, however, the principles of fair data are being adopted and also used for samples. FAIR is an abbreviation which stands for findable, accessible, interoperable, and reusable. Findable data and samples means that researchers that could potentially have an interest to use the biobank should be able to know about the existence of the collection and have some details about what the collection consists of. In Europe, as an example, there is a central catalog hosted by the BBMRI-ERIC organization that lists a large number of biobanks and what the biobanks have collected. In the Netherlands, the BBMRI Netherlands node has a subcatalog in which hundreds of biobanks are listed. These can be browsed so researchers from other institutes can become familiar with what is available. Accessible then means that there should be a transparent and clear access policy and application procedure to get access to the samples and data. It does not mean that everyone should be able to access it. If, for instance, your biobank does not want to work together with companies, then this should be described in the access policy, so that it is clear and transparent to all. Interoperable means that the data and samples should be collected in such a way that others should be able to use them. This means that for data, for instance, you should rely on international data standards and data dictionaries. For samples, there are similar standards, such as the SPREC, the Standard Pre-Analytical Code, that can be used to describe exactly what is in a biomedical sample aliquot. Reusable is more of a principle. This means that all data that is collected should be made available for future projects under the right conditions. For sample analyses, reusable typically means that when a sample is analyzed from a biobank, the resultant biomarker data is shared with the biobank for future uses. In this way, we get the most out of our data and samples and reduce waste. Next, what is important is to have a clear governance framework in place. There are different governance models and types of organizations involved in the governance of a biobank, dependent on the type of biobank, the size of the biobank, and the context in which it operates. For instance, you may appreciate that the Lifelines Biobank that I mentioned in the beginning is a very large project that involves hundreds of professionals working for the biobank. This biobank has an extensive governance framework with several committees involved. However, maybe you are working or thinking about setting up a small biobank collection of about 100 patients within the context of your research group. Then having several committees involved is redundant. There's no one-size-fits-all for a biobank, therefore. So please consider the requirements of your project. Most biobanks, however, will have a steering committee in place. The steering committee is the board that gives guidance to the future direction of the biobank and is also the final responsible committee for the biobank. Most biobanks will also have a scientific committee that has representatives from the research group involved, as well as some external researchers from other institutions. An access committee can be in place in case your biobank is expected to have a lot of requests for access. They will only check whether the application meets the requirements set by the biobank. Finally, some biobanks will have a separate committee of the participants, in particular with very large biobanks and for longitudinal studies where you want to follow the patient follow the patients for a long time. Another important requirement is to have a quality management system in place. This QMS should have clear and unambiguous standards operating procedures for the collection of data and samples, so that when these are used for research purposes, you know that how they were obtained and what the quality is. These SOPs should describe the whole process, starting with the inclusion of participants, the subsequent sample and data collection, processing, storage, issuing, and analysis of the samples and data. The importance of standardization and quality can be illustrated by showing an example of sample collection in the surgical context. Here we see the visualization that George Dagger made some years ago. It shows the steps from the surgery department where a sample is collected, the subsequent pre-analytical processing stages, and then the long-term storage. In this case, a freezer is used or a fixating formula. In each of these steps, standardization will lead to more harmonized results in your analysis because all the variation in conditions that can be influenced are standardized. Also, it leads to better recording of sample processing conditions. Of course, there are limitations to what can be achieved, as you can see here. The green circles show the steps where the biobank has full control over the process and should ensure as much as possible that things run smoothly and standardized. The yellow circles show the steps that are not under the direct control of the biobank, but which can be influenced, and through SOPs, the variation in quality based on these steps can be reduced. In red, you see the steps which cannot be influenced and may lead to variation in quality of your samples. So by standardizing as much as possible the other steps, any variation in quality should remain limited to those things that are out. The next thing to be standardized is the long-term storage of the samples. Here you see a number of images that may seem somewhat familiar to you about suboptimal storage conditions. In terms of structure, I always like to show these images of the Lifelines Biobank, where about 150 freezers are carefully organized in a central facility. Of course, this might not be feasible for you, but your university may have such a department already in place. If it is in place, then it's very wise to see whether you can actually place your samples there rather than taking care of the long-term storage yourself. Probably this organization will need to ask you for a financial contribution for the long-term storage, but please consider it seriously because you will be carefree from that point onwards. Last thing to mention then is the much needed IT infrastructure. This is an aspect that actually is also both quite complicated as well as very easy. The easy thing is you need to involve a professional IT expert to make this system operational for you. But that is also the hard thing because experts cost money. Nevertheless, having a solid IT backbone for your biobank is important and downstream will prove its value once people start requesting data and samples from you. The basic purpose of the IT system should be support operations, record clinical data, and record any quality-related data. This is an example of the LIMS system that we use in the Lifelines project. When setting up a system, make sure that you use the required and relevant international standards for data. This will contribute to the FAIR principles and ensure that over time, when you build collaborations based on your biobank, that others will be able to work with your data. Privacy and security are clearly important topics to consider. In terms of privacy, a key principle is to separate the clinical data from the personal identifiable data. In your database, there should be a separate place to record the name, address, hospital number, etc. of the patient, and it should include a patient biobank number. In a completely separate database, make sure that you record all the clinical data with the same patient biobank number. Security is also an important point. If you want people from outside to be able to access the data, then it is a major point to safeguards and to ensure security. But also, if people from your department have access, you should ensure that the access is granted on a need-to-have basis. Also, rights to be able to, for instance, alter data should be strictly limited, and an audit trail should be used in case alterations to the data are made. Final point is the backup and disaster preparedness. If you intend to be a long-term biobank, then one thing is for sure, things will go wrong. It is then your responsibility to plan for it, please. Make sure that you create regular and automated backups and that you are also in the regular practice of recovering these backups to see whether the system still works. So, to conclude, I have explained to you the two types of biobanks and the differences between them. Also, I have discussed some of the ethical, legal, and societal implications of biobanks and have discussed about the key FAIR principles for data and samples. Finally, I have presented some of the operational elements that should be taken into account, such as a quality management system, your long-term storage facilities, and the IT backbone of your operations in order to establish the minimum standards for qualification of a biobank. Last thing to repeat is that biobanks serve one purpose: research. For that, you need researchers to use your biobank. Therefore, a continuous focus should be on finding the users to perform research and generate societal impact. This concludes my presentation for today. I thank you very much for your kind attendance to this session and please enjoy the next speakers. I look forward to meeting you in real life at the next edition of the International Conference and Exhibition on IMERI.
Okay. So thank you very much for a very interesting topic presentation, Dr. Bart Serger. So I think it is important for us or for the participant that will be build the biobank in Indonesia, because I think Indonesia has also a lot of many of samples that maybe can use for so benefit for the researcher to use for research nowadays. So I think this is important topics also for our biobank in Faculty of Medicine Universitas Indonesia. So we proceed to the next speaker for the next topic from the Rafika Indah Paramita. I'm from Apotheker for Faculty of Medicine Universitas Indonesia with presentation about the future of research biobanking based on experience in Faculty Medicine Universitas Indonesia. So I will inform you the short CV from her. So, excuse me, back again, committee to the slides. CV, okay. Rafika Indah Paramita, background education. So, 2017, Master of Pharmacy, Universitas Indonesia, and then 2014, Bachelor of Pharmacy, Universitas Airlangga in Indonesia. So The current position is researcher in bioinformatics core facilities in IMERI, Faculty of Medicine, Universitas Indonesia, and also a lecturer. So I think we provide also the committee provide also the pre-recorded presentation. So please the committee to play the pre-recorded video.
Hi, good afternoon. Core facilities IMERI, Faculty of Medicine in Indonesia. We'll talk about the future of biobanking research and experience with IMERI FMI Biobank. Here's my outline. We'll divide into 3 parts. The first part is about genomic sequencing research using biobank samples. And then the second part is bioinformatics for genomic sequencing research. And last one is biobanking research with IMERI FMI Biobank. Okay, we go to the first part about genomic sequencing research using biobank samples. Biobank is defined as an institutional facility that dedicated to the systematic collection of human biological material to support multiple and future studies. Millions of people generally give their time, blood, and others biological samples, and also the information to biobanks, all with the goal of improving research into human disease. So biobanks will collect information and also the samples. So it's include the collection, storage, usage, and distribution of biological sample for research purposes. So with that collective effort, it produces a staggering amount of complex data. And all of that needs to be quality controlled. So how about the future of biobanking? Nowadays, we already face the era of new biology, especially in genomics era. The future of biobanks in era of the genomics era can lead to encouraging candidates for understanding the more complex mechanism of biodiversity that include physiological and pathological mechanisms that underlie the state of health of human beings. And the use of large quantity of human specimens included blood, saliva, biological tissue and fluids, and also the DNA, and also the data associated with them. So it means the integration of many different skills, such as biological, medical, biochemical, biotechnological, and also bioinformatics. In recent years, we have witnessed an explosion of data in biomedical sciences, thus including medical human research that specifically to determines the order of nucleotides by sequencing. So besides we have clinical data, it can be more useful if we can integrate with genomic data from biobanks. So there is a specific genetic association between genomic data and also clinical data. One of the methods that can be used to have genomic sequencing is with next generation sequencing, or NGS. NGS is one of the advanced techniques that used for screening genetic variants across the entire human genome. With the massive sequencing technique, it would be low cost and also will give a high throughput result. And the impact of these genomic resources can enable research that leads to quicker diagnosis, such as for rare disease for children. And then also in the cancer case, we get targeted cancer treatment and repurposed medicines. And all of them are good for people in society. If we talk about NGS, or next generation sequencing and genome sequencing, we can use a lot of methods. And in this case, we can use, the first one is targeted sequencing. So this targeted sequencing can be used if we already know about the predefined genes. So we don't need to sequence all of the genes and only on particular genes that we want to take a look. And the second one is a whole exome sequencing. This is used to capture all coding exons of the genome, but not in a non-coding part. And the last one is whole genome sequencing, or WGS. Whole genome sequencing is used to sequence the entire genome that is standard for sequencing. So it will give the result for both coding and also non-coding regions. Beside the targeted whole exome sequencing and whole genome sequencing, nowadays we also can use microarrays or SNP arrays that can be used to perform a large-scale GWAS or meta-analysis data across ethnic diverse population. By using these microarrays, it can show about more than 800,000 SNPs, including functional SNPs such as non-synonymous SNPs, HLA region variants, pharmacogenetic markers, and previous disease associated with SNPs. Yeah, if we talk about next generation sequencing that produce huge data, it's impossible if we don't talk about how to handle the data, how to analyze the data. So bioinformatics is one of resources that can be used to handle the genome, that huge genome data. Bioinformatics is defined as the application of tools of computation and analysis to capture and interpret the biological data, include the genomic data. The prospect in the field of bioinformatics is future contribution to functional understanding of the human genome, that leading to enhanced discovery of drug targets and also the precision medicine. Yeah, after we know about bioinformatics, especially the main goal is translational bioinformatics. So we can use proper bioinformatics tools or software or technologies to translate the data from the genomic data to more useful that can be used also in clinical side. And one of the translational bioinformatics is in the precision medicine area, related to biobanks to identify the risk factors of complex disease. And then we can also get potentially proposing medication. And also we can find novel therapeutic targets and also integrating the development of polygenic risk scores with non-clinical risk factors. And if we talk about precision medicines, of course we will get more about pharmacogenomics. Because of a lot of variability in drugs response that has been found to be related to functional change in ADME or absorption, distribution, metabolism, and expression related genes, and also pharmacokinetics and pharmacodynamics related genes or proteins due to inherited inter-individual variation. This inter-individual variation can influence the therapeutic outcomes such as drug efficacy and safety. And if we got the insight about the genetic variation that relate to ADME or PK or PD genes or proteins, it sure can reducing trial and error to patient treatment. So the treatment can be achieved more successfully. Here are some of genomic sequencing research that using biobank samples. The first research is come from Taiwan. They already profile more than 100,000 individuals from Taiwan Biobank and look at the Han Chinese race. So in this research, they did like SNP arrays or microarrays, more than 100,000 individuals from Taiwan Biobank. And they got some information. The first one is about genetic disorder carriers. For a specific genetic disorder, the big three is about G6PD deficiency, citrullinemia type 2, and also Wilson disease. Now, this is for G6PD deficiencies because of there's a mutation or variance in G6PD genes. For citrullinemia type 2, because of the variant in SLC25A13 genes, and for Wilson disease is about variance in ATP7B. And for autosomal dominant disorder, the big three is about the FNA2 non-syndromic hearing loss because of the variant in KCNQ4 gene, and also hereditary pancreatitis because of SPINK1 gene and also PRSS1 genes. And in the third, about the familial hypercholesterolemia because of the variant in ApoB genes and also LDLR genes. Not only about recessive or autosomal dominant carrier, they also get information about the cancer susceptibility genes. In here, we can see that the most or the highest frequency of cancer susceptibility genes is come from CHEK2 and RAD51 genes. So it can make a higher risk for hereditary cancer predisposing syndrome. The second one is because of variants in SMAD4 genes. It can make juvenile polyposis syndrome. And the third one is adenomatous polyposis coli because of the variants from APC genes. And not only variants related to disease, we can also get information about variants related to pharmacogenetic. In this result, we can see that the highest excessive metabolism is in azathioprine drug that related to variant TPMT. So if the clinician that give a prescription with azathioprine, it should be more careful because of the mutation from TPMT. It can make excessive metabolism of azathioprine. The second one is celecoxib. In here, celecoxib is also metabolized faster because of the mutation of variants in CYP2C9. And vice versa with the celecoxib in poor metabolizers, we can see the highest poor metabolizers is warfarin in here because there's a mutation in PCOS1 genes. So you should be careful if a clinician give a warfarin because of the variants in PCOS1. It can make warfarin metabolize slower. Next, second research that use genomic sequencing research using biobank samples is research from UK. They provide using whole exome sequencing from almost 50,000 individuals from UK biobank samples. From this result, they get more than 97% had at least one carrier with LOF variants or loss of function variants. And most genes, more than 69%, had at least 10 carriers with loss of function variants. And also in this study, they found novel LOF variants with large effect on disease traits, including piezo1 genes on varicose veins, COS6A1 genes on corneal resistance, MIPI genes on bone density, and AQ-GAP2 and GMPR genes on blood cell traits. So if we see here in summary statistics for variant sequences exome, they can found more than 4.5 million single located variant because of the method they use. They use whole exome sequencing, so you get more number of variants than the slip arrays. Yeah, this is a novel that associated with disease. And the next research is from Korea. This is Korea Biobank Array projects. So it's same with the Taiwan. They use slip array to provide the Korean cord samples in 2014. The genomic coverage of the Korea Biobank Array is over 95% in common variants with MAF more than 5%, and over 73% in less common variants, or the MAF is about 1 until 5%. Okay, we go to the second part. It's about bioinformatics for genomic sequencing research. As I mentioned before, that if we did a genomic sequencing research, it's impossible to do it manually. So we need a technology to help to handle or to analyze the data. So from the previous study that I mentioned before, there are two kinds of research method that can be used. The first one is about variant calling. So this method is come from targeted sequencing or whole exome sequencing or whole genome sequencing. From the research, we can get the output file from a sequencer or from NGS that was a FASTQ format. So before we further analyze the files, we need to check the quality first. So in the first step, we have a FASTQ quality control. If the FASTQ is fine, we can move to sequence alignment. That if the quality of the FASTQ file is not good or not quite good, we need to pre-processing before we did the sequence alignment. So we can trim or filter first the sequence, and the sequence that had a good base pair can move forward to sequence alignment. In the sequence alignment, we can align the GS output file, that is the FASTQ format, to human genome reference. And after we did the alignment, we can call the variants using some softwares such as GATK or BCF tools. And then after we get the variants, they already called by the variant caller software, we can move to annotation. So this annotation will give the information about the genes, about the kind of variants or kind of mutation, etc. And then the last one is data visualization. So this is one of the example of variant visualization. We can use a little plot that can be made in mutation mapper. Then this is the URL address. We can just submit the position of the variants and then the reference and alternate allele, and also the chromosomes. Not only for variant calling analysis, Biobanking also provide pipeline for SNP array analysis. And here I will show you the software that can be used for analyzing SNP array. The first one is GTC2 VCF pipeline that can access from this URL address, and also for defining the mosaic chromosome, you can use a pipeline from Mocha, and this you can access the software from this URL address. The first one, if we use SNP array, we will get the IDET files, not FASTQ files, so it's different with the previous one. So after we get the IDET files, we need to convert to GTC files. And to convert IDET to GTC, we need the EGT cluster file and BPM or CSV manifest file. And this kind of file we can access from provider website. So after we got GTC files, we can continue to generate VCF file or variant calling files using VCF tools plus GTC2 VCF. After this, if we need the pictures of mosaic chromosomes, we also can use a Mocha pipeline, and they will give us the plot of mosaic chromosomes. And this is the examples of the SNP array result. We can see in chromosome 19 in this position from allele G changed into A. It's already defined in a database with DB SNP ID RS 5928, and also in FinFar database with number 161278. Its variants, the phenotype is familial hypercholesterolemia with significancy is likely pathogenic. So besides we get the information about the variants, we also can get the information about the mosaic of the chromosomes. It's we can get it's normal, loss, or gain. The last part is about our experience in biobanking research with IMERI FMUI Biobank. In this research, we use the samples that from IMERI FMUI Biobank that collected from October of 2014 until October 2017. And here we sequence 16 samples that from breast carcinoma frozen fresh tissue that collected from breast cancer patient with age of 31 until 69 years old. And all of the cancers were invasive carcinoma that varies from grade 1 until 3. And for library preparation, we use DNA purification. We use KM DNA mini kit from Kiagen. And then the sequencing kit, we use Implicit Cancer Hotspot Panel V2 for Illumina. And the sequencer, we use Illumina MySeq. And for the data analysis, we use Supermicro workstation for the hardware. And the software, we use our in-house pipelines for somatic foreign coding. We can find that a lot of pathogenic clinical significance that found from the 16 samples. We can find that the most found pathogenic variants is from PIK3CA genes in this position from allele A to G. And this is the ID of DB-SNP or CLINFER. And the interesting part is variants TP53 genes in this position from G to C that have a clinical significance of the drug response. From 16 samples, it showed positive in 11 carriers. Okay, next, if we visualize it in each genes, we can see here that all of the protein change that happen in this study is also related to therapeutic implications. The interesting part is if there's a patient with mutation in E545K, the FDA already approved for the treatment of the patient with a combination of alpelisib and also estrogen receptor ER antagonist fulvestrant. Next, for FGFR2 genes, there's only one mutation that was missense mutation in here, but there's no known therapeutic implications. And then the last genes, there's TP53 genes. Is we can see here the highest mutation, the highest number of mutation is in P72R. And the P72R is missense mutation that can change drug response. So in here, we can see that P72R is related to drug response that can change efficacy of response from paclitaxel, cyclophosphamide, antidiabetic agent for also and also cisplatin. With this result, research of the genome sequencing to get more precise therapy for the patient with breast cancers. So here we go for the summary. The future of human biobanks in the era of genomics can lead to encouraging scenarios for understanding the more complex mechanism of biodiversity and the physiological or pathological mechanism. The data integration between genomic data from biobank and clinical data can contribute to human health, such as disease diagnosis and treatment, discovery of new drug targets, and also the precision medicine. And if we talk about genomic sequencing, of course, we will need bioinformatics to handle today. So bioinformatics will give advantages of advanced and powerful computational technology that possible for discovery and rapid translational of meaningful clinical and biological outcomes. There are some references that are cited for this presentation. And thank you very much for your attention. If you have any question, you can drop to our email in bioinformatics.imeri@gmail.com or bioinformatics.imeri@ui.ac.id, or just contact us through our WhatsApp number. So thank you very much for your attention. Good afternoon and see you next time. Bye-bye.
Okay, thank you very much for a very interesting presentation, Ibu Rafika. Ibu Rafika also here, I think, yeah, Ibu Rafika, and then you can answer the question if the question is for you, yeah, Ibu Rafika, not to not by email. You answer the question not by email, I think, because you are still here. Okay. Thank you very much for your attendance here, because you are in the last minute for the partition. Yeah. Okay. So yeah, thank you very much for the time and then your willingness to come here. Yeah. Okay. I think. Yeah, the presence of biobanking in medical institution or in hospital that collected sample from the patient with associated clinical information from each patient supported the era of personalized and precision medicine today, I think, yeah, in which genome for the patient should be investigated, yeah, in the future. Combine comprehensive data sample, include clinical information from biobanking, and then also bioinformatic tools play a role on the management of the patient in the future for the diagnostic, treatment, and even for the prevention, yeah, for better health of the human being. Yeah. So I think now we proceed with the last lecture from Mailania Saraswati, medical doctor, specialist pathological anatomy from our faculty. Here I would like to inform you the CV from Dr. Melania Saraswati. So the education background is 2018, yeah, as a anatomic pathology consultant, and then 2017 Master of Medical Education from our university, Universitas Indonesia, and then 2013 Anatomy Pathology Specialist from Universitas Indonesia also, and 2003 as a medical doctor from the University of Indonesia. So and then her current position is a lecturer from pathology anatomy department, yeah, and then medical staff, pathologist consultant, and then also undergraduate education coordinator. So time is yours, Dr. Melania. I think you will present directly live from your.
Yes.
Okay, thank you very much.
Okay, thank you very much, Prof, for the kind introduction. Permission to share my slides. Okay. All right. Thank you for introducing me, Prof, and thank you also for the committee for inviting me in this lovely session. The topic that was given to me was tissue versus liquid biopsy in biobanking. This is probably not a new topic in the world, but for our biobank, liquid biopsy has only been recently introduced into our unit. So the general concept of liquid biopsy is that cells or components of cells are released to blood circulation or bodily fluid, and this includes cancer cells. Cell-free nucleic acid were first actually detected in 1948. Within cell-free nucleic acid, we can find circulating tumor DNA or ctDNA, which comprise about less than 1% of cell-free DNA. However, well, nowadays, we know that biopsy is still the gold standard for cancer profiling. However, there are limitations in clinical practice to obtain and analyze samples from tissue biopsy. So as an alternative, we try to come up with an easier solution, which is liquid biopsy, that becomes the choice to assess tumor progression and treatment response in diseases. ctDNA may originate from apoptotic or necrotic tumor cells from the primary tumor, or live tumor cells from the primary tumor, or circulating metastatic tumor cells. So these are the samples that are usually contained in a biobanking. There are these large group of solid biopsy, which consist of tissues. These tissues can be stored in form of fresh tissues or formalin fixed embedded, paraffin embedded tissues. And then parts from liquid biopsy, which may consist of circulating tumor cells, circulating tumor DNA, cell-free RNA, microRNA, extracellular vesicles, or tumor-educated platelets. In our unit, right now we already have a collection of 349 tissue, which largely consists of ovarian tissue, and then followed by breast tissue. And nowadays, we have collected several types of liquid biopsy. All are scheduled collection, meaning that there are researchers who work together with the biobank to keep their samples in the biobank. There are two ongoing research right now. The first one is on metastatic prostate cancer, in which we store the peripheral mononuclear blood cells in minus 80 degrees Celsius freezer, and also the RNA. And the second research is regarding urinary tract stone that consists of RNA sample from the urine and DNA sample from the blood. So what are the comparison of tissue biopsy and liquid biopsy? For tissue biopsy, we already know that it is the gold standard for cancer genotyping. It is also highly accessible for histological analysis and staging. However, it could be unavailable due to the heterogeneity of the tumor. So sometimes the part that we are obtaining from the patient may not represent the worst part of the disease itself. And it also has longer turnaround time. With liquid biopsy, it usually retains epigenetic characteristic and tumor-specific mutation. However, for histological analysis, it is limited to CTC, and by itself, it doesn't even show the relation between cells. It is easier to obtain with faster turnaround time, and however, there is a low level of tumor-derived product in the body fluid, and there is always a risk of false negative result. Conventional tissue biopsy require invasive procedure, more invasive than liquid biopsy. However, it is more specific per marker tested. We know that such certain marker occur in certain cell tumor that we want to see. And liquid biopsy may not be originated from the cancerous cell. FFPE preserved tissue could present highly variable quality. Some say that the RNA are already fragmented. But in liquid biopsy, it is not modified by preservation. Hence, it takes strict procedure to avoid DNA degradation. In conventional tissue biopsy, DNA quantity are highly variable depending on sampling method. And in liquid biopsy, the quantity and quality of DNA strongly depends on the pre-analytical and analytical process. Conventional tissue biopsy enabled localized analysis, no characterization of intra or intertumor heterogeneity. Meanwhile, in liquid biopsy, it highlights intra and intertumor heterogeneity and multiple tumor sites. And conventional tissue biopsy usually can be obtained only once, hence it is not applicable to serial monitoring. On the other hand, liquid biopsy can be obtained anytime during the course of disease. Hence, it is important to, or it is helpful in monitoring the disease or the treatment given to the patient. That is in clinical setting. So if we do have those samples, what can we do with it? There are several techniques that can be used to examine the samples. For both samples, actually, NGS and PCR-based approach are available. But for tissue, we can do in situ hybridization and immunohistochemistry examination. Those technique cannot be done in liquid biopsy. However, liquid biopsy is becoming more and more popular nowadays because it does offers various opportunities for cancer management. It provides molecular stratification, identify resistance mutation, and monitor tumor response in a fast and minimally invasive manner. Up to 2020, there are already 2 liquid biopsy-based assay that are FDA approved, which is EGFR mutation test by COBAS, and also epiprocolon. Hence, for I think EGFR mutation is more popular in lung. So for lung cancer and colorectal cancer, perhaps the application of liquid biopsy in the clinical setting is already enabled. Sample collection and storage. I think we know how tissue biopsy are obtained and processed. So most of the discussion will be heavily on liquid biopsy. So we obtain liquid biopsy usually from the peripheral blood, sometimes from other bodily fluid. For example, in our unit, we have one from the urine. From the blood, from the plasma, we can obtain circulating tumor cells and also circulating tumor DNA in the collection of cell-free DNA. Circulating tumor cells are usually obtained by removing all the erythrocyte and then removing all bone marrow-derived cells, and then taking out the tumor cells that are in the circulation using specific marker to such tumor cells. For example, if it's a carcinoma, we usually use CD326 or EpCAM to take all the cells, epithelial cells within the peripheral blood mononuclear cell. And then for cell tumor DNA, they usually have a certain kit that tracks ctDNA from plasma, and from that we can run to NGS, next generation sequencing or RT-PCR for further analysis of mutation, DNA methylation, copy number alteration, or in fact gene fusion. This is an example of how the sample collection and processing from a liquid biopsy. So serum and plasma is preferable, and then they are isolated, and then they can be stored first in room temperature or 4 degrees Celsius, depending on temperature that we can obtain the sample and then store it in minus 80 degrees Celsius until further use. Up until now, there is yet standardization for liquid biopsy handling. The easiest way probably use container tube with EDTA preservation. This we can store in 4 degrees Celsius regular refrigerator, and then can be used within 6 hours. However, nowadays there are commercially designed collection tube for cfDNA, and it may be stored in room temperature for about 3 to 7 days. The National Cancer Institute of the United States, however, recommend shorter duration for room temperature. For example, for EDTA, only 2 to 4 hours, and in preservative tubes, up to 3 days. Post-analytical, depending on the standard operating procedure in the laboratory, but in our sample, we keep the RNA in minus 80 degrees Celsius, cDNA in minus 20 degrees Celsius, and TMBC in minus 80 degrees Celsius. Or it can also be stored in liquid nitrogen. So these are the advantages and disadvantages of CTC in comparison to circulating tumor DNA. CTC, both samples are well validated, and the technologies are reproducible. Diagnostics in colorectal cancer. It might predict early relapse after primary treatment, and it is also a live cell, so it has broad potential utilities. For example, for culturing, xenografting, and then testing drug sensitivity in vivo. However, it is not predictive for a therapeutic benefit in metastatic setting. There is uncertain clinical utility in the setting of micrometastatic disease following curative intent primary treatment. It is also undetectable in most patients with early stage cancer and in many with advanced stage cancer. Usually provides quantitative rather than qualitative or functional information. ctDNA is highly sensitive and also highly visible, and it is correlated with clinical outcomes in the adjuvant treatment and metastatic disease setting. It can also provide composite information on the molecular biology of multiple metastases in an individual patient. It can reveal drivers of therapeutic resistance, for example, EGFR mutation in non-small cell lung cancer. And then it also it has demonstrable association of genetic alteration with therapeutic benefit. For example, alpelisib therapy in PIK3CA mutated ER-positive breast cancer. However, it is also undetectable in many patients with early stage and some with advanced stage cancer. Not all detectable mutations are relevant to cancer biology and or therapy. It might not provide actionable information, for example, when only non-druggable genetic alteration are detected. Impaired detectability of low-frequency aberration, and there is also background noise due to non-neoplastic age-dependent clonal expansion. Clinical utility. There are several clinical applications that can be used for liquid biopsy, for example, for early cancer detection, and then surveillance of for micrometastatic disease, and also treatment selection and response and monitoring in patients with metastatic disease. This is an example of how liquid biopsy is implemented into clinical setting. So we can always draw blood from the patient for cfDNA analysis, and then this will enable us to detect any certain mutation that occur post tissue biopsy. This is also an example of liquid biopsy utility to monitor therapy and response and resistance. And here's also another example. But if we obtain CTC, then we can always do a culture and then have a more extensive study with CTC. Liquid biopsy can also play a role in pediatric cancer, because in pediatric cancer, usually the treatments are more intense and prolonged, and liquid biopsy is needed to monitor treatment response. Here is also the workflow, how the blood sample is collected, and then we perform analytical process, obtaining the CTC and cfDNA, and then this also can be stored for biobanking, and perhaps in the future when the patient is still alive, we can always look back and then test again for newer treatment, or if it's for the biobanking for treatment purposes. There are some limitations and advantages in liquid biopsy in pediatric cancer. The limitations are, it is not easy to achieve optimal condition for sampling processing, and the tubes used on the processing may compromise the molecular assay, and as a consequences, they limit the potential of CTC to enumeration and then immunotyping. The advantages, the results for detecting ctDNA in about 50% of patients are promising. And risk stratification and cancer monitoring can be helpful for the precision of treatment. It's not, we can't always integrate liquid biopsy into clinical practice. There are steps that must be followed. These are the steps that need to be ensured in order to incorporate liquid biopsy to daily practice. The first is development and of assay to ensure analytical validity, establish clinical validity, and then demonstrate clinical utility. And then we will need regulatory approval, incorporation into guidelines, and also what about the situation with third party, with incorporation into the clinical workflow. We need to invest in the laboratory and human resources, train physician in application to the test and interpretation of the finding, and then create a standard operating procedure for application in different clinical scenarios. Conventional tissue biopsy. This is an example of research regarding an EGFR mutation. Here we see that the A part is tissue biopsy and the B part is liquid biopsy. It is quite in line. However, peripheral liquid biopsy apparently have better specificity for detecting EGFR mutation in NSCLC patient. But with regards of PFS and OS, there is still a lack of evidence which one is better. This is an example of comparison of cfDNA and tumor biopsy in gastrointestinal cancer. Apparently, cfDNA has a better sensitivity in detecting alteration in the patient in comparison to one time sampling of tumor biopsy. And we know this is probably due to the heterogeneity of the tumor itself. This is also research trying to compare the sensitivity of liquid biopsy in comparison to tumor biopsy sample. And apparently there is concordant rate of all mutation detected in tissue sample or liquid biopsy or both. And the sensitivity of liquid biopsy in comparison to conventional biopsy is about 70%. I think last but not least, this is analysis of whole exome sequencing. The pooled sensitivity analysis detected a single nucleotide variants in cfDNA versus tumor tissue. The sensitivity is only 0.5. Another example showing that mutation detected in the tissue DNA, cell-free DNA, or CTC DNA also showing a different result. So the concordance of liquid to tissue biopsy is still varied, and some mutation may appear in tissue biopsy but not in liquid biopsy, and vice versa. Some studies show that liquid biopsy may show better sensitivity in clinically important mutation. I think for the summary, liquid biopsy provides new ways to detect, monitor, and research in cancer. However, tissue biopsy remains gold standard for cancer genotyping, albeit more difficult to procure. Concordance level of tissue and liquid biopsy is still varied, and its clinical implications still requires further investigation. There are more areas to be researched. Liquid biopsy and biobanking collection will provide more opportunity for researcher. And from technical point of view, pre-analytical process remain an issue to maintain sample integrity, and this needs to be standardized. I think this is all my presentation. I thank you very much for your kind attention. Thank you for Research Biobank IMERI FKUI and Oncology Urology Research Team, and also Dr. Mutiadia who had helped me for this presentation. Thank you very much. I will take any question from the audience.
Okay, thank you very much for a very interesting topic presentation from directly experience, experience directly from your research, Dr. Nia. So, it's nice, nice topic. Okay, so the biobanking that support medical care institution, especially for cancer patient management, like our faculty nowadays, they collect mainly the tissue from the patient, but there are limitations in clinical practice to obtain and analyze sample from the tissue biopsy as a gold standard for cancer profiling. So as an alternative, liquid biopsy has become a choice to access the tumor, like circulating cell tumor or cell-free DNA that present in the blood, And from Dr. Nia experience, we have successful got the material from liquid biopsy, and then this sample can be applied for the management of the patient, It is the important thing for the Dr. Nia presentation today. Now, we proceed to the discussion, question and answer. So we have time until 16, So that's true, the committee? So there are no limitation at the time for discussion. I don't know. So I think, okay, I begins with the question from, here the committee has sent me the questions, several questions for the speaker. The first question come from the participant Amalia Turosida to the Dr. Bart. Yeah. For the first question, in the case of tumor from the organ that have left and the right side, sometimes the surgeon have to take both of them, right and the left, in order to avoid the spreading, etc. If the tumor is only in the right side, how should the biobank manage the samples? Do they keep both normal and tumor samples in one set compartment, or should they separate it with notes that the left one is normal tissue or organ? So this is the question, a little bit technically application from this biobanking collection of the sample. So please, Dr. Bart.
Yes, thank you for the question. And it's always interesting to find what is picked up by the audience and the questions that come forward. So I would basically answer that it is very much dependent on the purpose or the goal of your biobank collection itself, and also the resources that you have. If you are able to store potentially less relevant samples, then this will spark perhaps other types of research questions in the future if you are able to store it. However, the chances are not very high, of course. So I personally would think that probably the less relevant sample could be discarded. But it really depends on the purpose of your biobank and the resources that you have to store such samples.
Okay, thank you for the question, Dr. Bart. There is also second question here from the Amalia Turosida. If a researcher intended to use the sample from the biobank, is it possible or allowed to ask the specific volume of the samples in order to fulfill the experiment that she or he conducted? Do you understand what I give you the question? If the researcher intended to use the sample from biobank, is it possible allowed to ask specific volume of the sample in order to fulfill the experiment that she or he conducted? Can we ask about the volume of the sample regarding the collection of the sample?
Was the question directed at me? I'm not certain.
The question for the Dr. Bart.
Okay. That I missed. I apologize.
Okay.
All right. So yeah, I think if you have a proper informed consent in place and you have ethics clearance for your collection, then asking for the volume, I think, is not a problem at all. Maybe there's a secondary question there that, especially for secondary use collections, are you permitted to take a bit more volume than medically needed, for instance? And then we run into problems because, of course, you are collecting a sample that is a primary purpose is medical purpose. Then your research interests cannot have any influence on the sampling procedure that you are doing because you are doing it for a medical purpose. So if that is an underlying question, then please note that if you are doing a de novo biobank, you are collecting for research purposes only, then if you have a good consent, if you have ethics clearance, then you can collect the type of sample that you need. But if it's for a secondary use, residual tissue type of collection, then you have, of course, limitations to what you can do.
Mm-hmm. Okay, thank you. Here, yeah.
if I may chip in, regarding the sample collection, I agree that it depends on what the researcher wants. So if they want to have the cancerous part and then also the benign or the non-neoplastic area within the same organ, then we will collect that. Or some researcher would want to have disease part from the patient and then a normal control from another patient. But if we collected, it's not a scheduled collection, so it's a de novo collection. We usually just take the diseased part. And then as for the volume, as long as we already have an understanding with the researcher and we agreed upon the research that's being conducted and we agreed to give the sample, we will of course inform the volume. However, I think as a rule we would want to ask the researcher to use as little as possible in order to preserve more for future research. Thank you.
Okay, thank you, Dr. Nia, for the additional information from your experience, I think. So I think, we proceed to the next question here about actually there is also a question about this attempt that intended to use the sample from biobank. I think the answer is already given by Dr. Brad and Melania, but here is more about the organization of the biobank. So what is the most? It's also a question for Dr. Bart. What is the most significant criterion for the identifying whether the biobank is growing and can continue to do so?
That's really dependent on a lot of factors, I think. But let me give some feedback on that. I think the many biobanks struggle with sustainability, long-term sustainability, in particular for financial reasons. Of course, we're always looking for funding. It's the biggest problem of any research group in our lives. But if you are able to provide significant contributions to relevant medical research, and you are able to prove that, then typically sustainability becomes less and less of a problem, because you are proving your added value to the research domain. Then typically you will find that getting new funding, for instance, might be easier for you than if you do not contribute. So the sustainability element could also be translated to whether or not your biobank should be permitted to continue, should be permitted to grow. If you are sustainable, I think you are providing your own evidence that you should be allowed to continue and grow as a biobank. I think that would be my sort of impression about this.
Okay, thank you for the answer, Dr. Bhatt. So I would like also ask you about, also related in this question from the participant, about you have already explained that there are many minimum standard requirement for the biobanking. So what is is there any limitation of the human resources, for example, to run the biobanking or for good biobanking? I think because there are so many jobs or so many tasks for the person that involved in this biobanking organization. Is there any special human resources criteria, or how many person it should be present to run the biobanking, for example?
Yeah. Well, I'm not sure whether there should be any limitation, but I think there has to be proper attention to education, training, and knowledge within the colleagues that are active in the biobank. I visited Jakarta, the Universitas Indonesia Biobank, been very impressed there because there are professionals involved that have the relevant knowledge and expertise to properly operate a biobank. And that is a key difference, I think. So in terms of limitations, I don't think there should be any. It really depends on the size of your collection, the number of people that should be involved. But there should always be a clear focus on education, knowledge, professional knowledge about the relevant domain. And that sometimes is overlooked because everybody might have the impression that people have a long track record, for instance, and probably know everything and all about it. But the field progresses. I think we had a very interesting contribution also from Dr. Saraswati. You see that you can't keep looking at the past. You have to look forward and see what is developing and how to integrate that into your biobank. So I think that is the biggest requirement. So not a limitation, but a requirement to work with trained, professional, educated staff.
Okay. Yeah. Thank you very much for your answer.
If I may, Prof.
Yeah.
If I may add.
Yeah. Okay.
I think,
please.
I think one of the key factor also in sustaining a biobanking is the support from the institution where the biobanking lies.
Of course.
Yes, I think so. And if a lot of people understand the importance of biobanking and how biobank can become the foundation of high quality research, then I'm sure that we can always sustain our institution, our unit. I think. Yeah.
Okay, thank you for your addition, Dr. Nia. So here, actually, there are many questions more here, but the time is up, I think. Yeah, but what do you think? We continue the discussion or we stop here? Yeah, I think one question or two questions more. Then all of the question, I think, is directly to Dr. Bart here. So this is also important thing, the important question. I mean, so from the Dr. Endang, yeah, Dr. Bart, there are many ways to classify the type of the biobank. Do you think there will be impact on the operational LC and regulation based on the type of the biobank?
Very nice to see Dr. Endang in the chat. Thank you for the question, and look forward to meeting you in person again in the near future. Yes, of course, there has to be an impact on the LC considerations dependent on the type of biobank that you have. And if we put it into extremes, sometimes it becomes the most clear, the difference. So, for instance, if you look at a secondary use sample-based biobank and you look at the interaction with industry, then the secondary use sometimes is considered appropriate. However, in the public-private partnership, so the collaboration with industry, then it becomes more difficult. And there you see that if you have a secondary use biobank, collaboration with industry will be evaluated very critically by your ethics board. It can perhaps be done, but the requirements will be much different. Whereas if you have a de novo biobank, you have informed your participants about the intention to work with colleagues from academic institutions, but also colleagues from private industry, then it has a very different application. So I think those all come into the sort of the balance that we have to find when we are evaluating the LC aspects of our organization. And Dr. Endang also asked about operational and regulatory. I think that they all go hand in hand in the same evaluation. So in brief, that would be my response to that. Of course, I think, in all honesty, the question really warrants sort of a 60-minute discussion itself, because there are very interesting elements when it comes to the biobanking domain.
Okay, thank you for the answer, also for all here, the participant. So I think time is up. So before I close this session, I would like to resume this workshop today. So from the BART presentation, Dr. BART presentation, so there are two types of biobanking based on the purpose. So for the primary purpose medical care, or for scientific only. And then what is needed for the biobanking institution, so ethic clearance, fair data, fair is fundable, accessible, interoperable, and then reusable thing, yeah. And then government structure, quality management system, IT system, storage facilities, and preferably the users, yeah, the user of so and then from the Dr. Rafika presentation, I would like to resume that the bioinformatic also important thing, yeah, to be investigated, yeah, combined with the samples that collected from biobanks. So in this era of personalized medicine, I think this good sample and also the clinical data from the patient and combined with the bioinformatic tools, I think is supported so significant for the management of the patient in the future, I think. So, and then from Dr. Nia presentation, I think the tissue is before is mainly material for our collection. So now we can also collect it, collect also this liquid biopsy that has also that contain also the material that can be used for the research, especially in this biotechnology or biomedicine research. Yeah, then it's so significant benefit for the patient in the future also. So I think I close this workshop, and then for the participant, also distinguished speaker, yeah, I would like to thank on behalf of the committee for the nice presentation. Yeah, we have gotten so many knowledge, information about the biobank, especially from the Dr. Bart Sridhar that has experience, yeah, in to manage the biobank in Netherlands. Yeah. Okay. Thank you for the attention and also for the nice meeting today and then discussion also. Thank you very much, and I would like to give back this session to the committee.